Good day, everyone. This is the Concept Academy, USMLE Step 2 webinar on gastrointestinal system. Just as we used to say, we are not in any way trying to proclaim ourselves as the expert in the field. We are not, even closer to that. We have so many experts amongst us here. So our intent is basically to show you a simple way or simple ways of looking at USMLE Step 2 GI, and we don't want you to misinterpret our intent. So we are not in any way better than you. So just accept this as a very simple gift from us. If at all we make any mistake, we do not say it the way you expect us to say it. Don't look down on us or judge us. All right. So we want you basically to sit back very well, relax, get yourself a cup of coffee or tea. So while you imbibe the important concepts that they are going to be testing in the exam, and by the time we are done, you will know that today is a day well spent. All right, so let's start. So, as we used to say, the best material for your preparation still remain the first aid, basically. So it's not that maybe they are paying they are paying us to advocate for them, but it's just the bitter truth. Why? It is a book that you can easily flip over. There are few systems in the step 2 that are quite bulky. Gastrointestinal system is actually one of them. Another one is neuro, another one is cardio, and another one is pediatrics. The others are not that plenty. All right, if you look at my screen here, you can see 95 pages. So one, we can't finish the whole 95 pages today, but whatsoever we do today, it will worth it. All right, so we're going to go in this order: oral and salivary gland disease. What are they going to be testing? Basically just simple stuff. We are not here to be moving unnecessary jargons or stuff for us, so we just put it in a way that you could possibly understand and think about. Then from there we'll go to esophageal disease, and like that. So this is oral and salivary gland disease. The first aspect here is the oral lesions. Here, before I start fully, we are not going to be solving questions. So we are not solving questions, but just to give you the point. By God's grace, I will still make the announcement later then. By God's grace, we are reconsidering going through the whole step 2 by January. So, but the flyer for that is going to come out. So we'll sit down and flip through everything, and it's going to just be like 3 to 4 months program. So, but in that kind of program, it's a training, like it's a thorough training, because every single thing we show you, you solve questions on them. Like you will be like, okay, this is oral cavity. These are the points. Now attempt this question. You move again. Okay, this is the oral hairy leukoplakia. How are they going to be testing this? Now, the good thing about that kind of approach is that it gives you this foundational knowledge to be able to think independently, and also to be able to put together all the concepts you've ever learned in step 1, and whatsoever concept you are learning in step 2, you just start practicing questions along with them. For those that just finished this recently concluded step 1 rapid review pro with us, they know that it was not ordinary. So it was very eye opening, and it's worth it. like it's what it. They themselves could testify that they learned a lot, like a lot, not just about USMLE, because USMLE will become child's play when you understand the concept in medicine. And this is not stuff. Even those that have left school for a long, quite some time, some years, or everyone could relate. So, and that's one good thing about the Concept Academy. All right, so I think that program is going to start by God's grace by January. The flyer for it is going to be out for anyone that is interested. So we are not in any way coercing anybody to do that kind of program. Initially, we were thinking of doing it or starting it by February, but February will be too long, so that people can easily write their step 2 latest by May. They are already writing their step 2 by May, and if at all they want to match, they can quickly apply for matching while they are preparing for their step 3. All right, so just the flyer for that will be out. Just be relaxed, stay tuned. We don't need everybody to subscribe to it. It's not compulsory. Even with just 3 or 2 or 4 people, we are okay. Like, just sit down, let's go through medicine in a highly simplified way. So let's go. So this is oral lesions. So let's see what USMLE want us to take into the exam. There is a concept of we call these guys benign oral lesions. There is a concept of recurrent after stomatitis. It's just a grammar. They are just blowing grammar. Anyways, so after stomatitis. Now, the thing is that they are most likely going to give this diagram in the exam. Most likely. Now, that's how it's most likely going to come. I didn't say definitely. So they will give this diagram. They will now show this lesion here. So the lesion they are going to show, you realize that it is well demarcated. And that lesion is only going to be found on the mucosa. The lesion is only going to be found on the mucosa here. Just the mucosa. Can you see? So they will put something else in the question, that this lesion is quite recurrent. The lesion is quite recurrent. So when you see them say that this patient has been having this recurrent lesion, now show the diagram, you are dealing with recurrent after stomatitis. Now, anyone can have it. Like, anyone can actually have it. So it's not that maybe you can say that this is the cause to it. Basically, it's painful, it's shallow, it's well demarcated, and if at all you check whatsoever they are going to put, the diagram very well, you are most likely going to see yellow exudate in it. That's how it has been. That's how it will continue to be. But they will put that it's recurrent in the question. It must be there. Now, because you don't know what is causing it, like there are some differentials that you can just put at the back of your mind and be like, hope it's not this, hope it's not this, hope it's not that. And what are those differentials? So it might be, maybe we are dealing with inflammatory bowel disease. Maybe we are dealing with celiac disease. Maybe we are dealing with SLE. You don't need to cram any of this. So most time it's just going to be for you to diagnose it, and that's that. Can you see? Nothing to cram, nothing to. You just give just see it well demarcated, only on the mucosa. That's where you will see it. Just be like, and they will put recurrent there. They will tell you this is the 2nd or 3rd or 4th episode that the patient has been having, or the patient had it before. You can even reason it out without even reading anything about it. All right. So if at all they test that, how do you want to treat this? So topical corticosteroid will help. So then systemic immunomodulator, depending on whatsoever condition that is actually causing it. But this is the only place the patient will have it. Now, let me paint the picture better for you. There are so many times that you've experienced one lesion inside the mouth, like ulcer. You were not having diarrhea, you were not having any other symptom, just in the mouth, just one, just going to be there. So once you see that kind of question, you will be thinking towards recurrent aphthous stomatitis. Now, if you now look at the question, you are seeing that lesion, then you are also seeing some other symptoms in the patient that are in keeping with any other pathology, then that pathology is likely to be the cause of it. So, and these are just the differentials. Maybe you are dealing with inflammatory bowel disease, celiac disease, systemic lupus erythematosus. And you see, easy and straightforward. Just be relating it. So what about so don't attach stuff to it, because if you attach stuff to all these things, you will be looking at it in a complex way. Whereas when you start seeing patients, you need to look at those patients in a very simple way that will make sense. All right. What of torus palatinus? Torus palatinus. All right. The thing about the torus palatinus is that it's actually a benign lesion, asymptomatic, bony overgrowth. Now, the thing about it is that it should be found on the midline. Can you see? It should be found on the midline. And in the exam, they may just give this diagram. They now show you one bony overgrowth. And your duty is just to check, is it on the midline? Is it deviated? Is it on one side or more on one side and the likes? All right. So if it's on the midline, you just reassure the patient there is nothing to do. Just your answer is going to be reassure. It's asymptomatic, it's on the midline, you don't need to do anything. So because it's just a benign and it's not giving the patient any symptom, just a benign lesion. That's torus palatinus. Now, the next question you are expecting is, what of if it's not on the midline? So if it's not on the midline, then it's likely you are dealing with another thing entirely. So that's that. So that lesion that is looking like it, that is not on the midline, need to be biopsy. So you now need to biopsy, because for all you can, you may be dealing with a cancer. All right, can you see? When do you biopsy? That's why I just put it there. When do you biopsy? So very easy. Another thing again is that if the patient is symptomatic, then you may also need to biopsy. All right, so note when you need to biopsy. If the patient is symptomatic, and symptomatic in the sense that it's rapidly growing and it's giving the patient a lot of discomfort and the likes, or he's no more on the midline. Can you see? So that's torus palatinus. You see it on the hard palate. Now, this is just the diagram, which is most likely going to be given to help. But if I thought they do not give the diagram, what you will see that you put in question is going to be there is a bony growth on the hard palate covered with what do you call it, fleshy distal or tissue or something like that. You shall give it. The patient is not having any symptoms, nothing and the likes. What is the best next step? Best next step will be, they will have described it that it's on the midline. Just say reassurance. Can you see? Nothing. So now, what is complex on this thing now? You can sit down and revise this within 1 to 2 minutes. If the patient is having significant discomfort, don't forget, you need to treat. What's the treatment? Surgical excision. And that's that. Then we come down to what we call oral leukoplakia. I know that everybody here has heard about the word oral leukoplakia before. We have oral leukoplakia. So they are just whitish lesion that you see in the mouth. So that's leuko. We also have erythroplakia. They are reddish in color. So both oral leukoplakia and erythroplakia, they are actually pre-malignant. That's the question number 1. So oral leukoplakia and erythroplakia, they are pre-malignant. All right, so they are pre-malignant lesion. So definitely they are most likely to give birth to a particular cancer. Can you see? Very easy and straightforward. There is now one that is quite confusing that they are going to give. So they can give it in a very logical way, or they give a diagram. All right. You call it oral hairy leukoplakia. Can you see? It's quite different from oral leukoplakia. This is hairy leukoplakia. Now, for the oral hairy leukoplakia, the first point under it that you want to take into the exam is that it is a manifestation of Epstein-Barr virus. In which patient or which set of patients? Immunocompromised patients. So you can see this in HIV patients. You can see it in anyone. So just immunocompromised. It might even be someone that recently had maybe a transplant that is on steroid or some immunomodulators that you are going to see. Just remember immunocompromised patient. So when you read that question and you are saying immunocompromised state in that question, they now give you a tongue. They are just showing the diagram. So before you rush and be shouting, oral leukoplakia, just ask yourself that, hope I'm not dealing with oral hairy leukoplakia. So where are you going to see it? Lateral portion of the tongue. So lateral portion of the tongue, and the way it's going to appear is going to appear feathery or hairy. So it's going to look hairy. It's going to look feathery. Then it's painless. Then you cannot scrape it off. And the fact that you cannot scrape it off is making it to look like the other leukoplakia, the oral leukoplakia and the likes. So if you can scrape it off, you won't be thinking towards hairy. So in the exam, all you need to check is this patient immunocompromised? Can it be scraped off? Because if it can be scraped off, you will be thinking towards something that look like candida. If it cannot be scraped off, you will be thinking towards oral hairy leukoplakia. So can you see? Very easy and straightforward. Is there any malignancy potential in this patient? No. It's just telling you that the patient is immunocompromised. Now, let me set a question here. They show a diagram, or the question just said that oral hairy leukoplakia, blah, 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 blah. No, nothing else. And that's what is the best next step. The best next step will be go and check the patient for HIV. Just say HIV test. So you'll be like, why should I pick HIV test? You go for HIV test because that's the commonest immunocompromised state that you can see, that you can link with the patient. So something like that. So can you see oral hairy leukoplakia? All right. Which part of the tongue is it going to affect? Lateral portion. So lateral portion of the tongue. So they will show something like this. Can you see? So sorry, sometimes I flip through the net to show you some beautiful picture so that you have an idea of how the picture will be given in the exam. Oral hairy leukoplakia on the tongue. So something like this. So can you see? You just see it look feathery in a way. All right, so that's just by the way. Let's continue. So no malignancy potential, don't forget that. Now if we go back to the oral leukoplakia now, what are the risk factors for that? Any risk factor for malignancy in the oral cavity? So tobacco, can you see? Tobacco, alcohol, HPV. So never forget this tobacco. Tobacco, like, note it very well, is highly tested in the exam. All right. The risk factor for transformation to squamous cell carcinoma. So if the oral leukoplakia you are seeing is non-homogeneous, is large, you see it in multiple anatomic sites. You are seeing it on the tongue, you are seeing it around the tongue, you are seeing it on the floor, you are seeing everywhere. So then the the risk of transformation to squamous cell carcinoma will be very high. All right. So where do you normally see iris location? Lateral tongue. They will give you to you in the exam, so no one will ask it. Let us meet our mics, please. Okay, Dr. Ikweme. Dr. Ikweme, sorry, let me just be landing so that I do not lose my line of thought. Yeah, so sorry, because I need to think to talk. All right, so lateral. So these are the high risk location where you are going to see the oral leukoplakia. Is it the lateral part of the tongue, the floor of the tongue? Floor is not part of what you consider for the oral hearing. So you just talk about the lateral portion of the tongue. All right, so the next question you are asking when they give you the diagram of the tongue, you just see something like this in the exam. Can you see? This is even more or less around the floor of the tongue. Can you see it? All right, so this is more or less around the floor of the tongue. You see, this is more or less around the side. So this is the leukoplakia. Can you see? This is the erythroplakia. You can see some reddish lesion in it. So this will be erythro. Both of them have pre-malignant lesions. All right. The question they are going to ask next is, what's the best next step for this? Best next step. Best next step. So the best next step for it is going to be, sorry, 1 minute. The best next step is going to be biopsy. You just go for biopsy. So that's the answer. Biopsy. So this is your answer. Biopsy. That's all. They won't ask about what are you going to see? Hyperkeratosis, atrophy. No. No one will ask all this. Very simple question they will ask. They will just show you the diagram. You just look at it that I'm seeing it on the lateral. I'm also seeing it on the floor of the tongue. And it's whitish throughout. This is most likely oral leukoplakia. And that's what's the best next step. The answer is biopsy. That's all. That's all. Then the next question they may also ask is risk factor. The answer is tobacco. So if you check the option and you do not see tobacco there, so your answer may be human papilloma virus. Now, if they put two of them there, human papilloma virus and tobacco, you may need to check the patient very well. Is this patient taking tobacco? Is this patient someone that engages in oral sex? All right, so you need to be very careful so that you will not the question already said that the patient does not use tobacco, in either smoke cigarette nor ingest alcohol, and you are going for tobacco, and no, that would be wrong. So the answer in that kind of question would be human papilloma. So your duty is to check what is the risk factor in this patient. Means these three. The question you might have seen before might be talking about tobacco. In the exam, the question might actually be about human papilloma virus. All right, can you see the two possible questions you are expecting here? Can you see this and this? And the diagram for you to diagnose it. Dr. Ikweme, you wanted to say something?
Yes, sir.
Okay, sir.
You made mention that there is no malignancy potential
In which one?
in oral hair leukoplakia.
Yeah, there is no malignancy potential there.
Okay, now in this risk factor for I don't understand the risk factor of which illness is this one you are actually referring to.
This is actually about the oral leukoplakia. Can you see? Not airy.
Okay.
Airy is not there.
Okay.
Exactly.
Okay. Thank you.
Lovely. Well done, sir. So that's how you'll be. Do you get it now, Dr. Ekweme, very well? So the way you'll be looking at this in the exam.
Yes.
Lovely. So the next one is oral candidiasis. Can you see? Oral candidiasis. Oral candidiasis. The thing about the oral candidiasis is that they will also show the tongue, and you see a whitish lesion on the tongue. Do you get it? And the question will definitely put something there that it can be scraped. Once you see it can be scraped, just know you are most likely dealing with oral candidiasis. Can you see? Oral candidiasis. It can be scraped. Most likely I'm dealing with oral candidiasis. So it's not difficult at all. Don't forget about story. So it can be scraped. They will say it can be. All the others we've mentioned, all those oral leukoplakia, hairy leukoplakia, you can't scrape them. All right. So the next thing that we're also going to be looking at later is how do you want to treat oral candidiasis? Because you've read the question, they say it can be scraped. So what's now the best next step? It's for you to give the patient a drug. So the drug will now be, the first line you'll be looking for in the exam is topical antifungal drug. Topical, 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 topical. That's your first line you are thinking about. Unless the question says that the patient is maybe having some moderate to severe symptoms. Maybe the patient is now having issue, a lot of discomfort. Like when you read the question, you know that this is quite serious. So if it's just something mild that is just there, the patient might not even know that he or she has it. So in that kind of regard, your answer will be topical antifungal. So which one do you want to go for? Either clotrimazole, miconazole, or nystatin. I think they test nystatin a lot. All right, can you see nystatin? Just ask your friend. Alright, let's rehearse the oral lesion. You see a whitish that can be scraped. What you'll be thinking about is oral candidiasis. It cannot be scraped. The next thing that friend will be like, where do you now see? Is it on the lateral part of the tongue or lateral part of the tongue, around the tongue, with the floor of the tongue? It'll be like lateral part of the tongue. You say that, okay, that is most likely to be oral hairy leukoplakia. Okay, everywhere, that is most likely to be oral leukoplakia. All right, very easy, straightforward. So what is the treatment for the oral leukoplakia? Let's go back to leukoplakia again. So what is the treatment for it? The treatment for it, because there is a malignancy potential in it, is actually surgical excision. Can you see? Surgical excision. If surgical, in fact, that's the main treatment option that you want to consider for the patient. Do you get it? We also have, if you realize that when you excise it, you also think about it. When you excise it, you are most likely going to remove a larger percentage of that patient, maybe tongue or wherever the lesion is. So in that regard, you go for risk factor modification. Because the patient has so many things. Are you going to remove the whole tongue, or the patient will be tongueless? So in that regard, you just be like, you go for risk factor modification, because amidst the option you will see surgical excision option A, option B, risk factor modification. Can you see? They will just put it option A, option B. You now go back to the question. If it's just small, you can excise it. If it's very big, you can't. It's not advisable to excise that. So that will involve the risk factor modification. All right, so that's just how you'll be looking at this. Can you see? So the other treatment option that you have is just the structural medical treatment and the lab. These are the main questions you are expecting: surgical excision or risk factor modification. Realize that you will never regret it. What about the erythroplakia? Just like oral leukoplakia. So these ones, they have some reddish lesion in them. So where do you see it? Commonly located on the floor of the mouth. You see it on the floor of the mouth, the ventral tongue, or the soft part. You can see them everywhere anyway. So please just note that. Then whatsoever you want to use to explain it, you can. You don't have any other thing to use to explain. Just like the oral leukoplakia. But let's meet our mics. All right. What about the risk factor? Tobacco. So what is the treatment you want to give to the patient? But before the treatment, how do you want to make the diagnosis? Biopsy, just like leukoplakia. All right, so please never forget this. The treatment is just similar to that of the leukoplakia, and that's all. So oral lesion, leukoplakia, erythroplakia, oral hairy leukoplakia, oral candidiasis. Very easy and straightforward. So what about the oral submucosal fibrosis? This is another concept they may test in the exam. So oral submucosal fibrosis, where you are aware of fibrosis. So what this patient is going to basically be mentioning or complaining about is burning sensation, ulceration, and pain in the oral mucosa. Everywhere. Like, so what's the risk factor? They test this risk factor in the exam, and that is chewing areca nut. So, which including the betel quid. Just look at this betel. You can look at it as betel products. Bethel products. So Arakanot, Bethel products. All right. So how do you want to make the diagnosis? The same thing, biopsy. Just say, what's the best next step? Biopsy. So what's the treatment? The treatment they are going to test in the exam is this. Is what they are going to test. There is no any other one they will test. This is the only one they will test. Discontinue the Bethel. Once the Bethel product is discontinued, the patient should be feeling better. Is there any malignant potential in this patient? Yes. Can you see? Very easy and straightforward. All right. Then, so if you look at it, you don't have much. You can even think about them and close your eyes. If I say all of you should close your eyes now and imagine everything I've talked about, you realize that you can easily reason them out. All right. When we are doing our program, you will see I will be giving you a lot of exercise. Or you pick a sheet of paper, write the list of those oral lesions and what give them out. Okay, for the oral hearing, okay, lateral, it cannot be scraped off. For the candida, it can be scraped off. The other, you can see them everywhere. What's the best next step? Biopsy for this. What's the best next step for the oral hearing? Assess the patient for immunocompromised state. Very easy. So oral lichen planus. So we all know about lichen planus for the skin. They have their own peculiar attributes. They usually call them U6Ps, if I'm not mistaken. All right. The same thing you are most likely going to see them give here. So this is what you have. Can you see? They even put 5 P's here. Pruritic, purple, pink, polygonal, purple, and plague. Can you see what they put here? So these are the lesions. These are the way the lesion for the skin is actually going to present. So let me show you how lichen planus look so you appreciate it better. Lichen planus. So this lichen planus. This is a very good one. Can you see? If you look at it, they will just give something like this. Maybe around the forearm, they are going to give it. Closer to the wrist, it might be anywhere. So you just see, they will say, well, they will just give it just the way this diagram is. That's how it's going to be. You can use the 6 P's to actually describe it. Can you see? Some of them will be in the question, pruritic. The others, you will see them on the lesions. So it's pink, it's polygonal, it's purple. All right, and plaque. So, and that's just what will help. So these are the location. That's one for the skin. Another one is the hora, which is the one.
What's the problem?
Can we mute our mics?
Sure. Oh, thank you. Thank you. Can you wear it? Thank you, sir.
So this is actually so the one on the oral cavity or oral mucosa is the one we are now looking at. So most time they can give you the one on the arm, the wrist. I mentioned arm because it's closer to the wrist. That's why I was using the word arm. All right, so wrist. Then they will now ask you about the one of the mouth. So or they tell you that the patient has been having this, and the likes. All right, so what is that thing that you are going to see in the mouth that you must rehearse towards the exam? Like if you forget, no one will forgive you. Like it is the one they are going to put there. It's the one they will examine. It's the one they will check. It's the one they will test. And that is what? Reticular white plug. Reticular white plug. So please never forget this at all. Reticular white plug. Never forget this. So if I thought they give you the diagram, is the one they are most likely going to be testing. All right. So that's just by the way. How do you want to make the diagnosis? Just basically clinical. Let me show you that reticular white plug so that when you see it in the diagram, you know that, oh, is the one. Let me show you. Sorry, please don't be annoyed. All right. Lovely. Let me see the one that will look like. Yeah, this is a very good one. Can you see the way it is? Feel. So this is how the diagram will look like. This is what they will give. It's not that maybe, it's not maybe. Oh. Just see reticular. They call it reticular because of the way they are entered. They give it a very wonderful, beautiful name. Wickham lesion or something like that. All right, so just see it. They will just give it to you like this. That reticular white plaque, reticular white plaque. Once you, it's just the diagram. Once you just say this is lichen planus, ora lichen planus. So please never forget that. So that's why the arrow is on it. They will show you, and it's one they will test. So what about the treatment? Now, this is now where it becomes tricky. For the treatment, you've seen the diagram, you've seen the patient and the likes. The next thing is, what do I want to do? Just check that question. Is this patient symptomatic? If the patient is symptomatic, that's when you treat. If the patient is not symptomatic, no treatment is required. So if the patient is asymptomatic, you can just pick reassure. If the patient is symptomatic, you pick topical corticosteroid. That's the answer. So your duty is just to check, is this patient symptomatic? Is this patient not symptomatic? So when we are doing the program in January, as I told you, so you will now be practicing all this on these questions. You will be saying, okay, what's the answer? What do I want to pick here? And the likes. You'll be practicing just those concepts. Very easy concept. Just read the question, look at the diagram that is given, look at the question, and pick your answer. All right. So that's that. If I thought they've given the topical corticosteroid that is not effective, so that's when they will be going for topical tacrolimus and the like. But they hardly get to this area. Or this area, they hardly get there. So they are most likely going to stop here. Just this topical corticosteroid. Oropharyngeal cancer. Oropharyngeal cancer. In the United States, HPV infection is responsible for 70% of all new cases of squamous cell carcinoma of the oropharynx. So now what it means is that when they give you question in the exam, you've read the question, you're already thinking towards oropharyngeal cancer. They now say, what's the most likely risk factor here? This is your answer, HPV infection. It doesn't mean smoking cannot be. Smoking can be, but you need to be very careful. That's why I needed to put this statement here that in the United States, HPV infection is responsible for 70% of all new cases of squamous cell carcinoma of the oropharynx. You see, very easy, straightforward. All right, so when you hear about the oral cancer, so oropharyngeal squamous cell carcinoma is making up to 90% of all oral neoplasm. That's a fact. So what are the pre-malignant lesions that we've talked about? So one of them is leukoplakia, erythroplakia. Another one is lichen planus. All right. So the submucosal fibrosis should also be part of it. All right. So that's just by the way. How will the patient present? They may not actually have any symptoms. And for those that have symptoms, they are going to have an ulcer. So now, the ulcer that you are now going to see here, the edge is going to be rolled up. Rolled up. So that's the edge of the border. Then the central area is going to be necrotic. This is completely different from the aphthous that we talked about. The central area for the aphthous is filled or is covered with yellow exudate. So when you look at it, just be like, this is not yellow exudate now. The edge is raised here. This is most likely cancerous. It just be like, most likely I'm dealing with squamous cell carcinoma. Very easy. All right. So where are you going to see it? Lateral portion of the tongue. Also the ventrolateral part of the tongue. Now, what are those premalignant lesions we talked about that can affect the lateral portion? oral leukoplakia, erythroplakia, oral hairy. You now say, oh no, oral hairy does not have malignancy potential. So you remove that one. So you start thinking towards oral leukoplakia, premalignant lesion, erythroplakia. Okay, see, very easy. So what is the risk factor here? So now you're like, where am I? Say United States. Which risk factor am I thinking about? You say HPV. It just show you oropharyngeal squamous cell carcinoma. What's the risk factor here? You say statistically, based on United States location, the commonest risk factor here will be HPV. The next thing will be, oh yeah, go and check that patient for HPV. They say the patient is HPV negative. If the patient is HPV negative, you will now be thinking towards these guys. Am I dealing with smoking? And do you smoke? Or use of smokeless tobacco? They call it vape. And all manner of stuff that I think they smoke them like that. All right, alcohol. Then the Bethel or areca nut injection. You know, we talked about the areca nut causing the oral mucosal fibrosis. So never forget that, these guys. So these are the risk factor in HPV negative oropharynx tumor. So don't forget, the first thing you will be thinking about in the exam is, am I dealing with HPV? Am I dealing with HPV? Because of all you care, smoking will also be there. So you now be like, what is the risk factor here? Maybe I'm dealing with. If you now check the question, you can't see any clean chart towards HPV. So maybe you are dealing with HPV negative. So you now be thinking towards this guy, smoking, alcohol, areca and the likes. So, and that's that. So that's for the risk factor. So how do we want to make the diagnosis? They won't ask beyond, what do we call this name? Biopsy. So just biopsy. So now, after, if the question says they've done biopsy, now I want you to write it down. After biopsy, for a lesion, the next thing you want to check for is, what is the degree of metastasis? So what is the degree of metastasis? Once the question says biopsy has been done for any lesion, they now say, what's the best next step? You want to do something to check for the degree of metastasis. So which may be head and neck CT. Okay, because if the thing has not really metastasized, your treatment option will be different. If it has metastasized, you start modifying your treatment option. Very easy, straightforward. So what is the treatment? Yeah, the treatment, basically surgical resection. This is just what they will test. It's initial surgical resection. This is basically what they will test. Lymph node dissection done with significant nodal disease or deep infection, and they hardly get to this level. Basically, they hardly get here. But you can look at them at your own pace, but never forget surgical risk. Just think about them simply, because the exam, for all you care in your GIT, they might not ask more than 10 to 12 questions. So don't give yourself a headache. Easy. Can you see? Oropharynx, HPV negative. I'll be thinking about smoking, alcohol, areca nut. Can you see? So how will I know it's cancer? The ulcer there, we have necrotic central area. Then the border will be rolled up. And we are done with that. Let's look at the salivary gland disease. So this is actually the salivary gland lesion. Dr. Sunday. All right, I thought someone wanted to ask something. Okay. So let's look at the salivary gland disease, how they will be coming. So now, you don't need to cram the table that is given here. It's not necessary. So we know you really want to prove to the world that you read for the exam, but you don't need to overread. Okay, you don't need to. So maybe at your own leisure time, If not that it's webinar we are doing, I will have said you should bring out your sheet of paper. You now write SAL adenosis, acute suppurative SAL adenitis, then acute non-suppurative SAL adenitis. That's the third one. Then salolithiasis. The fourth one, ranula and the mucosae. So these are the 6 lesions they are going to be testing. All right. So how are you going to be tearing them apart? So if at all you read the question, and around the place where those places where the how do I put it, where you are supposed to have those salivary gland, you are now seeing swelling. So you are seeing swelling there. So what you want to quickly check is, this is swelling. Is it painful? Is it painless? So if the question says a painless swelling, maybe around the front of the hair or something like that, you now be like, okay, any other symptoms here, basically, you cannot see it's not painful, so there is no sign of inflammation there. Then you will be thinking towards SAL adenosis. Can you see? Painless swell, just painless. Any other thing they put there does not concern you. Don't go and overread that question. No sign of infection, just swelling. That's all. Just swelling. And the diagnosis was the most likely diagnosis. The answer is SAL adenosis. Now, what can make that salivary gland to be swollen? It's not painful. It's just possibly the patient has been vomiting a lot, maybe having bulimia, maybe the patient is having malnutrition, maybe the patient take alcohol a lot, liver disease, and all manner of stuff. You shall see a clincher there. They will not ask you what is causing it. No one asks that kind of question. They will not ask it. That what is responsible for. They will not ask it. If I thought they ask it, the answer is in that question. It's going to be the only thing in that question. So that is for SAL adenosis, a non-inflammatory, non-infectious, painless swelling of the parotid gland. That's all. All right. So you've seen that. If I thought they asked, apart from diagnosis, what's the best next step? The best next step basically is just the ultrasound. Can you see? Ultrasound, just to check it, whatsoever that the patient is also having there. What's the treatment? Whatsoever that is causing it in the question, you just address the underlying cause. So the hardly test is just the diagnosis. Then you are done. So now we read the question around the parotid gland area and the likes. We are seeing swelling. So you now check the question. The question says the swelling is now painful. Immediately you see it's painful, you'll be like, am I dealing with acute suppurative SAL adenitis or acute non-suppurative SAL adenitis? All right. So these are the 2 differentials you have. Is it acute suppurative or acute non-suppurative SAL adenitis? All right. So under what will you see in question that will make you to go for acute suppurative SAL adenitis? You will see symptoms and signs of bacterial infection. So you will see symptoms and signs of bacterial infection in the question. Can you see? You will see it there. So the patient may be febrile. Can you see? The patient may be febrile. Fever may be there. Then the thing is very painful. You are not seeing any other thing that can justify that this is viral infection, which I'm going to mention very soon. So they can put all manner of stuff there. All right. So just don't forget this. You now go for acute suppurative SAL adenitis. Just by seeing it's painful and it's swollen. All right. And you are seeing fever and the likes. So it doesn't mean that for the next one, acute non-suppurative SAL adenitis, that the patient will not have fever. It doesn't mean that, but there is something you will see in question. All right. So now the next thing is, what is the most likely organism that is causing the infection here? Staph aureus. Can you see? You just check the options and pick Staph. So you need to rehearse this. If you don't rehearse them, you just sit down, you're just solving questions. You now get into exam, they now ask you. You now look like it's difficult. If you go into the exam with this basic knowledge, it will make a lot of sense to you. So you just be out start for us is what they are testing. All right. So basically that's that. The other risk factor are here, which you don't really need to bother yourself much. So they can test this. These are your potential questions. All right. So what is the best next step here? You are already looking at now. Say what's the best next step? Now, for the best next step in the exam, it can be towards investigation. It can be towards treatment, drug, or whatsoever you want to do. So the way to know the best next step is just to check the options and be like, are you asking me about investigation or you're asking me about treatment? So if it's treatment, all the options will be related to treatment. If it's investigations, all the options will be related to investigation. So best next step will be ultrasound. So it's not difficult. Ultrasound for what we've talked about so far. All right. So, and that's that. So now, what do you want to give to the patient for treatment? If this is all about treatment. So you need to be very careful here. What do you want to give to the patient for treatment? Now, as simple as what they put here is what they test most of the time. Most, I didn't say definitely, all the time. So hydration and the salagogi. So which is just by giving the patient sour candy, the patient will be chewing it and the likes. Because you want the salivary gland to drain more. Because if you are told there is stasis, so there is stasis or the patient is dehydrated, so those bacterial infections will settle there and they can easily lead to abscess. So you don't want that. You just be like, oh yeah, take this sour candy, be chewing it. So the patient will chew it and will produce saliva more, and that will make the infection to be resolving with time. Then warm compress. If the patient is having a lot of pain, you give NSAID. So NSAID. Now, if you look at it, you are like, NSAID is what they are going to test. It's not even this NSAID they test in the exam. They don't even test this NSAID and all this one. It's even this salagogi that they test in the exam. Because that is what most people will see that can actually make them to overlook, that they can overlook. You see a patient now that is having acute suppurative sialadenitis in the clinic, and you just give and you just go and take the antibiotic. Yeah, the antibiotic will work. But if the patient is not rehydrating himself and is not chewing to produce more of the saliva, so the next thing is whichever bacteria that is there or debris and like, they can actually worsen one or lead to another entity entirely, like sialolithiasis. So never forget the salagogi or salagogi. So it's simple, you can easily overlook it, but they test it a lot. Like when you get into the exam, you see it, you'll be happy and be like, wow, that's what we have been expecting you. Say we have been expecting you to appear. Just appear in the option. We know, this makes sense. Yeah, this salagogi. So if the question says the physician has counseled for hydration, salagogi, blah blah blah, and the like for pain based on NSAID, is there another thing you want to add to it? So you can now be thinking towards antibiotic. That is for this. Can you see? So now the same salagogi hydration is also going to help this patient here, sal adenosis. So it's also going to that. It actually helps basically all of them in a way. All right, so that's just by the way. So for this acute suppurative, what of acute if at all you are dealing with abscess, how will you know you are dealing with abscess? The question will say the patient has the swelling, is painful, is this, is that. They place on hydration, salagogi, antibiotic, and the thing is not resolving, and it's now becoming fluctuant. You are most likely dealing with abscess. So with that regard, the answer will be surgical drainage. Can you see? So you need to sit down and imagine it, how they will test. That's what will help. So what of acute non-suppurative sialadenitis in the exam? So now, for this question, they will tell you, blah, 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 the swelling is there. They will now say it's also painful. But there is something you will see in that question. You call it viral prodrome. which is most likely going to be in the question. So viral prodrome is going to be there. So when you see that viral prodrome, the next thing is I'm most likely dealing with acute non-suppurative sialadenitis. So, and that's that. It's commoner in children, most common in children less than 15 years. So the patient is most likely going to be pediatric. So which organism do you want to take into the exam? The same one you are thinking about, mumps virus. You say mumps virus. So very easy, straightforward. All right. So what is the investigation? So real-time reverse transcriptase polymerase chain reaction. It looks like, are you sure this is what they will test? Well, we've put it in the box. That's why you just check the option and pick it. It now look like you can answer complex questions, but you just practice with them. Real-time reverse transcriptase polymerase. That's best next step. All right. So what about the treatment? For the treatment for this one, just the same thing you were giving here. Hydration, salagogi, one compress, and the likes. So if the patient is having pain, you can give painkiller and say that it may help. So apart from that, there is nothing more to do. You don't give antibiotic for this. So how could this have been prevented? MMR vaccination. Measles, mumps, and rubella vaccine. What of sialolithiasis? How will you know this is all about sialolithiasis? There is something you will say there. You call it episodic. This is the word you are looking for. Episodic. So they will just say this patient has been having intermittent or episodic painful swelling of this. Just see that word, intermittent or episodic, episodic. It comes, it goes, and it worsens when the patient is done hitting. Do you get me? So when the patient is done hitting, so it worsens. It may be during the time the patient is hitting or after. So most time after meal. So it's postprandial pain. So after that, it's going to resolve. Can you see? It will now resolve. Then the next time the patient eats again, after eating, it will come up, or during the time the patient is eating. The reason is that when we eat, when we talk, we produce saliva. So those saliva are supposed to be coming out, and what is making them to come out, to roll out, is basically the squeezing of the salivary gland. So as they are squeezing, they will be squeezing against those stones. So sialolithiasis, and that will make the patient to have pain. So you just see the word episode. This is the word you program your mind that you are looking for in the exam. Just this word, episodic. That's what you are looking for. So what about the investigation? Best next step. The best next step basically is going to be the ultrasound. So if you look at it, ultrasound, then this polymerase chain reaction, reverse transcriptase polymerase chain reaction, reaction, real time. All right, so that's that. So what about the sialolithiasis? The best next step, and it's about the treatment too. Never forget this again. Can you see sialagogi again? So Sandy, one compress, the same thing. So it's not difficult. So the same thing. You just want the salivary gland to continue to flow. All right. If at all the patient is having pain, give painkiller. If the patient is having infection, so this one that I put in box is actually what they test. Like this one, yeah, under the sialolithiasis, this is what they test. Because if the patient can continue to produce saliva, the saliva will eventually push out the stone, and the patient will be better. You now tell the patient, you just don't want the patient to prevent dehydration. Because when the patient is dehydrated, they will form the stone again. Can you see? Very easy and straightforward. If at all this does not help the patient is still having it. All right. You can now go and do the sialoendoscopy or surgical removal of it. That's after this one has been done. So when you check the question, have you done the initial? Now be like, what is the initial? What's the initial? What's the initial? Rehydration, sialagogi, this one, that one. Be like, I've done everything. Wow. you are still having it, yes, you now be looking for something like this salo endoscopy or saloadenectomy. And that's all. What about ranula and mucosa? Ranula and mucosa. All right. So the thing about these guys is that they are also swelling. These are swelling in the floor of the mouth. All right. So floor of the mouth. We just talk about swelling. We've talked about one swelling before, torus palatinus, and you know definitely that's going to be on the midline. So the thing about these guys is that they are also swelling there. So one, they are not supposed to be on the midline. All right, then what will help you to differentiate them is their color. So color for the ranula, the question we talk about the fact that it's actually appearing bluish, while the mucosa does not appear bluish. That's all. So you just want to give yourself a headache by trying to cram a lot of stuff. So they will definitely put it there. There's no way the question will be about ranula, that this bluish swelling will not be there in the exam. There's no way the question will be about mucosa, that you don't know that you are saying that there is this lesion, this pseudocystic lesion or cystic-like lesion that does not appear blue. So it just be like mucosa. So ranula is bluish, mucosa is not bluish. So how will you make the diagnosis? It's clinical. So it's clinical. So what the next question you are expecting is treatment. The answer is surgical excision. So you can sit down and rehearse that over and over and over and over again. All right. So the last thing I'm going to mention is about this benign and malignant. So by the time we are meeting next time in January or so you now answer this question. You pick your answer here and see how many of them you can get. So these are the benign and malignant tumor. So I don't have much to show us here, but just to mention 1 or 2 points. So we have pleomorphic adenoma. This is benign. So can't I play with you again? I'm only playing. My joke is benign. Pleomorphic adenoma. I didn't mean it. I was just playing with you. I thought you are malignant. He said, no, I was just playing. Pleomorphic adenoma. It's benign. All right. So now, this pleomorphic adenoma is actually the most common salivary gland tumor, and the gland that it affects majorly is the parotid. You see, the parotid is the biggest of them all. So you will be expecting a patient with malignant tumor to affect the parotid, but opposite is the case. Benign tumor goes towards parotid, while the malignant goes toward the others, like the mandibular and the likes. All right. So please never forget this. Pleomorphic majority in parotid gland. So what are the causes? The risk factor. You don't need to cram anything here. Nothing to cram here. So ionizing radiation, viral infection, smoking. You don't need to, nothing to cram. Don't give yourself a headache. All right. So that's just this gland, which is going to be in the body of the question. So now, how will I know that this tumor is benign? How will I know it's not malignant? So for the salivary gland tumor, when you read the question, you should be able to insinuate that this is looking malignant. So, this is looking benign. For the benign, they are usually slow growing, they are painless, they do not affect nerve. They do not affect nerve. All right. So if at all you want to think about any nerve here, The nerve you can be thinking about is actually the facial nerve. Facial nerve. All the stuff. So when you read the question, you start seeing it's painful, it's affecting nerve, it's fast growing. You start thinking towards this is most likely. It doesn't mean in all the cases anyway that they are going to be painful. So this is most likely malignant. So malignant, they are most likely to be painful, fast growing. They can involve the nerve. All right. So if this is pleomorphic that you expect to be benign, let me say the question says the biopsy shows maybe 2 years ago or so shows a pleomorphic adenoma. Now say, you now remember, can't I play with you? This is benign. Now say, now the patient is now having facial paresis. The patient is now having this, it's now having pain, it's now having that. Just there is malignant transformation already. So it's malignant. It has already transformed to be a malignant tumor. So that's about the presentation. So when you read the question, you should be able to say it's benign or not, just by looking at those clincher. So what about the diagnosis? Again, for the diagnosis, ultrasound, then fine needle aspiration biopsy, or ultrasound guided core needle biopsy to confirm the diagnosis. So how will you know this is what they are testing? They will say, which of the following what's the best next step in confirming the diagnosis? The answer will be biopsy. Just the same thing you have known before. Confirm, they said. They never say to look for this or just ordinary best next step. All right. So now, what about the treatment? What about the treatment? The treatment, you are expecting them to test in the exam. Basically, it's just surgery, unless you are dealing with the one with malignant transform. Just surgery. Because if it's benign, just need to remove it and the patient should be fine. So surgical excision is the answer. And this is where they are most likely going to stop. Just surgical excision, surgical excision, surgical excision, surgical excision. They will just do surgical excision. All right. So this is just a risk. Facial nerve injury dysfunction during the time they are doing the surgery. So the patient can also have this Frey syndrome, where the patient will be sweating while the patient is chewing. So there is something about this surgical excision you want to take into the exam. When they remove it, the possibility of it not being completely removed is high. So let me show you how it looks. So let me say this is the gland. The tumor can go like this. Can you see? So when the surgeon comes and the surgeon just remove this area, just remove it like this. Can you see? And be like, Dr. Tajuddin, say, how was the surgery? We try all our best to remove everything. You see how big it is? You say, well done, sir. You've really saved the patient. So if you look at it, there is a spike here. There is another spike here. There is another spike here that was left. So all these spikes, they make the lesion to recur. So the possibility of incomplete excision is very, very high. That's, you now say, okay, maybe after some time, the patient present again and say, Dr. Tajuddin, your patient has come again. The thing has recurred. See, you can't, please don't play with me. Please don't play with me. He said, we are not playing with you, but your patient is in the clinic waiting for you. The same patient you operated and he has recalled pleomorphic adenoma. You can use that if you wish. If it helps, fine. If it doesn't, you can throw it away. So this is mucoepidermoid carcinoma. This is malignant. This is also malignant. So you don't need to cram them. So this mucoepidermoid, commonly, I mentioned something like parotid. You usually see the benign in it, while the other one usually see. But this one is a bit different. So commonly you see it in the parotid gland. So now, the thing about it is that it's painless, slow growing mass, firm. So it's actually quite dicey because the fact has been established, and I want you to look at that fact in the exam when you look at it, unless maybe the question just mention histologically and be like, a diagnosis of mucoepidermoid carcinoma is made. What is the best next step? So which is actually what you are really looking out for. So the best next step here, if it's about the investigation biopsy, if it's about the treatment, just look and miss the option for surgery with radiotherapy because you are dealing with malignant lesion. The same thing for the adenoid cystic carcinoma. So this one is a bit cystic, so at the same time being glandular. All right, so this is submandibular gland. That's what it affects. So this one will invade the facial nerve. So you are going to see the facial weakness or paralysis in the patient. Adenoid cystic. So please never forget this. It's also malignant. Best next step, never forget histology. Biopsy. If it's about the treatment, just pick surgery plus radiotherapy because it's malignant. And that's that. So the only one you just go for surgery is this pleomorphic adenoma. And I noticed that most time the questions revolve around this one, and sometimes this one. All right, so I don't need to be 100% correct. So I'm going to give us 30 minutes break. So let's go for 30 minutes break. We come back in the next 30 minutes. All right, thank you everyone. For those that want to run away, let's run away. Okay, I hope we are learning one or two things. All right.
Yes.
All right, so to continue our journey, so we now have an idea of how the one we've done, they are most likely going to be tested. So just rehearse them, like say them to your friend, ask your friend. So if they give you this, what will you be thinking about? Because that's actually basically what you need. So not to, because once you see it, you will know. It will always come out clearly in the question. You know, when you don't rehearse them very well, when you see some questions, you will have 101 things running through your mind. So it may actually make someone to waste time in the exam. Then when someone is about to enter the examination hall, that person is most likely going to be jittering because the person is not sure of what is most likely going to be tested. And it's not compulsory they test everything, but you know, when you are done with the OGI, you should be able to say that they asked me this, they asked me this, and the likes. All right. So esophageal disease now. So to be sure, are you with me? Is everyone with me, please?
Yes, you're with
All
me,
right,
Dr. Pesos.
thank you. So now this is dysphagia. This is dysphagia or odinophagia. There is no one here that will say, I don't know dysphagia, I don't know odinophagia. So dysphagia is just difficulty with swallowing, while odinophagia is pain with swallowing. This is something everybody knows. All right. So if you look here, this statement is a fact that you will take into the exam. Like, it's a fact. You hold it very well. So I told you last time that all the key facts in the first stage, they are the possible questions they've tested before. So the book of the ages. So in an immunocompromised person with odinophagia, candidiasis should be one of the differential diagnoses. So anytime you read any question about, I will get there, I will show you about immunocompromised patient, maybe HIV patient, just say this patient had renal transplant, he's had HIV, had this, now having odinophagia. So the differential that one of the differential that you should be considering is, hope I'm not dealing with candidiasis. That's all. It's just as easy as that. All right, let us look at oropharyngeal dysphagia, We have oropharyngeal dysphagia, we have esophageal dysphagia. These are the two you want to differentiate now. What will you see in question that will tell you, this is oropharyngeal. Oh, this is actually esophageal. For the oropharyngeal, what they have is problem initiating swallowing. So they can't even first of all initiate the swallowing. So this is all about initiation. Why the esophageal is these people they don't have any problem with initiation. They can initiate the swallowing, but as the swallowing process is going on, they will now be complaining of the food getting stuck. Now, what does that one mean? In the exam, if you will be thinking towards oropharyngeal, the question will say, they will mention it, that there is a problem initiating swallowing. It will be there. So they will mention it that, okay, this patient cannot initiate swallowing. You are going to say it. The patient is having problem initiating swallowing. Do you get me? So it's going to be like well mentioned, or some other clinchers that will give it out that, okay, this is oropharyngeal. So if the patient cannot initiate swallowing, the food will still be around the oropharynx area. So the patient can easily aspirate can easily aspirate the food. So it means that this question around oropharyngeal dysphagia is most likely to come along with one or two pulmonary symptoms. However, esophagia is most likely not to come with pulmonary symptom. Now relax. So they now give you a question on dysphagia. As you read that question, you now see one or two pulmonary symptoms there. The patient is coughing, the patient is having this, the patient is having that. Just know that you are most likely dealing with oropharyngeal dysphagia. Because if that is going to be esophageal, the food will have gone a bit down. The food is just getting stuck. That is what you have for the esophageal dysphagia. However, for the oropharyngeal dysphagia, they can't even initiate the swallowing. Can you see? Very, very, very easy. So your assignment is so the question is all about dysphagia. You now trace the question, can I see any pulmonary symptom? If you see it, oropharyngeal is your answer. If you do not see it, esophageal is your answer. All right, so what are the causes? You can't cram all these causes. If the patient cannot initiate it, maybe you are dealing with stroke. Maybe you are dealing with Parkinson's disease. So majority of them are neurologic. The one that is structural is what we call Senka difarticulum. Senka difarticulum. And there is something you will see in question that will tell you that this is Senka difarticulum. And you call that halitosis. Halitosis. You will see halitosis is bad mouth odor. Halitosis. You know that this is Senka. So if it's Parkinson, you will see one or two symptoms of Parkinson in the question, either from the gait to the tremor to one thing or the other. If it's myasthenia gravis, you will see something related to the myasthenia gravis. They've been using it now. The patient cannot use it again. They've been doing this. The patient is now having weakness. So weakness with repeated use. Do you get me? The same thing for prolonged intubation, edema and the likes, and spasm around it. So that's that about this area. The stroke, you will see one or two things around stroke in the question. You will now see that the patient is having dysphagia, and the patient is also having some pulmonary symptoms, just a oropharyngeal. So you don't need to sit down and cram this. The question will come. All right. We'll look at this specially. So the next thing you want to do is, what is the history going to look like? Esophageal dysphagia, true history, physical examination, investigation, depending on whatsoever that is causing it. Now, what is the best next step? The best next step now, don't forget that they've already given you dysphagia. You look at the question, you are seeing pulmonary symptoms. The patient is just coming to you. They've not done anything. Now, what's the best next step in the management? The answer you are looking for is this: modified barium swallow. This is your answer. If they do not write modified barium swallow, what they will put is video fluoroscopic swallowing examination. This is what they are going to put. Modified barium swallow, with or without esophageal manometry, but they don't bother themselves about this. But this is the one. Can you see? Modified barium swallow is video fluoroscopic swallowing exam, because it's video, because as they are doing it, what do you call it? As the patient is swallowing, they are going to see. They will just be watching it on the screen for them to see that, okay, the patient cannot even swallow this thing. This is the level the fluid is. This is the level the contrast is. The barium is this, that, and they will be able to see it and the likes. All right, so that is the best initial test, and this is actually what they test in the exam. Modified barium swallow. They do not go beyond this one. You read the question, dysphagia, pulmonary symptom, ask what's the best next step. This is the answer. Modify. So re-ask this. Ask your friend, oh, what is this? They will tell you. Now, you've diagnosed it. What is now the treatment? What is the treatment? Basically, you can look at the treatment as more or less like general treatment and the treatment that is associated with whatsoever that is causing it. So the general treatment is more or less like diet modification, swallowing therapy, then sometimes temporary non-oral feed. You see, these ones I highlighted first here. They are the one they are most likely going to test. The reason is a common sense. The patient comes to you with oropharyngeal dysphagia, and the next thing, this is someone that has not been able to feed for up to 3 or 4 or 5 days, and the next thing you are discussing with the patient is surgery. Before that surgery, you want to kill the patient? No one will take that from you. That's why they say common things occur commonly. Simple thing they test. So amidst all the options, you will see big words, big grammar, this, that, this. Whereas all they are looking for is just diet modification. Just diet, just see diet, just pick it and now look like you know a lot. You are just being specific and being simple. Can we modify your? That's what a nurse that is in one area will do. That's why I used to say that the more you know, the less you see sometimes, and the more you know, the more complex you think, and the more likely you are going to miss the question. So someone that's a quack nurse or a nurse, this is what the nurse will have given, and the patient will be shouting, I prefer that nurse. So diet modification, swallowing therapy, then non-oral feed. It's after this one has been initiated and is there any other thing more or less like specific stuff or whatsoever, you now be thinking. And the one specifically is just for that Senka diverticulum, and that is cricopharyngectomy and diverticulectomy. We'll look at this later. So this is the treatment for Senka diverticulum. So this is the general treatment you are looking for, unless the question says this has been done. So what is the definitive treatment for this patient? Someone that's having dysphagia, that's having some pulmonary symptoms, that you are now seeing halitosis. You are like, this is Senka diverticulum, and I'm like, okay, what is the definitive treatment for this patient? Your answer will now be cricopharyngectomy or diverticulectomy. Then you are done. 1, 2, 3, 4 points. Okay. Don't forget this, your video. This is the only one you see video fluoroscopy. We don't talk about video fluoroscopic swallowing exam also in this esophagia. We don't do that. What about the esophagia? The patient will swallow, can initiate the swallowing, but the patient will be complaining of this food getting stuck. All right. So what are the causes? It can be from obstruction. It can be from motility disorder like achalasia, scleroderma, esophageal spasm. All those stuff, guys, you've had. We'll look at each of them one by one. Obstruction like stricture, Sankey, Shatsky, ring, web, carcinoma. I will look at all of them with us. So these are just obstruction. All right. So we'll look at each of them one by one. So in the exam, You don't really need to say this is the one or it's not the one. This patient is just having dysphagia and it's not having pulmonary symptoms. So what's the best initial test here? Esophagogastroduodenoscopy, EGD. From the esophagus downward, we start talking about EGD. So, but most of the time, before they do EGD, they usually do barium swallow. The best initial test in the exam that you want to be looking for is this EGD. They will just say, what do we call it? Endoscopy. So you just say endoscopy. So look at this question. So permit me to just show you one question here. 74-year-old man coming to the office due to difficulty swallowing food. What's this? Now, see, the symptoms began 4 months ago when the patient was eating steak and felt like a bite got stuck in the middle of his chest, which resolved after drinking a glass of water. He now says since then he has had worsening difficulty swallowing bread, meat, and other solid food, and has modified his diet to soft food. He has no difficulty swallowing liquid. There is no chest or abdominal pain from eating. Medical history include intermittent nighttime heartburn relieved by antacid. All right. The patient does not use tobacco, alcohol, or recreational drug. Family history is unremarkable. Vital signs are within normal limits. Physical examination shows normal dentition and oropharyngeal mucosa. Tonsils are normal. The abdomen is soft, not tender, with no organomegaly. The remainder of the examination shows no abnormality. Which of the following is the best next step in the management of this patient? You now look at it as this patient is having dysphagia, and this dysphagia is most likely esophagia because I'm seeing food is getting stuck. All right, if that is the case, if the best next step, now quickly check, is it all about treatment, all about investigation? At least you investigate. If you are told they miss it like this, you investigate before you go for the main treatment. All right, so the best next step here is going to be the endoscopy. That is the EGD. Another name for the EGD is upper gastrointestinal endoscopy, and that's all. Can you see? And that's how the question will be given in the exam. All right, so that's just by the way how you differentiate them. So let's look at the infectious esophagitis. It's from this infectious esophagitis I will now show you this and this. These two. So what is infectious esophagitis? This patient definitely has esophagitis. All right. It's just the infection of the esophageal mucosa, or you see esophageal lining. So this infectious esophagitis, you see it in immunocompromised patients. So now, the way the question will come is either someone with HIV, organ transplant, or something is now presenting with difficulty or pain with swallowing. So you just say at the back of your mind, I just like infectious. Like, doctor, infectious. Can you reduce your voice? Let's still read the question. Okay, say until proven otherwise. This question is all about infectious esophagitis. So there are some questions you don't even read finish before you say this is the answer. Yes, it's infectious. All right, now let's look at them. There are 3 guys they are most likely to be testing here. One of them is Candida, another one is Herpes simplex, another one is cytomegalovirus. All right. So what you want to take into the exam is the way each of them, the peculiarity with each of them, and under which condition do you go for which one. Okay. So this is Candida. I will just describe the 3 of them for you. We now see the way they present. This is Candida. Candida, you go for Candida when they say the patient, they are also picking oral thrush. And that oral thrush is actually scrapeable. So you'll be like, okay, maybe I'm dealing with Candida. Do you get it? So oral candidiasis. And if I thought they do endoscopy, what they will see is this yellow-white plug adherent. So then when they do biopsy, they will be seeing this yeast IFA invading the mucosa. This is just what they will see. Anyways, that's candida. So oral thrush will be here. So now, if you remember, I mentioned something about the candida for us, that for mild infection, basically you just use oral drug, antifungal, miconazole, nystatin, clotrimazole, and like those are just the ones you use. So for the moderate to severe, that's the one you use, fluconazole oral. So did I say oral? I wanted to say topical. Please don't mind me. So I wanted to say topical. So topical. Then you now use oral here. Do you get me? So for the moderate to severe, you use oral. The other one, topical. For mild, topical. So please never forget that topical antifungal for the mild one. So that's for the candida albicans. So the other infection for this immunocompromised patient with difficulty or pain with swallowing will be, am I also dealing with herpes simplex virus? All right. Herpes simplex virus. The ulcer you see here is actually, they have oral ulcer, and the ulcer is going to be round or ovoid. Immunocompromised patients with ovoid or round ulcer. So they can also try to, when they take the biopsy, they can describe the cells they are seeing there. They say multinucleated giant cell with intranuclear inclusion. So multinucleated giant cell with intranuclear inclusion. So what is the drug you want to use to treat this herpes simplex? A cyclover, which can be oral or intravenous. So now let me compare it to cytomegalovirus. For the cytomegalovirus, the ulcer here is linear. So now in the exam, when they tell you this patient is having difficulty with swallowing and is immunocompromised, they now mention ulcer. That ulcer, you want to see the attribute of the ulcer. So if the ulcer is linear, go for cytomegalovirus, cytomegalinear virus, megalovirus if it helps. So cytomegalovirus. If they say it's round, you go for herpes simplex. So what are you going to also see in the patient with cytomegalovirus? Colitis, retinitis. So if it's colitis you are seeing, are they going to mention colitis? This is what they would do. This patient had renal transplants so months ago. Is now having difficulty with swallowing. The patient is also having diarrhea. When they do endoscopy, they are seeing linear ulcers. With biopsy, they are seeing intranuclear and intracytoplasmic inclusion. What is the diagnosis? The diagnosis will be cytomegalovirus. I mean, what's the cause? Cytomegalovirus. Diagnosis: infectious esophagitis. So best next step, this is all about treatment: ganciclover IV. So IV ganciclover followed by oral fal ganciclover once the patient can tolerate oral medication. So what you start with here is IV. Don't forget the patient cannot really eat because of the pain. So when the infection now resolves, the patient can now tolerate orally. You need to discharge the patient, right? So you stop the IV ganciclover. You now place the patient on oral Valganciclover. Valganciclover. You can assume that, okay, the patient is like, doctor, discharge me. I need to go for Valentine, for Val. Be like, we are just treating you. Shall decide. Okay, let us stop the ganciclover and commence on Valganciclover. All right, you can look at it like that if you wish. That diarrhea that the patient is having is from CMV colitis. CMV colitis. So anyhow, the patient can come. So the question will just be very that clear. So this one has oral thrush. These do not have oral thrush. All right. Is cyclover IV or oral? ganciclovir IV. Then when you discharge the patient, Valgan, because the question may even be about when the patient is going home, what do you want to give to the patient? That is for infectious esophagitis. All right, so when we are meeting in January, you will solve questions on all of them. Like you will now be the one thinking, oh, is this candida? Is this, what do I want to give? Like you'll be able to think and be like, okay, which one is which? Why am I going for option E here? Why is it not this? Why is it not that? You will be the one doing all those stuffs. Like you do them by yourself. All right. So that's for infectious esophagitis. So this is the way we investigate here. Endoscopy. Whatsoever you will now see on that endoscopy, you take the biopsy of it. So if the question just say immunocompromised patient that is having pain with swallowing, what's the best next step? And it's about investigation. The answer is endoscopy. So with biopsy. So I'm coming before you ask your question. So now they give you a beautiful question. They just, the patient is having what do you call it? Is immunocompromised, is having dysphagia or dinophagia and the likes. They now say that, shall I give you the examination finding, give you all manner of stuff. They now say, okay, what's the cause? So they now say option A, candida, option B, herpes simplex, option C, cytomegalovirus. So you need to be very careful before you go for candida. So you want to go for candida when the question mentions something about oral thrush. You want to also go for candida if the CD4 count is less than 100. So they can mention the CD4 count there. Just be like, go for, based on the CD4 count, I'm thinking towards candida. Based on the oral thrush, I'm thinking towards candida. So if you can't see those guys there to justify candida, your diagnosis will be viral esophagitis, because these two are viruses, while this one is not a virus. Yeah, someone wanted to ask a question. Okay, Dr. Ekweme. Dr. Ekweme. Okay, maybe it was a mistake. All right, so that's for the infectious. Think simply. Don't go out. So this is a question they've asked before. High risk factor for candida esophagitis include broad spectrum antibiotic, corticosteroid. So you just see that this patient has been using steroid. Treatment in an ICU for cancer, diabetes, organ transplant, mechanical ventilation, indwelling catheter. It can be any of them in the exam. So we are done with that. What about the pill esophagitis in the exam? So what will you see in the question? I will tell you, this is pill, this is pill, this is pill. All right. So definitely there will be one of these drugs in the exam, in the question. So you need to rehearse them. So like you to imagine that someone, you are in a clinic and this patient is sitting right before you shouting, I'm having difficulty. So and this patient has been on drug. Just quickly check the screen. You can see the list of the drug the patient is taking. You already know what is causing it. You just be like, okay, you're actually having what we call the pill-induced or drug-induced esophagitis. All right, so these are the drugs: ascorbic acid, bisphosphonate, chemotherapy, potassium chloride, ferrous sulfate, NSAID, and some other drugs. All right, so it will definitely be there. It will definitely be in the question. So one of these must be in the question. I put arrow on bisphosphonate because these are the ones they've tested before: potassium chloride, ferrous sulfate, and NSAID. It might even just be NSAID that you are dealing with. All right, so how will I know? Put something here. The same thing, the same logic, it does not change. Difficulty or pain with swallowing plus a pill that can cause it in the question. Just go for drug-induced or pill-induced. So best next step. If that's all they just give you, that's the best next step. You do endoscopy, upper GI endoscopy with biopsy. So that's what you do. All right, so when you do that biopsy, what are you going to see? It's very, very important, because you need to be sure that it's actually that drug that is causing it. So what are you going to see? you are going to see, when you do that endoscopy, what you are going to see is localized ulceration. You are like, so many things can cause the ulcer. So many things can cause ulcer. It can be from this. It can be from this. Now say, doctor, relax, relax. Just check around the ulcer. What are you seeing? And I'll put something there that normal mucosa surrounding that ulcer. You'll be like, this is drug. That is drug. So drug is going to cause localized ulceration with surrounding normal mucosa. So once you see this, you know that this is drug. So please never forget. They may ask this on biopsy, what are you likely going to? So these are the things you rehearse. So now you have already done the whole investigation paparazzi. You now say, what's the best next step in the management? The best next step in the management is more or less, you now check the option. Give the patient this, give the patient PPI, give the patient that, discontinue the drug, this one, that one. The answer is discontinue the pill. So that's what you do. This is what you do. Discontinue the pill. Discontinue the pill. Discontinue the pill. That's what they will test. Just say discontinue it. Because if you were to be the one in their shoe, what would you have tested? I think that's what all of us will have tested. I mean, like, okay, do you want to discontinue? You say, I want to do so. That's good. Symptoms usually will resolve 7 to 10 days after discontinuation. You now see option A, reassure. Option B, discontinue the pill and reassure. Option C, start PPI. Option, so the answer will be discontinue the pill and reassure. So we are done with that. What about eosinophilic esophagitis? If I ask all of us now that when you hear the word eosinophilic, what comes to your mind? Everybody will be shouting, asthma, this one, allergy, this one. And that's the same way it will come. So in that question, this patient is having dysphagia. You will now see something like asthma, allergy, elevated IgE, elevated eosinophy in the question. So that's one way it can come. So you are seeing past medical history of seasonal allergy. The patient is now coming with dysphagia. So that is not relieved by PPI. You'll be like, I hope I'm not dealing with eosinophilic. All right. So beyond that, what are you going to see that will help you in the diagnosis? What are you going to see? You will see this picture. They will give you this picture in the exam. And let us draw our own. Maybe we say it's eosinophilic. Say, yes, eosinophilic. Oh yeah, let's draw it. Eosinophilic, 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 eosinophilic. Can you see I'm writing letter E, 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 E. Eosinophilic, eosinophilic, eosinophilic. You can do the same. Eosinophilic, 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 eosinophilic. So you will see something that look like this ring. I just draw it like this so that at least to pass the information across to us anyways. You can see this ring-like structure on the diagram. You call it concentric ring. When you see this, just be like, most likely I'm dealing with eosinophilic. This diagram alone, just eosinophilic. So that's what you will see. Can you see? Eosinophilic. So they can also have what we call thick linear furrows. These are the thick linear furrows. Can you see? Can you see? Can you see? Can you see? So if they give you this diagram alone, by seeing this alone, this like ring-like, just go for eosinophilic esophagitis. All right. So what is the sequence again? You say endoscopy with biopsy. Endoscopy with biopsy. So if they say what's the best next step, you go for endoscopy. So you see something like this. So after that, biopsy. If they say which test, like the test you want to do to confirm the or the most accurate test, biopsy. Endoscopy with biopsy. Endoscopy with biopsy. All right. So, and that's that. So if we do the biopsy, you will see a lot of eosinophil there. So you don't need to even negotiate it. Everybody knows that that's what they are most likely going to see. So at least 15 eosinophil per high power field. So what about the treatment? Maybe we are already shouting eosinophilic esophagitis, asthma, allergy, IgE, this one, that one. What's now the best next step? Now, this best next step that I start here is actually the most tested in the exam. This one. This is the most tested that you want to check. Like you hold it. Like when you are going into the exam, you are even just like, this is what they will ask me. This is what they will ask. They won't ask because this is a diagnosis, a clinical diagnosis. Even if you go to Canada, it's the same thing. Because medicine is the same everywhere. That's why if you leave United States, you go to Canada, you will still perform. Because the thinking is the same. I want to write Canada exam. I want to write. It's the same thing. And first aid arrange them in. Just pick this, pick this. If you like, go and throw your first aid away. Say the book look tattered. PPI and elimination of possible causes. These are the possible causes. So now, this is the answer. PPI. They will say the patient has been placed on PPI or something. Then you want to eliminate the possible causes. So these possible causes, you don't know them. There's now what they used to do. We call it 6 food elimination diets. So these 6 food elimination diets, you are possibly reacting to something. You are allergic to food. Since you have asthma, you have this, you have allergy. Maybe you are allergic to something too. So what are these 6 food? You can try to write them out several times. So the point that you note them. Wheat, milk, egg, nut, soy, and fish or shellfish. So these are just the one you are thinking about because the patient does not know. But if the patient can pinpoint it, that I noticed that this is the food I had, that's the one you eliminate in the exam. So now the way the question will come is going to be like eliminate this so food from the patient food. Option A, option B, give this. Option C, give that. Option D, give. If you forgotten, eliminate this. That if you are thinking towards eosinophilic esophagitis, this is the best initial treatment. PPI and elimination of possible causes. When you see that question, the answer option A will be too simple for you to believe that that's the right answer. So you need to practice that. So elimination of possible causes. So you now see them do this 6 food elimination diet. So maybe we are dealing with wheat, maybe we are dealing with milk, maybe we are dealing with egg, maybe we are dealing with nuts and the likes. So that's, if at all this now fail, you say I've eliminated, the patient has taken, has taken PPI and there is nothing, his thing does not improve. That is when you now give inhalation or steroid, or you give the patient topical steroid. The patient should swallow. So when the patient swallow it, that is going to outline it. That's going to outline the esophagus and actually help and reduce all the inflammation that is going on there, and that's all. So never forget this PPI and elimination of possible causes. So at it being we are doing our program now, you will have solved these questions so that you now see the way each or all of them are tested. So you'll be able to say, okay, this is the answer, so that you will get used to the thinking. You see, dietary therapy here, we are testing here. This one is just to diagnose it. All right, so that's just by the way. So we are done with this. So what about esophageal rings? All right, esophageal rings. So the thing about the esophageal rings, I used to say something for those that are used to us. I remember in our village, when you dig well, this is the well that has been dug. Sorry, please don't be annoyed with me. So they will now put ring. Let me change the color. So they will put ring. They will put rings. Put rings. Put rings. Put rings. Put rings. Then they put a cover. Don't mind my pronunciation. To cover it. That's the well. So when you open the cover, sometimes, or if it's not even covered, you may see what we call web on it. When you get there, cobweb on top of it. So what does this analogy tell you? Web, esophageal web, they are on top. Rings, they are below. So anytime you read a question that mentions esophageal ring, they are actually at the lower part of the esophagus. While the web, esophageal web, you see them at the upper part of the esophagus. So, which ring are they now going to be talking about? You call it Shasky ring. Don't mind my pronunciation, may not be too correct in the pronunciation, but this is the one they will test. Shasky ring, Shasky ring, Shasky ring, Shasky ring, Shasky ring. So that you won't get into the exam, you see Shasky ring, you are shouting, I don't enter one chance. It's a big word. No, it's just the commonest ring they will test. Ring, just the lower part. Alright, so you now come here. So, how will the patient present? Usually asymptomatic, but they can have. So you think about it. If this is the ring, if the patient swallows solid cannot really go through. But if the patient swallow fluid, water will go through. So this patient, most of the time, they are just going to have dysphagia to solid. That's what you see, dysphagia to solid. Alright, so that's just by the way that you want to note. Okay, how severe is going to be is the same thing you are thinking. It depends on how narrow the lumen has become as a result of the ring. This is another ring here. And this ring is just like this. So then, definitely this is wider lumen compared to this one. So this patient here will be less symptomatic compared to this one that will be more symptomatic. So what is our diagnosis again? All right. With respect to this, so you are going to do barium swallow, then endoscopy and biopsy. So you do barium swallow, endoscopy, and biopsy. All right. So what about the treatment that they are going to test in the exam? The treatment they are going to test. When they do the barium swallow, you will see this thing, symmetric, circumferential. Once you see circumferential, now you just say, this is ring. Or they do the endoscopy. Endoscopy will show you will see that fleshy outgrowth. You just be like, oh, this is the ring. And that's what you will see. You see this is ring. Thin, smooth, circumferential membrane. Biopsy used to evaluate for esophagitis. So that's the essence of the biopsy. So shall know that is ring from here. So what do you now want to do? Shit. You will now go, you are looking for big grammar. You are just joking. The only thing they are going to test is this esophageal dilation. That's, option A, they will mention, hey, do this, B, do this, this one, that one. It shall list them. Option F, dilation. So the answer will be esophageal dilation. This is it. So after the dilation is done, you now place them, because when you dilate, don't forget that ring is supposed to be found at the lower part. So they may have one or two, just to prevent, reflux and all manner of stuffs, which may be a complication of that dilation because of forcefully putting that instrument that you are using for dilation. So you place them on PPI for 6 weeks. So followed by 6 weeks of PPI therapy, proton pump inhibitor. So, and this is it. This is the most tested concept in the exam. Just this dilation and this PPI. Just that's the most tested. More than 99% of the time. This is just what they test. Initial therapy, just this one. So just rehearse it. Ask your friend. So if I thought you read the question and it's about ring, what will you give? What will you even see in question? You see them say when they do endoscopy, it's showing smooth circumferential membrane, this, that. Now say, what is the best next step here in the management, which is related to treatment? The answer is dilation. So if I thought it's recurrent and refractory, you can repeat whatsoever you might have done before. So you can repeat that. There's something we call stick house syndrome. Stick house syndrome, where people will go and visit another, or you pick meat inside the pot, so you do not chew it very well, so you now want to swallow it. It will now look like that meat does not want to go down. So like the meat does not want to, all because it was not properly chewed. So that is more of stick house syndrome. So it's just food impaction of the esophagus after eating a piece of food without sufficient chewing. Example, meat bolus. All right, so that's just by the way, and we are done with this esophageal ring. Can you see? If I ask now, what do we test? Everybody will be shouting dilation in the treatment. They will describe it. So let's look at Plummer-Vinson syndrome. Plummer-Vinson syndrome, where is a triad that everybody here that has written step 1, I believe, still remember that we used to say, die. I command you to die. Die. They're like, why you don't kill me? Dysphagia, iron deficiency anemia, esophageal web. So this is web, and web is related to the upper part of the esophagus. Upper. All right. So if this patient has iron deficiency anemia, how will I know that this patient has iron deficiency anemia? Because they wouldn't just give dysphagia and just say iron deficiency anemia. So what you will see is that the patient has dysphagia basically. They can now say maybe the patient is having glossitis, angular cheilitis, koilonychia, MCV, mean corpuscular volume, less than 80. Can you see the way they bring it out? And the patient is also having maybe weakness. So when you see this, and they now say the patient is having dysphagia, so they do endoscopy, they are seeing the web, just know you are most likely dealing with Plummer-Vinson syndrome. The triad will be there. Now look at it. They give you a question, dysphagia. They now show this diagram. And the next thing you see is MCV is less than 80. Like maybe 70, 74, 76, something less than 80. This diagram, what can we see here? Now, this is where your confusion may be. You are seeing one protrusion here. This one where my cursor is actually a protrusion into the lumen. But this protrusion is only located on one side. It shows that it is not circumferential. Then this protrusion is at the upper part of the esophagus. Now, you are going to be wrong. If you get into the exam and you are thinking where my cursor is here is the upper, this is just the neck. So this is actually, so you can't be looking at this as the lower because the esophagus still go down. So this is the neck. So the esophagus, you can be thinking about it maybe around this, starting around this area here, then it's going down. So, all right. So this is just the upper part of the esophagus. You are seeing this membrane protruding, and it's not completely circumferential. Then this is most likely web, and this patient has been having dysphagia. The question gave me MCV less than 80. Then I'm dealing with Plummer-Vinson syndrome. So So if I thought this patient is going to have, anything, do you think this patient is most likely going to have, something like oropharyngeal dysphagia or esophageal dysphagia? Anyone? Do you think this patient is going to have oropharyngeal dysphagia or esophageal dysphagia? Anybody? I don't know if you can hear me. Maybe I was talking to myself. So it's actually, yeah, I get your point, but it's most likely still going because it's at the upper part. upper part. So whatsoever that is accumulating there that cannot, it can easily spill away. Spill into the airway. So that's just by the way. Just for you to understand the reason why they talk about the fluoroscopic evaluation. All right, so that's just by the way. Please just note which we call modified barium swallow. So how are we going to treat it? Dye. You now write dye. Dysphagia, iron deficiency anemia, esophageal web. So if this patient is having iron deficiency, you give the patient iron to replete the iron. Can you see? So iron repletion, rapid resolution of the dysphagia in some patients may help. For all you care, that might just be. So if I thought the esophageal web is that bad, esophageal dilation again, then the next thing you do is annual upper GI with biopsy, endoscopy with biopsy. You still do the same thing for the ring. Now let me show you something here. If you remember the diagram, this is the esophagus. The upper part of it you have the web, the lower part of it you have the ring. The kind of cancer you see around the lower part of the esophagus is what? What kind of cancer do you have here? Adenocarcinoma. Why the upper part? What kind of cancer do you have here? Squamous cell carcinoma. Exactly. So if I thought you are doing biopsy, just to be sure that this patient does not develop squamous cell for the web, if it's the ring, does not develop adenocarcinoma. So now this is a key fact you want to focus on. Esophageal web, they are like ring, but they are non-circumferential and are associated with different conditions like Plummer-Finson syndrome. Esophageal web are often ruptured during endoscopy and do not cause recurrent or refractory symptoms. So when they are even doing the normal endoscopy, they can, if at all anyone is there, it can be ruptured. So that's just by the way, key fact. So in this key fact, focus on the fact that it is non-circumferential. Then we are done with this. You see, we are done with the ring. We are done with the one that is associated with the web. Let's look at distal esophageal spasm. Distal esophageal spasm. All right, distal esophageal spasm. It's actually a motility disorder. It's a motility disorder. So what are you going to see in question that will give it out? This distal esophageal spasm. You see episodic retrosternal pain that is precipitated by emotional stress, hot or cold liquid in question. So any of these might be emotional stress, it might be hot or cold liquid. That when the patient takes hot liquid, that's when the patient have the retrosternal pain. So the cold liquid that you are going to see. So I now want you to look at and see what I put here. So often precipitated by injection of hot or cold liquid. So they did not put the emotional stress. Emotional stress is there and is relieved by nitroglycerin. So when you give the patient nitroglycerin, the smooth muscle here will relax and the patient will be better. All right. So how are you going to make the diagnosis? So for now, we have a sequence. Now, in the USMLE exam, it's not about stuff. It's about the order. What do you do first? That's why, they have all manner of, I don't know the name they call those charts, where you say after this one is done, you now go to this, you now check for this. It's order. That's why if someone can master the order, you realize that it will just be, even if they list all the possible options you've ever seen on that concept before, you will still know which one you do first. So it's the order. So this is the order we will be following here. Barium swallow, EGDB, then manometry. So you can look at it as BEM. Barium swallow, EGD, manometry. So now if the question asks that what do you want to do now, what's the best next step? So what you will be thinking about will be, have you done barium swallow for this patient? So you do barium swallow. And this is the reason. Anytime you see someone having dysphagia, basically, or someone having pain that's related to the esophagus, let me put it like that. Before you go and put your scope, you want to do barium swallow. You want to ensure that you do barium swallow. So it's more like an initial test, but most time, the way they frame the question, you will know whether how come you are not mentioning barium swallow here. So this is more or less like the initial test you want to put at the back of your mind, barium swallow. So that if I thought there is a reason not to put the scope, you will see it. You will know that, I can't put the scope here. I will puncture the esophagus. So this is BEM, order. This is the order you must note. So EGD with biopsy. So but before you do the EGD, you do the barium swallow. So most accurate test you want to do, manometry. Shakener, can you see? Most accurate test, manometry. What do you want to do before the barium swallow? So but this is the one at the middle you do before you do the manometry. And that's the diagnosis. So now, how do you want to treat it? But before I mention, so when you do the barium swallow, what do you see? You see this. Now you need to be very careful before you see this and you start shouting, eosinophilic, eosinophilic, eosinophilic. No, this cannot be a eosinophilic, because this is episodic. It comes and it goes. The one you see in eosinophilic is not episodic. So you can see the corkscrew appearance you are seeing here. Can you see? Corkscrew. Apparently that corkscrew we normally use to open wine for those that drink wine. But people like us that don't drink wine for now. So we use our hand. So that corkscrew, that's what you see there. So that's that. So with the manometry, when it is done, you just realize that the pressure around this lower part here is very high. Can you see? This middle part, lower part is very high. So once you see that, just be like, okay, this is looking more like distal esophageal spasm, DES. Does this affect the sphincter? No. It doesn't affect the sphincter. All right. So we are done. Look at the treatment. What do I want to take into the exam? This is the one you are taking into the exam. Calcium channel blocker, 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 calcium channel blocker. Symptomatic relief. Unless there is a reason why the patient cannot take calcium channel blocker. But this is the first one you think about. So if that's not there, you go for TCA. If that's not there, you go for nitrate. So calcium channel blocker. For instance, if it's very, very severe, and this calcium channel blocker does not help, so you now go for this POEM, Pahora endoscopy myotomy. And we are done with that. Can you see? So if I want to show you something here now, let me show you this picture. Esophageal pathology 1. So they give you something like this in the exam. Just give you something like this. You're just like, okay, I'm seeing some contraction here. Can you see? So like spasm at the lower part of the esophagus. Be like, hope I'm not dealing with distal esophageal spasm. Just by looking at the question alone, you already have an idea. I mean the diagram alone. So you now see, they now read the question, non-existent substernal chest pain, intermittent dysphagia. You say, Now, which one of the following approach is most appropriate to treat this patient symptom? So the answer you'll be thinking about will be calcium channel blocker. So your answer here will be calcium channel. If that's not there, TCA. If that's not there, nitrate. So if they now say they've done that, it's very severe, blah blah blah, and like you now go for poem, but poem is not even there. Yeah. What are they testing here? Just the pathology, simultaneous multi-peak contraction of the esophagia on esophageal manometry. So I will show you that. I'll show you that later. So that's what you see on the manometer. Though they do not give us any diagram here. So and that's that. Just see multi-peak because that distal part, all of them they are contracting at the same time. All right, so that's just that about the DES. What about achalasia? Achalasia. So for the achalasia, it is what all of us here know. If I ask us now that, what are we going to say? So for those that are not specialists amongst us, be like, okay, I know I've heard about bed beak. I know I've seen that when they give me this social area will be dilated, blah blah blah, and the like. So that's more than enough. But there is something that will quickly draw you closer to achalasia in the exam. This word, if it's going to be by cramming, you cram them. If it's going to be by noting, rehearsing, make joke. You need to lighten your head and make jokes a lot. Joke around it. Progressive dysphagia to solid and liquid. Not to solid, then to liquid. No. It's to solid and liquid. Not to solid, then to liquid. No. This is to solid and liquid. All right, so that's what you note. You see that question we just say, initially, this is someone, can you see? 56-year-old woman comes to the physician because of a 6-month history of difficulty swallowing food. Initially, only solid food was problematic, but liquid have also become more difficult. In this kind of question, you may not even need to read it finish. Just be like, I hope I'm not even dealing with achalasia. Just be like, let me assume that you have 10 or 15 seconds left for this question. Just read the beginning. Just say achalasia. You just check the option. Now look at which of the following is the most appropriate next step that you want to. We'll look at all those stuffs. So you can quickly trace, but you know where you are going to. You already know the pathology. Let me even assume that the question is all about diagnosis. You just say this achalasia. That progressive from solid and liquid. All right. So now the next thing we are expecting is what is even the pathology itself. So they have impaired relaxation of the lower esophageal sphincter and loss of peristalsis in the distal two-thirds of the esophagus. Festus, relax. Relax. This has something to do with esophageal sphincter. It's not relaxing. This has nothing to do with esophageal sphincter. So esophageal sphincter pressure here is normal. Esophageal sphincter pressure here is going to be very high. So when they give you this kind of graph and you look at the lower esophageal sphincter pressure for achalasia is going to be very high. Can you see? When the food eventually gets to that area, the pressure there is high. Can you see? Whereas if you are dealing with DES, the pressure in the lower esophageal sphincter pressure is not high. All right. So the next thing you are expecting them to ask is, what is responsible for that inability to or impair relaxation of the lower esophageal sphincter? What is even causing it, Ganself? And now say degeneration of inhibitory neuron in the myenteric plexus. This is the next one you are expecting. What is causing it? What is causing it? Degeneration of the inhibitory neuron in the myenteric plexus. So we are done with this. So we've seen the way the patient will present progressive dysphagia, solid and liquid. So please never forget that. Okay. So you now see this picture. This is the one for achalasia. Can you see it cannot relax? So can you see the way the thing is sealed up? So it now produce this narrowed lumen that when you look at it, sometimes it look like the beak of a bird. Can you see beak of a bird? So you call that bird beak. Why this other area, dilated one, is looking more like the head and neck of the bird. So this is the beak. So this is bird beak appearance. All right. So they give the patient the barium to swallow, and this is what you see. The barium is settled there, while it's trickling down. Can you see? That's what is giving all that narrowed appearance, and that's what these are all food substances. So now the thing about these food substances is that they can start creating all manner of irritation to the esophagus, blah blah blah, and the likes, and they can even spill to the airway if it's that bad. So that's just that, anyways. So that's why you have regurgitation of undigested food. Regurgitation. Then weight loss. If the food is not going down, the patient will start losing weight. The patient will start coughing and the likes. So let's look at the diagnosis here. Now here, the best initial test is EGD. Is endoscopy. The best initial test here is going to be endoscopy. After that, you now go and do manometry. So it's more or less like you also have barium, but I intentionally just remove that. You know, we say BEM. So this is endoscopy. Normally, before you do endoscopy, you do barium. But the reasonable best initial test here that you want to note and be like, okay, what's even going on is this endoscopy. Then after that, you go for manometry. So manometry is the most accurate test here. Manometry for the distal esophageal spasm is also the most accurate test here. So barium swallow. When do we now do it? When manometry finding are equifocal. Manometry finding is neither here nor there. That's when they are now doing the barium swallow. So that's why I just left it as EGD, from EGD to manometry. So just rehearse it. So you can't go for manometry as your best next step until EGD is done. Unless the question says, which of the following, or what is the most accurate test to help with diagnosis? Your answer will be manometry. Because the question specifically asks you what you need to make the diagnosis. Manometry. So we are done. I've mentioned something here. So we are done with this. So what about the treatment? Now, what is the treatment you want to take into the exam? Like this area, you need to rehearse it with your colleague when you are in your tutorial. Like, rehearse it like that is the expo. Just be intentional about it. Rehearse it. Like, you see, you can sit down alone without joining any tutorial and read for USMLE if you understand the trick. Sit down. Pick one material. One. Don't be having 5. I don't know. You are not a professor that combines it. Just pick one and read it. The outcome is most likely going to be high. One material that is very important. So this is the definitive now treatment. See, The treatment you are looking for, there are 3 they are going to put in the option. So let me put it like this. The first one is, for the definitive, is Ella myotomy, POEM, which is paraoral endoscopic myotomy, and the less often one, pneumatic dilation. Do you get it? Pneumatic dilation. All right. If you look at these guys, these are surgery, more or less like a procedure. So these 3 are procedure. We now have another one. You call it botulinum toxin. Are you sleeping or you are awake? Let me even be sure that are we awake or we are sleeping small?
Awake.
Awake.
It's only Dr. Taufik that is awake. You see, Dr. Kweme. Dr. Kweme, you are sleeping there. All right. So now, when you get a rehearse it, you just say in your head, you just say surgery or botulinum toxin. Now, you now check that question. If the question is talking about older patients, you don't do surgery. You rather go for botulinum toxin, or the patient has comorbidity. So this kind of patient that are older or have comorbidity, they are most likely to develop a lot of complication from the surgery. You don't want that. Just do botulinum toxin injection, it will help. But if you are dealing with younger patient that does not have any comorbidity, you go for surgery. Either HeLa, POEM, or pneumatic dilation. That's all. So now, in the exam, the question is given. This person is shouting, this is what do you call it? Ecalesia. What did you now choose? HeLa procedure. You just look down. That's why some people will go into the exam and come and be like, I was asked a question on ecalesia, and the answer is just HeLa procedure. Another person will go into the exam and just pick that blindly. That's why the score will not really be that different. So in the exam, what you look out for, immediately you hear, even if someone gives you that information, you just say thank you. Did they ask you question? You say, okay, I was giving question, or by any way, you shall have the information. Oh, yeah, Kalesia. Oh, that's fine. Just say, oh, that's fine. You now go back and rehearse this. So if you are dealing with older patients, botulinum toxin. If you are dealing with younger patients, you do surgery. Younger patient without comorbidity, you prefer to go for this. All right, and that's that. So, and these are just the 2 you rehearse very well. The others, calcium channel blocker, phosphodiesterase inhibitor, they are just for short-term relief of the symptoms. So nothing to really bother yourself about. All right. So they are only used in patients who are not candidate for definitive treatment and have failed botulinum toxin. So what are these candidates that are not who are these patients that are not candidate for definitive treatment with surgery? They are the older patient or patient with comorbidity. So you don't do surgery for them. You rather go for botulinum toxin. So if botulinum toxin now fail in them, you now come to calcium channel blocker and phosphodiesterase inhibitor. And this is where you are expecting majority of the question. Just this area, just rehearse it. So you just be like, okay, they may give Dr. Kweme older patients and give Dr. Ijeoma younger patients. And we are done. Then we come down to esophageal diverticula. So everybody here knows the diverticula they are most likely talking about, and that is Senka diverticulum. That's the one we want to note very well. Okay, so Senka. Now look at this Senka. I want you to look at this diagram. So this is the diagram. This is the diverticulum. As this patient, this is the weakness or weakened area where my cursor is. You call that weakened area Killian triangle. No one will ask about Killian triangle. It's a step 1 concept. So no one tests that in step 2. No one really asks, they won't ask any question about this thyropharyngeus muscle, this one that they don't really ask that the boundary. That's what I mean. So they don't ask that. But this is just the Senka diverticulum. Is it a true diverticulum or false diverticulum? It's a false diverticulum. The only true diverticulum we have is something like the Merkel, which we'll be looking at in pediatric, and our question on it will come. So this is the diagram. Can you see? So if they do barium swallow, this is how it's going to. Can you see this outpouching? The diagram does not change. Can you see? It's just going to come out like this. All right. So now this patient is coming down with dysphagia. It's coming. I just see dysphagia. What will I see in that question that will bring me closer to Senka diverticulum? So any of these two guys, number one is halitosis. Halitosis. You just see someone is having dysphagia and the patient has halitosis, just go for Senka. If they do not put halitosis there, they will put this patient has been regurgitating undigested food after eating. You are just like, what does that mean? What it means is that when this patient eats, some of the food that was supposed to go down, they branch to enter into this sac. So when the patient is done eating, some of them can now come out. Now be like, I finished eating beans. Where is beans coming from in my mouth? So like the old beans, yeah, like what's going on? So where is beans coming from? I finished eating meat. This is a meat now that is coming to my mouth again. I even thought I finished. So after eating, you now see questions we say that the patient is having some undigested food coming. So can we just mute our mics? Dr. Bukola, please let us mute our mic. Thank you. So you just see the undigested food just coming back into the throat. So once you see that, just be like Senka. These are the two things they will put there. Halitosis or this. They can also put this diagram. They can give you, just see this out pouching. So just see it. So what's the best next step you want to do is just the barium swallow. Never go for endoscopy first. The reason is that if you go and do endoscopy, they are like, oh yeah, pass it. Advance. In the course of you say, I'm experiencing a resistance. Be like, just advance. It might be the sac that the probe is actually inside. So a scope, I wanted to say, it's inside, they can puncture it. So you don't do scope. Yeah. So you want to be you don't just go straight and say, I want to go and do endo. There's nothing to it. So you go for barium swallow. And that's that. So what is history like? You already know. What do you want to do? Barium swallow. That's all you need there. Barium swallow. So what about the treatment? So this is the treatment. Surgical excision. Cricopharyngectomy can help. Or diverticulectomy. So that's the treatment. And you are done. All right. So let's see this last stuff under the GED, so that you have a way of looking at it before we go for another break. So what about GED in the exam? How do you want to be looking at GED? Gastroesophageal reflux disease. So the way we look at it, in fact, everybody here knows already the way we look at GED. You just see this patient can be having heartburn. The patient can be having heartburn. Can you see? The patient can also be having regurgitation after meal. Food will go back. So after meal, food is supposed to go back as we change position, as we bend, as we raise our intra-abdominal pressure. The pressure will be mounted on the stomach, and that should push the food up. So, however, our lower esophageal sphincter is blocking that. So that's why they always advise people to, in a way, sit up after eating. You don't just lie down immediately after eating. All right. So when this patient puts himself in a reclining position, it can even become worsened. And when the patient sit up or stand, or when the patient take antacid, all these heartburn and the like will improve. Then there is something else the patient can also be having, which you know. I'm just reminding you that they are not asking anything here, but what they will put in the story, sore taste, global sensation, unexplained cough, usually at night when they sleep. So morning hoarseness, because the acid has come into the esophagus, has gone into the airway, they can have some hoarseness, and chest pain that can even mimic coronary artery disease. So these are just the symptoms. So when you see an adult having cough more at night when sleeping and the likes, so just know that, hope I'm not dealing with GERD. So that's just GERD for you. GERD. So what is that thing that can also make the lower esophageal sphincter start to relax abnormally like that? So likely you are dealing with scleroderma. Scleroderma will also make it to relax. Can you see? So please never forget, it can also make it to relax like that. Now, so what do you now want to take into the exam? So anytime you see anyone around us, or you read the question, you now see those GERD-like symptoms. What you are actually looking for, don't be carried away by those symptoms, because no one is testing that. No one is testing that. All these bitter taste, asthma-like symptoms of standard burning after meal, worse at night or while lying down. That's not what they want you to bring. They know you know this. So now, when you see the question, you quickly check for some stuffs. You call them alarm symptoms for malignancy. Is this just something mild or malignant? So if it's something benign, you will not see these alarm symptoms there. If it's something malignant, you will see the alarm symptoms there. I call those alarm symptoms BDW. So if you like, call it BMW. That may help, but BDW is what we give it. B here is bleeding. You may say the patient is having hematemesis or melena. D is dysphagia. There is now dysphagia in it. When you sleep, if you don't eat, you eat late, you can have GERD. But are you losing weight? You say no. Are you having dysphagia? You say no. Are you vomiting blood or your stool is dark in color? You say no. Then it's just the normal one. So this is what you check in the exam, because this will modify your option. So if these are not there, then I'll say what is the best next step? Because they are not there, the alarm symptoms are not there. Those alarm symptoms are for malignancy. If they are not there, your answer will be, so it's just ordinary GERD. Your answer will be trial of proton pump inhibitor for 8 weeks. So if you check the same question that Dr. Lagwaja was saying, they gave me question on GERD, then I say, what is the best next step? I just choose endoscopy. I just choose trial of PPI. So you need to know what they were looking for, or what they might have omitted in that question. And that's this BDW: bleeding, dysphagia, weight loss. So if they are there, then you want to go and do endoscopy. During that time that you are doing endoscopy, you do biopsy. So but the answer here will be endoscopy. If they are not there, you just give the patient PPI. So the patient should be fine. So if the patient takes the PPI and the condition improves, you continue the PPI. So if the patient takes the PPI and the condition does not improve, you first of all increase the dose of the PPI. If the condition still does not improve, you now go and do endoscopy. If after increasing the dose, the condition now improves, you just continue with that current dose of the PPI. So it's what you will have done in that small clinic that possibly some of us have. You just see, the next thing is, are you having dysphagia? Are you having bleeding? Are you having weight loss? So you now say, no, I'm not bleeding, I'm not vomiting blood, I'm not having this. Your stool is a normal color. Are you having weight loss? You say, I'm not having weight loss. So immediately you see that all those stuffs are not there. The answer is PPI. They are there. The answer is endoscopy. Because likely you are dealing with malignancy, adenocarcinoma. So are we going to make the diagnosis? It's clinical. The most accurate test to do is what we call 24 hours pH monitoring with impedance. So if at all, you know when you go and do endoscopy. Can you see? You know when to go and do endoscopy from what? If you are seeing bleeding, you are seeing weight loss, you are seeing what dysphagia, or the patient has been taking PPI and the patient is not having improvement. So that moment is when you go for this endoscopy. So, but in the exam, what's the most accurate test you want to do? The answer is 24 hours pH monitoring with impedance. Just sit down and rehearse them and be fine. Like you yourself will know that, because this is just normal practice, not just someone cramming something somewhere. Because if you do it very well, you realize that you have the basic understanding of so many things. Even if you forget and you carry your book again, you rehearse it will make a lot of sense. And if you go to step 3, like it just look like a child's play, because the knowledge is there. You won't be struggling with it again. And that's all. So these are the alarm symptoms I told you all about: hematemesis, weight loss, dysphagia, chest pain. Okay. So GERD can mimic angina or MI. GERD is not a result of presence of H. pylori. GERD arises from a transient relaxation of the lower esophageal sphincter. So what is now the treatment? We've looked at the treatment already, what you want to do. So don't forget. So all patients, weight loss, modification, lifestyle modification, edge of bed elevation, if normal people have it, and just all patients, small meal, they shouldn't be eating meal late at night, so they should avoid alcohol, just normal thing. So initial empirical treatment, if there is no all those alarm symptoms, you go for what? 8 weeks of PPI. If there are alarm symptoms, then you need to go and do endoscopy. And that's that. Now, prolonged use of endoscopy, what can it cause? It's going to can cause what we call what? Vitamin B12 deficiency. Do we all agree with vitamin B12 deficiency as a consequence of prolonged use of PPI, everyone? Do we agree with them? Vitamin B12 deficiency. Yeah. So
Yes.
Exactly. So if they bring it out, you don't say I don't know where it's coming from. Because if the thing is blocking the proton from being pumped, it's also going to block the intrinsic factor. So that is important in vitamin B12 absorption. All right. So we are done. If you look at it, look naughty, but you already have an idea of what you are looking for in the question. Just rehearse this. Ask your friend. When you see a GERD question, what will you see? You say bitter taste, this was that nice. When the patient like that, you say, okay, GERD. So what will you now look for? You say, I'll quickly look for alarm symptoms. What are they? Bleeding, dysphagia, weight loss. So if they are there, what will you do? You say, I'll go endoscopy straight. If they are not there, I'll give the patient PPI. That's all. Can you see? You are done? Easy, straightforward. That's what they've been asking. All right. So what are the complications of GERD? What are the complications of GERD that we want to take into the exam? All right. The complication of GERD, if I ask all of us now, we will all mention them. So, but never forget erosive esophagitis, then esophageal peptic stricture. These two guys, don't forget them all. Aspiration pneumonia, you agree, because they can aspirate at night. If the thing continues unchecked, so like now having bleeding, dysphagia, weight loss, and the likes, you go for Barrett esophagus, then adenocarcinoma. So likely the patient is having some malignant features. So now this is the management of Barrett esophagus. So whatsoever PPI that the patient might have been taking before, you just optimize it, because it's just Barrett anyway. So it's a dysplastic lesion. All right. So if at all there is no dysplasia, you can repeat the endoscopy every 3 to 5 years. If there is indefinite dysplasia, repeat endoscopy in 2 to 6 months. If there is dysplasia, treat with endoscopic eradication straight up. So you may just realize, if you can pick it, fine. If you can't pick it, you can drop it. So, and that's that. So let me allow us to go for 20 minutes break. We meet in the next 20 minutes. So just move around and we come back and do something again. So, all right. So we continue from where we stop. So as I was saying, just look at them simply. That's why I'm not rushing, so that you get the point. And it's not about showing off here, but just for us to pick one or 2 points and note them and be like, just rehearse this, or else we just keep on just walking and walking, and it now look like it's difficult because we've not really taken our time to master what we are supposed to master. And the best way is you can even face the mirror by yourself, and the next thing is, oh, if they ask me question on this, this is what they are most likely going to put. They will now say this, I will now look for this, I will now look for this. You can open your first aid down before you, and you will just be pointing at, oh, this is aorta hernia, this is how this is going to come. Never forget this, never forget this, never forget this. Like 3 points or 4 points, you're okay. So you just realize that, wow, this makes sense compared to you now thinking that because if you solve 300 questions you automatically become authority in it, or you've already mastered what they will ask. That's a lie. You need to note the point, so that anyhow they twist the question, you will still be able to reason it out because you have what we call the foundational knowledge. So let's look at the aorta hernia. So this is all about the stomach herniating through the diaphragm. So that's aorta herniation or aorta hernia for us. So that's just by the way. So we have the types. We have types of like 4 basic type of aorta hernia that you want to note. The first one is sliding aorta hernia, and this is the commonest. Please, I want you to pay attention to me very well so that you will know what they will test and how it will be tested. So this is the commonest one. Like 95% of cases, they are related to this type 1. Is the sliding aorta hernia. So if it's sliding, what is sliding? You just have the gastroesophageal junction and also the gastric cardiac. So this is the gastric cardiac. Let me try to show you this image. So this is the type 1. Can you see? You can see this gastroesophageal junction. So can you see it? And the gastric cardiac, just like this area here. So they are actually herniating upward. That's all. So they are herniating upward. So if you compare it with the others, you realize that this is actually quite different. So the fundus, this is the fundus of the stomach, is not involved. All right. So that's just the type 1. And this is the one USMLE step 2. We test this one. Most likely to test. Most likely to test this type 1 because it's the commonest. The next one they are likely to test is this type 2. So the type 2 is paraesophageal, which is what we know from step 1. So what you have here is the part of the gastric fundus we herniate into the thorax. So part of the gastric fundus, this area, is going to herniate there. So what about the gastroesophageal junction? It will not move. It will remain in its anatomical site. So type 1 is the sliding. This area will move superiorly. In fact, more than 2 centimeters above the diaphragmatic hiatus. So then the gastric cardiac, just this area that is abutting this gastroesophageal junction, is also going to move. You can see the gastric cardiac now moving too. That's for type 1. So what of type 2? Paraesophageal, you have the gastric fundus. It's actually what is herniating. Now, in the exam, they know you know it. They're not going to say, okay, the patient has, with further evaluation, they realize that the gastric fundus herniates. Once you see that, this cannot be type 1. So it cannot be sliding no matter how you look at it. Then the gastroesophageal junction will remain intact. Can you see it's remain where it's supposed to be? So we are done with the type 2. What about the type 3? Type 3 is when you see the mixture of the two. So if you look at this picture, you can see the gastroesophageal junction has moved, cardiac has moved, fundus has moved. It's just the mixture of what you have there. So, and that's that. What of type 4? Type 4 is complex. So when you start seeing another abdominal structure alienating together with it, that's type 4. It may be the spleen, it may be the colon, that's type 4. It's very rare. So you are not expecting question on type 4. So you are expecting question on type 1 mostly, type 2, and type 3. So why did I mention type 3? Because in that question, if you are not very careful, you will not know it's actually type 3 because they will not mention the type. And they may mention the type. So this is 1, this is 2, this is 3. And that's for the types. All right, what are we going to see in the question that will tell us that this is aorta hernia? So most time you will see them mention this air fluid level behind the cardiac silhouette. I just say air fluid level behind cardiac silhouette question. So just say, okay, they do x-ray, they are seeing air fluid level behind the cardiac. Once you see that, you'll be like, I'm most likely dealing with aorta hernia. So, and that's just by the way. And that's just by the way what you want to put at the back of your mind. So it doesn't mean that's what you should see compulsorily in all of them. So, but this is a very good clincher towards aorta hernia in the question. So now, thank you, Festus, for your autotonu. So what are we now expecting them to ask in the exam? All right. So basically, the treatment, how do we want to treat? If you are dealing with type 1, which is sliding, you just check the question, is this patient symptomatic or asymptomatic, irrespective of how the thing is discovered. So if the patient is symptomatic, it says symptomatic, no treatment, you just reassure. So however, if the patient is symptomatic, no matter how little the symptom may be, so you go for conservative management. That's your answer. Conservative management. So when you say conservative management, what do we mean? We mean lifestyle modification, proton pump, inhibitor, and the like. So that's what you are going to go for. Lifestyle modification. So what are these lifestyle modification? All right. So what are these lifestyle modifications? One of them is weight loss. I just tell the patient and just be like, okay, try to lose some weight, this, that, and the like. That's for type 1. We have to do it like this. So type 1, just then proton, place the patient on PPI if the patient is symptomatic. What about type 2, 3, and 4? Once you see 2, paraesophageal in the exam, or talk about the mix or the complex one, the answer, if the patient is asymptomatic, you still do conservative management. Despite the fact that it is type 2, 3, and 4, you do conservative management and watchful waiting. How are they going to test this watchful waiting in the exam? So most likely be like, okay, and follow up the patient. Follow up the patient. So that is for asymptomatic. Whereas for type 1, which is sliding, no treatment when the patient is asymptomatic. So if the patient is type 1 is symptomatic, conservative. If the patient is type 2, 3, and 4 is symptomatic, you go for surgery. Your answer here will be surgery. And that's how. Sorry, 1 minute. All right. So that's surgery. Surgery 2. So paraesophageal, mixture, surgery. And the complex one, surgery. So I think someone wanted to ask something. Dr. Kafo,
Okay, thank you very much. I just wanted to ask, sorry to for this question. This type 4, I'm not 100% sure of what it is. I know about 1, 2, 3.
Okay, the type 4 is when you are seeing another organ in the abdomen. Yes, urinating together with it. So it may be a spleen that we are talking about here. So that's why it's very rare. So you are not even expecting them to test that in the exam. So but just for you to know that, okay, I know the type 1, I know the type 2, I know the type 3, I know about the type 4. So you just see one organ also urinating together with it. But once you see part of esophagus, you see, and some of us will not appreciate this information now until you get into the exam, because you just realize that they will just give the question. So you are like, okay, yeah, the gastroesophageal junction is actually intact, it does not move, or blah 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 and the likes. You now say, what is the best next step here? And this is question about treatment. So best next step here: A, reassure; B, lifestyle modification; C, surgery. Can you see? And the like. Once you realize that this is paraesophageal as son, just go for surgery. So surgery, paraesophageal surgery. So paraesophageal hernia, surgical gastropexis to prevent gastric volvulus in some cases. So, and that's that. Easy and straightforward. Okay, so let's look at the esophageal cancer. So sorry. So let me see. So these are the questions you will solve. So you read them one by one. You pick your answer. This one, reassurance and observation. You will know why is this reassurance and observation. So you'll be able to know, okay, what's going on here. So this is a procedure which is actually a surgical procedure. You call it anti-reflux procedure. So because they can actually have reflux. So this definitely is most likely to be related to maybe type 2 or type 3 or type 4 for all you care. So the same thing here. This is reassure the patient and follow up. Can you see how they are bringing all those jargons out? All right, so that's just by the way. Dr. Kweme.
Okay, you have actually existed the place. I just wanted to screenshot the first one. Thank you, sir.
Why are you screenshotting the Dr. Kweme? All right. So let me show you so you can screenshot it. So are you done screenshotting?
Thank you, sir.
You're welcome, sir. All right, so that's that. So let's look at esophageal cancer now. Now, if you look at what we did on achalasia, we mentioned a point. So the dysphagia they have in achalasia, is it to solid then to liquid, or to both solid and liquid, or which of them? Who remembers?
Achalasia is both solid and liquid.
Solid to liquid.
Solid and liquid. That makes sense. So that's actually what you'll be looking for in. Can you hear my voice? That's what you'll be looking for in the exam. Can you hear my voice?
Yes.
All right. So that's what you. So now, if you now get into the exam, you now see initially to solid, then to liquid. So you are most likely dealing with esophageal cancer. So this statement alone will help in this exam. So for the authority in the field, that means us. We know you may have maybe other things you think about, but that's fine. But this exam, when you read that long question, right from the beginning, you look at the question, you are seeing 10 lines, 15 lines. You now check the question, the beginning. And now see, this patient has been having dysphagia initially to solid, then to liquid. Once you see that, just say, most likely I'm dealing with cancer here. You now quickly trace any weight loss. You quickly trace any this, any that. So that's that. So this is very high yield. This is the statement that will help you to quickly know if you are dealing with esophageal cancer. So what about the risk factor? Okay, before that, what are the examples? We have the squamous cell carcinoma, we have the adenocarcinoma. So squamous cell, worldwide. So this is the commonest worldwide. In the United States, USA, so the adenocarcinoma, USA, adenocarcinoma. So this is the commoner one. All right, so please never forget this. What are the risk factor? The risk factor you will choose depends on which one you are dealing with. So if you are dealing with squamous, because the squamous is related to the upper part of the esophagus. So this is the squamous. So you'll be thinking towards anything that can affect the upper part. Hot tea, smoking, alcohol, this nitrosamine, this one that, so just related to the upper part, because the upper part will be the one that will first of all be exposed to them. So that is going to, they will be all be a risk factor to for squamous cell carcinoma. For adeno, this is related to something like the gastric acid coming here. So this one is whatsoever the patient is ingesting here. So here now, for the squamous cell, don't forget hot tea, hot that, hot this one, alcohol, tobacco, nitrosamine. You shall look at them here. So for the adeno, they all be related to gastric acid palaver. So something like GERD that is not controlled, Barrett esophagus, this one, that one. So they will all be related to the adenocarcinoma. All right. So squamous cell carcinoma of the esophagus tend to occur in the upper and middle third of the esophagus, whereas adenocarcinoma occur in the lower third. So how will they present? Progressive dysphagia, initially to solid and later to liquid. So then, apart from that, you will now start seeing all this weight loss. Can you see? You will be seeing something related to cancer, bleeding. Can you see? Bleeding, dysphagia. So something that will take GERD from ordinary GERD to the Mr. Legendary GERD. So weight loss, bleeding, dysphagia. Once you see that, be like, I'm dealing with cancer. All right. So what's now the best initial test? Best next step? Endoscopy. Don't forget, when you see GERD and you're seeing those alarm symptoms, just say endoscopy. When you do the endoscopy, you see and you take the biopsy. All right. So after the endoscopy, they've done it. So that's the initial and the most accurate test, endoscopy. Don't forget that. Anytime they are done diagnosing and they say what's the best next step for cancer, is just to look for metastasis. So never forget this fact in the exam. So once you look at the question, they've done endoscopy, what's now the best next step? You now be looking for something they can use for metastasis or for staging. So, and that is something like CT or endoscopic ultrasound. There is no radiologic test. No radiologic test can diagnose esophageal cancer. Diagnosis can be made with the tissue biopsy. Then esophageal cancer metastasizing early because the esophagus lack a serosal. So what's now the treatment? Treatment, basically, chemotherapy and surgical resection. Can you see? Chemotherapy and surgical resection. So if there is metastatic disease that is considered incurable, systemic therapy alone is used. You don't need to go and do surgical resection. So you just leave the patient alone because it has already metastasized. So, but the best initial treatment is chemotherapy, chemoradiation and surgical resection. All right, so that's that. Look at this fact. Resection is required for esophageal cancer treatment to be curative. So when you look at it and realize that it's not curative, it's not likely to be cured because it has gone everywhere. No need of doing resection. You cross it. You don't pick that. All right. Then we are done with that. Gastrointestinal bleeding now. GI bleeding. So GI bleeding is not what we don't know. Trust me. Like, if we say GI bleeding, the authority here, from our medical training, we all have an idea of what do you call it, the GI bleeding look like, the upper, the lower, how they divide it into upper and lower using ligament of Trex. So the upper GI bleeding, so hematemesis, the patient can present with hematemesis because it's coming from above. So when the blood is, some of them are trickling down, they can mix with the fluid acid, from acid to all manner of fluid secretions. So mixed with the stool, and they become black. So the stool will look darkish. So, and if I thought it's heavy enough, so that can surpass the volume of whatsoever secretion, so some of them will come out like the way normal blood will look, so hematochezia. So depending on the volume, anyways. So hypovolemia. So when the patient is bleeding continuously like that, they are becoming hypovolemic. You will see sympathetic nervous system will be activated. That's just for you to see the way the patient will present. So the patient can now be having lightheadedness, tachycardia, hypotension, blah blah blah, and the likes. So now, what is the diagnosis? How do you make the diagnosis? Rather, nasogastric tube, lavage, then endoscopy is definitive. So this, we have so many causes. PUD is the commonest cause. We are going to look at all the basic causes of upper GI bleeding one by one. All right, so we'll look at them one by one, don't worry. So let's pick the upper GI bleeding now. The first one is esophageal and gastric varices. There is no one here that will say that I don't know esophageal or gastric varices. Like, it's a lie. I don't know it. It's a lie. You know it. So now let us just mention what they will test and how they will test. You now see that they are quite reasonable. And it's the same thing you will have done. So what is causing the bleeding for the esophageal varices and the gastric varices is just from increase in portal pressure. So what can cause increase in portal pressure? Likely we are dealing with a patient with liver cirrhosis, that all those what do you call it, fibrosis has been laid down by the stellate cell, and they've actually caused what do you call his name? They've actually caused all those vessels to be narrowed. So basically, so the portal vessel cannot drain through the liver. So as a result, there will be increase in pressure within the portal vessel because they can drain down. So and that's going to cause portal hypertension. So there will be a portal hypertension. So, and that's that. All right, now most of the question in the exam will revolve around the treatment, and I want you to pay attention to the way they test it. So how will the history go? This is someone with liver cirrhosis that is now having bleeding, that is having this, that is having that. That's how the question will go. So if the patient is already bleeding, like vomiting blood or shitting blood, having bleeding, so you check the question, this is liver cirrhosis, you start thinking towards maybe you are dealing with varices. So now, so what do you want to do? Now, this is how you look at whatsoever you are going to do. Come me 1 minute. So this is how you look at whatsoever you are going to do. It's also the order. So when we meet in January, you will see, for those that will be with us, I will ask you, bring out your pen and paper. It's not out of audacity, but just to make you pass through the process of getting used to them. So you are going to write down RAS, R-A-A, or R-A-A, or RAO, anyhow, just this mnemonic. So the first thing is resuscitation. So when you get into exam, a patient with liver cirrhosis, vomiting blood, now say, what is the best next step? The best next step is resuscitation. So, but they won't put resuscitation there. The best next step is site 2 wide bore cannula and give the patient fluid. Resuscitate. They may not ask anything about antibiotic, ultra-tight, those big things you know. They may not ask anything about ligation, those big things you know. They may not ask anything about those tip, all those things we know, you know. They may not ask anything. All the question might just be around resuscitation, because that's what will determine whether the patient will live or die. Resuscitation. Because if you don't know it's resuscitation, you will see a patient vomiting blood, and the next thing that doctor, because the person did USMLE, will be shouting, hook tight. So that's wrong. So you go for resuscitation. So 2 wide bore. Now let me set another question there. This is someone vomiting blood. The patient has come, they've cited 1 cannula, or the patient come vomiting blood with 1 cannula, blah blah blah. Now, what's the best next step? This answer will be cite another cannula. He says cite another cannula. They are like, doctor, Dr. Canola, he say, or Dr. Kanuri, he say, yes. He say, because that is what we need to save this patient first. Resuscitation. 2 wide bore cannula and give the patient fluid. And that's what we normally do. But because it's USMLE, we think they won't ask that. And that's what they test to. So the second question, third question here is that the patient comes with bleeding, vomiting blood, having liver cirrhosis, this, that, and the likes. So the patient is already has cannula, they are already giving fluid. What is the best next step? The best next step there will be antibiotic. The best next step will be antibiotic. Oh, which antibiotic? Ceftriaxone. 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 So what are you trying to prevent? You are just trying to prevent something like this spontaneous bacterial peritonitis. Infection. So this is it, antibiotic. Just like a shot. So another question number 4. Patient come vomiting, vomiting blood, having liver cirrhosis, having this, coming with 2 wide bore cannula, already having fluid. Ceftriaxone has been given. What is the best next step? The answer is give this patient octreotide. Give this patient octreotide. All right, so that's somatostatin analog. So give this patient octreotide. That's it. All right, let us set another one. Question number 5. Are you with me? Are you getting it? Or I'm just talking to myself? Are you getting it actually?
Yes. Yes.
Lovely. So now let's set another one. This patient is coming with liver cirrhosis, vomiting blood, blah, 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 and the like. The patient has 2 wide bore cannula, has already received fluid. Ceftriaxone has been given, octreotide has been given. What is the best? And the patient is still vomiting blood. What is the best next step? Now, best next step there will now depend on, you've done the major thing. Is this patient conscious? You assess for consciousness. So you now check that question. Is this patient conscious? If the question says the patient is already losing consciousness, so the answer will be intubate. It's already having reduced level of consciousness. Your answer will be intubate. If the question says you check, you can't see any altered consciousness in the patient, your answer will be endoscopic pharyngeal ligation, because the patient is still vomiting blood. So the definitive treatment that you want to give to the patient, the last resort, will be the tips. So we are going to look at it very soon. So, and that's that about the treatment. So you just, when you get here, take a sheet of paper, write it down, rehearse it, say it. You will get so used to it to the point that the clinical judgment and practice it will show when you are practicing in the United States, because they know that that person knows it. It's not that someone is writing mnemonic down when you are rotating through a field. You have it at the back of your mind. So now, the next thing is this. If you look at this question I set for you here, the patient has already presented with bleeding. The patient is already vomiting blood, having bleeding. So now, all the ligation you are doing here, they are just secondary prevention of the bleeding, because in this patient, the possibility of, recurrence of the bleeding is very high. So now, what if the patient comes and the patient has not even started bleeding? And the question is like, which drug could have prevented this in this patient? What is this? That this is the vomiting the patient was having hematemesis. Your answer is beta blocker. The answer is beta blocker. So beta blocker actually reduces the risk of bleeding. This is the second question you are expecting in the exam. So that's the second question you are expecting in the exam. All right. So which beta blocker do you want to pick? Propranolol and nadolol. They are only going to, for those that did step 1 with us, we really dissect it very well. So beta blocker, you have 2 major receptors on the vessel, alpha 1 and the beta 2. All right, so this is the vessel. You have alpha 1 on it. You also have beta 2 on it. So alpha 1 will cause vasoconstriction, beta 2 will cause it to dilate. So if you block any one, the other one will supersede. So you give this patient beta blocker, so that is blocking the beta 2, then alpha 1 will supersede. Then the next thing you see is vasoconstriction. And that's where the vasoconstriction is coming from. All right, we also have another one, cafedilol. In the exam, when will you know when to go for propranolol and nadolol compared to cafedilol? Okay, how will you even remember? If you look at this cafedilol, it starts with letter C. See where the letter C is here. Look at propranolol and nadolol. They are still closer to themselves. They are still closer to themselves. Far away from letter C. So this one is in a group. This other two is in another group. This cafedilol, you use it in if the patient is having compensated liver cirrhosis. You use nadolol, propranolol if the patient is having decompensated liver cirrhosis. What do we mean by compensated? All these encephalopathy, jaundice, ascites, they are not there. It shows that it's compensated. If they are all there, this is decompensated. The reason why you just need to note this is that you know the answer is beta blocker. You now check the options. You are now seeing all manner of beta blocker there. You are now like, which one do I pick here? So definitely, you just need to check the question and be. If you see cafedilol, nadolol, propan, just quickly check the question for, is this compensated or not compensated? If it's compensated, cafedilol. If it's not compensated, you go for N and P. Now, look at all these beta blocker. They are non-cardioselective. They should actually be non-cardioselective. So you think about it. You now get into exam. You know the answer is beta blocker. They now give you metoprolol. You now say, it's beta blocker. All because you do not know the mechanism behind the usage of the drug. If you go for metoprolol, that would be wrong. Because metoprolol has no beta 2 effect. It is cardioselective. Atenolol has no beta 2 effect. It is cardioselective. Bisoprolol has no beta 2 effect. It is cardioselective. So that's about this. So any beta blocker they are writing, you know the judgment. You have your judgment with you. And that's that. Then we are done with this area. So look at this. Key facts. Although upper GI endoscopy may confirm the diagnosis in acute upper GI bleeding, the best initial step is to stabilize the patient hemodynamically with fluid and transfusion and ensure the airway is protected. And that's what, once you see it in the key fact like that, that's the concept they are going to test. So we come down to Mallory-Weiss tear. Mallory-Weiss tear. So definitely this patient must have been retching forcefully or vomiting. And this patient is now having a tear. A tear is now having a longitudinal tear or intramural laceration of the esophagus. So this will cause the bleeding. Now, where is the bleeding coming from? The bleeding is coming from the submucosa. What did we tear? We tear the mucosa. You tear the mucosa away that extend into the submucosa. The reason why I'm saying this is that you are going into the exam and now say what happened. There is a tear in this. There is a tear. If you just know that you have torn the mucosa that has extended to the submucosa all by this first retching or vomiting. So if that is the case in the exam, just find your way. So that's that. All right. What could have caused it? You just put it in question. Bulimia is very common in exam. Alcohol use disorder. So just be retching. Excessive retching, So, how do we diagnose? You don't even need abracadabra here, endoscopy basically. Because how will you see the tear if not through endoscopy? So endoscopy. All right. So if at all is bad, you may need to give the patient fluid. Just the normal way of treating the patient with shock. So you may need to give the patient fluid. So that's that. What about BOHAV? Everybody here has read about BOHAV before. You know it. So Mallory Waste, you have how many questions here? Two basic questions to solve. Can you see? All right. So BOHAV syndrome. There is no one here that will say I've never heard about BOHAV. Maybe the person did not write step 1. So that's just for you to see that it's quite common. So BOHAV. So what is BOHAV? Rupture of the esophagus. In the exam, it's not a syndromic exam. So you hardly see them test and it's BOHAV syndrome. No. The own is just to give the story that portray it. And that's what has happened. So in BOHAV, what we have is transmural rupture. So we have the transmural rupture of the esophagus. So if it's transmural, so it's cut it through. In the esophagus, air can flow through it. We swallow air. So air is going to escape into the, what do you call it? Into the mediastinum, can escape everywhere. So just something like that. So anyhow, the question comes. So you just be like, okay, this is what's going on. So if the hair is escaped, can go under the skin, you see crepitus. So this crepitus is the word that we give it out in the exam. Just say the patient has been vomiting, has been having this, now have, on examination, they see crepitus or crunching sound when they palpate the chest, when they palpate the, just be like, no. This patient has torn the esophagus. So you'll be thinking towards BOHAV. So crepitus will first of all draw you closer to it. So the next thing they will ask is, what's the best next step? So the best next step here is that because it is torn, if this is the esophagus and you tear it here, it is torn here. No matter how you look, you may not actually know that this is where it's torn. That's number one. You may not know that this is where it is torn. So you bring your scope. Because with scope, you can also perforate the esophagus with the scope. You can also perforate the esophagus with the scope. So what you do first is that when you are suspecting BOHAV, best next step is going to be contrast esophagogram or CT scan. Why? So when the patient takes the contrast, you put it here, you will see the contrast will be coming out here. That shows that this is where the thing is torn. And never go for endoscopy before the contrast. You don't even go and be like you want to go and perforate it again. So please never go for endoscopy if at all you see it. Just once you are suspecting BOHAV, you see crepitus in the exam, in the question, you are thinking, and the patient has been vomiting, you are thinking towards BOHAV. Best next step is all about the investigation. Just go for the contrast esophagogram or CT scan. So if you don't see contrast in the exam, you will see the CT scan there. Any of them will be there. Very easy. So CT scan or contrast. So that's what they will test. Just this one. This is just what they will test. Chest X-ray. If at all is done, so you'll be seeing mediastinal, subdiaphragmatic, just something related to the here. Anyways, so subcutaneous emphysema and the likes. So what is now the treatment? Something has already happened to the esophagus. Do you still want to give this patient something by mouth? No. Because whatsoever the patient takes by mouth can also seep out, which can actually cause sepsis. So you want to give the patient nil paoram, which you also call nothing by mouth. Then you give the patient fluid, nutritional support, antibiotics. All right. If at all is very large, so free or large perforation in high-risk patients are handled with surgery or esophageal stenting if at all surgery is contraindicated. So Small one may not require surgery. So by doing nil per oral, nothing is going by mouth, the thing will heal itself, and that's all. So if you look at it, so really nothing much. So the question they are going to ask is basically this one. Just what's the best next step here? This is what you are expecting. So nothing about the treatment. So this is just what the main thing you are expecting. We have what we call the Lavoie lesion. So nothing much about this. So I'm going to skip it. Then we come down to the disorder of the stomach and duodenum. So we are now in the stomach. Yes, gradually we've got into the stomach. So what do you want to take into the exam with respect to the stomach? The first thing you have is what we call dyspepsia. So I know that we all know about dyspepsia. I know we have read, we know it very well. So what is it all about? So the dyspepsia is actually, when you hear the word dyspepsia, it's related to the stomach basically. Heartburn is related to the esophagus. So some people use it interchangeably in a way. Some people do not know the difference. So I'm talking about patient. So heartburn is related to the esophagus. Dyspepsia is related to the stomach. So you now see the word dyspepsia. What characterizes it is, there are many, but just to put something at the back of our mind, epigastric pain for at least 1 month. Epigastric pain for at least 1 month. With postprandial bloating, you are seeing bloating, you are seeing discomfort, you are seeing all those stuff. You are just like, and all of them, they occur after eating. You just see dyspepsia. All right, let me bring it closer to you. This is so patient, 47-year-old woman complaining of 6 weeks of epigastric pain and associated bloating, epigastric discomfort following eating, blah blah. Just look at it. It's already more than 1 month. Dyspepsia. Dyspepsia is a symptom or manifestation that so many things can cause it, and nothing also can cause it. So if at all you check the question, you cannot bring out anything that is responsible for the dyspeptic symptoms. There is nothing you can associate with it. You call it functional dyspepsia. If you can see 1 or 2 things that is responsible for the dyspepsia, you call it secondary dyspepsia. Now, look at it again. No, this is someone coming, epigastric pain, at least 1 month. Just know you are dealing with dyspepsia, but you don't know whether it's just functional or secondary. If you check the question, you can bring out maybe the patient has ulcer, has malignancy, has taken a particular drug or something. You know that, okay, that is the cause. So anything can cause it. The question may be about cancer, maybe something related to cancer, and you'll be seeing dyspeptic symptom there. So many things can cause it. All right, so that's just like a background information for us. So now look at it. It can be from malignancy. It can be from peptic ulcer disease. Can you see? Peptic ulcer disease. It can be from drug. You will see a particular drug in the question. It can also be from biliary problem. All right. So there is what we call parome. I hope I pronounce it very well. So parome 4 criteria. I hope that's just the full gist about it. All right, don't mind me anyways. So Dr. Salma. Dr. Salma. Ah, tough.
Sir,
Okay, I thought you
yes,
wanted to say something.
it was a mistake. Thank you, sir.
Oh, all right, man. Okay, so this is per room. So when do you say the dyspepsia is functional? You can't see any evidence of structural disease, and you are seeing one or more of the following: bothersome postprandial fullness, bothersome epigastric pain and burning, discomfort, bloat. You are seeing all those stuff. You go for functional. Can you see? You can't see anything that is causing it. That's when you go for functional. So these are the other causes. So if at all, before you say this is functional, you must have looked at that question and rule it out and be like, then this is actually not, after ruling them out and be like, this is functional. So what are those other causes? I've shown them to you before. So, and that's that. So if at all you check for cancer, you say that, please listen to me very well here. You know, you look at the disease, you're like, something is causing it. You check for malignancy, you say no. The question says no, I'm not the one. Peptic ulcer disease, say no, I'm not the one, docky. Drug, question say no. Do you see us in this question? Biliary, say no. And I say, what is the best next step? The best next step is for you to go and check for this bastard. You call it Helicobacter pylori testing. When you check for Helicobacter pylori testing and you realize that that is not there, also you now be like, okay, maybe I'm dealing with functional. Please watch out for this very, very well. So this must have been ruled out before you say that, okay, this is actually what I'm dealing with. Is functional and not functional or non functional. So don't forget to rule this out. The question must say that it has been tested for and it's negative, or that is even what they are testing for in the question. Now, the next thing is, we've heard about this patient having epigastric pain for about 6 weeks now, having bloating, having this one, discomfort following heating, and the likes. When do I do endoscopy? You do endoscopy if you are dealing with someone above 60. By just seeing the question 66-year-old, you say, and having dyspepsia, you go for endoscopy straight. You now see less than 60-year-old patients. You are now seeing red flag symptoms. You do endoscopy in them too. So what are those red flag symptoms? Dysphagia, bleeding, weight loss, lymphadenopathy, vomiting, family history of GI malignancy. You'll be like, endoscopy. If you check the question, the patient is 56 and you do not see all these red flag in them, do not go for endoscopy. That would be wrong. So when you are looking at that question, sincerely speaking, you have work you are doing. You are not just reading and passing. The question is all about dyspepsia. And what you will see is this. This is what you will see. So if you look at this, we are not solving them. So we'll be solving them later. 42-year-old. You are now saying, I've been having, due to 4 weeks of episodic upper abdominal pain. Can you see? Episodic upper abdominal pain. Let me read this one finish. And I say, the patient described a burning pain that waxes and wanes and is associated with nausea. On several occasions, the pain has awakened her at night. When you read your question and you read that someone has been having epigastric pain that awakens at night, most likely you are dealing with duodenal ulcer. Most likely. That's the concept. Any question, it wakes this patient up at night, because when the patient does not eat, it will wake the patient up. The pain will come up When the patient hit, the pain will go down. Opposite to gastric ulcer. For the gastric ulcer, when the patient hits, the pain will come up more. That's why they don't hit. So duodenal ulcer patient is likely to be very big. Gastric ulcer patients are likely to have weight loss. Which organism is causing duodenal ulcer? Like very larger percentage of them from Helicobacter pylori. All right. So what I'm just trying to show you is these 4 weeks, dyspepsia and the like. You now check the question. You already know that this patient is what is causing this patient's dyspeptic symptoms is basically the duodenal ulcer. Okay, you see. Now, which of the following is the most likely underlying cause? If it's duodenal, go for Helicobacter. That's why the answer here is F. So every dyspepsia, look at this next one. 67-year-old man comes to the physician because of a 3-month history of bloating and nausea after eating. Immediately you say this is dyspepsia. Just write it, say this is dyspepsia. The next thing is, what is causing this dyspepsia? You are now tracing the question. Just be looking. So that's how you are going to do it. All right, so that's just by the way, just for you to see the duration and how they all play out. So, and don't forget when you do endoscopy, if the patient is 60, more than 60, whether you see red flag or no red flag, endoscopy straight. If the patient is less than 60, until you are seeing red flag, that's when you do endoscopy. If the patient is less than 60 and there is no red flag, so you don't do endoscopy. What about gastritis now? I know that we are aware of gastritis. What's now the difference between gastritis and dyspepsia? So for the gastritis, that is when definitely there is something. Dyspepsia, you can have functional one. So for the gastritis, you will see the symptoms and signs of dyspepsia in the question. You will now see either the patient takes alcohol or takes a drug, or is having increased MCV, or is having Helicobacter pylori being positive. You know that, most likely I'm dealing with gastritis here. So gastritis, you will see the symptoms of dyspepsia. They will now say the patient went to a party. The symptoms started when the patient went to a party or something like that, or the patient is on a particular drug, or you are seeing something related to MCV, which I'm going to show us. So you'll be thinking towards gastritis. So let's look at the gastritis now. I know you've heard about acute gastritis, chronic gastritis. Those are the two gastritis we all know. Acute, chronic, acute, chronic, acute. So what is acute? Gastritis is just inflammation of the gastric mucosa, basically. So if it's acute, then we are dealing with just acute inflammation. If it's chronic, likely we are dealing with something that deals with chronic inflammation. All right. So for the acute gastritis, what kind of cell will you see here? Neutrophilic infiltrate. So there is no loss of mucosal gland. It is acute and it's very rapid. So someone went to a party, developed the symptoms and sign of dyspepsia. Immediately you see went to a party yesterday, now developed the symptoms and sign of dyspepsia here today. Just know that gastritis, acute gastritis. Likely the patient took a lot of alcohol yesterday in that party. Now developed the symptoms and sign of gastritis. This is someone that is taking NSAID. Maybe the patient takes a lot of doses of it, now developing dyspeptic symptoms. Immediately you see that NSAID, you just be like, acute gastritis. Now, let us set a question here. If at all you do a biopsy here, what are you going to see? You are going to see neutrophilic infiltrate. Will there be any mucosal gland loss? This is just acute. It won't be lost. Will it be rapid? Yes. What about chronic gastritis? Chronic inflammation ends with, we usually talk about, fibrosis, right? So the cell you see here, mononuclear cell infiltrates, not the polymorphonuclear cells like neutrophil. So this is mononuclear. All right. What else? There will be loss of mucosal gland. So you will see loss of mucosal gland. We didn't say there will be loss of parietal cell mass and nothing happened to the mucosa as you have in menetrier disease. In chronic gastritis, the mucosal gland is lost. In fact, the mucosa is going to atrophy and the gland they contain will also reduce. So parietal cell will be lost. Mucosal cell thickness will reduce. Everything we shall like that atrophy will show here. No, not here. So if they ask for when they do biopsy, what are you going to see? You already have an idea. Just chronic inflammation, palaver. They will see here. Is it rapid? No, it's actually insidious. So what are the two types here? The two types you have the type A and type B. Type A and type B. Now, type A is related to antibody. Type B is related to bacteria. Which one? Which one? Helicobacter pylori. NSAID. All right. So, antibody here. So, which part of the stomach does type A affect? Fundus. This is the cardiac. This is the fundus. Which type of the stomach does type B affect? Antrum. Can you see the antrum? Now relax. Let me show you. So, before I dig deeper into this, so that you have an idea of how everything plays out in a way. So let me quickly just say one or two things again under the acute gastritis. We've already said it's rapid, it's fast, superficial or deep erosive lesion, and say that alcohol H. pylori, stress from severe illness like burns. So CNS injury. So we have what we call the Colling ulcer. We have what we call the Cushing ulcer. All right. So please never forget Colling for the burns, Cushing for the CNS injury. So autosic injection of one thing or the other. So that's for acute gastritis. Now look at the chronic. Now come closer to the chronic now. For the person that is sleeping, wake up. You may want to wake up here so that you get the gist of how you'll be looking at it. So this one, for the type A, fundus. For the type B, antrum. All right. So what we have here is just antibodies that are directed against the parietal cells. So when they are directed against those parietal cells, they will shall kill the parietal cells. But it's chronic inflammation that's going on. All right. So this will cause pernicious anemia because you are having something to do, or something related to the acid secretion. Because once those parietal cells are destroyed, they will not be able to secrete acid again. All right. So the acid production is going to fall. All right. So then you are most likely going to see some other autoimmune disorder in the patient. Let me assume that this is a table question. So not naturally, we have some cells here. You call them G cell. G cell, they are here. So when acid comes down like this, it's going to reach the G cell. If the acid is high, the G cell will be inhibited. So if the acid is low, the G cell will be stimulated. So if the G cell is inhibited, the production of gastrin is going to reduce. All right, now look at it here. You damage the parietal cells here. The total volume of acid that will be produced will reduce. So the G cell will sense it and be like, what happened to acid? So G cell will now throw out a lot of gastrin. So in this question, for type A, you are going to see elevated level of gastrin. Gastrin will be very high here. Elevated level of gastrin. All right. So what will the gastrin now do is going to come and just start overstimulating all the remaining parietal cells that are yet to be killed, to be damaged. So that is just by the way. When you damage the parietal cell, intrinsic factor is also not being produced again. If the intrinsic factor is not produced, vitamin B12 cannot be absorbed. So therefore, the patient will develop vitamin B12 deficiency. So if the patient is having vitamin B12, how are we going to know that this is vitamin B12 deficiency in the exam? You will see that the MCV will be very high. Now relax. Festus, enjoy it. Summarize this thing. Now let me tell you. They tell you this patient is having gastritis. You now look at the question. The only thing you see next in that question is increased MCV. You just see dyspepsia symptoms in the question. You now see increased MCV there. The next thing is most likely I'm dealing with type A, chronic gastritis. Shikena. Just say most likely I'm dealing with type A, chronic gastritis. So, because in it, you see the intrinsic factors are not produced, the parietal cells, they are killed, they are damaged by those antibodies. All right, so that's just by the way. So, what is the patient at risk of? Gastric adenocarcinoma and carcinoid tumor. So, what about the type B? Type B affects the antrum. So, type B affect the antrum is, and I mentioned something that bacteria. Which bacteria is that? Helicobacter pylori. So if this is related to Helicobacter pylori, how does it happen? Helicobacter pylori is going to actually, in a way, kill what we call the, the delta cells. So delta cells actually have some inhibitory effect on the G cell here. So it's going to set up chronic inflammation here. Kill the delta cell, kill the surrounding cells, kill so many things and the likes. All right, that's just by the way. So if it's killing, chronic inflammation is going on here, affecting the G cell, affecting everything. So most of the time, you are not going to see high level of gastrin here. They might have been killed, they might have been damaged. Even though there may be initial high level of gastrin, because the first cell that will be damaged will be the delta cell. Delta cell that normally releases somatostatin that inhibits the G cell. So if they first of all kill them, so G cell will, now that inhibition is removed, G cell will be over producing the gastrin. So there may be initial phase of that. After a while, they will all be died. So there is reduced level of gastrin here. And that one is most likely going to cause reduced level of the acid. Can you see? It doesn't mean there is no any other way the acid can be produced. The acid can still be produced from via some other mechanism. The vagus nerve and all manner of stuffs and the likes, they can still be produced through that. So but never forget that this is where the type B is actually affecting. All right, so what is this patient at risk of? The patient is at risk of peptic ulcer disease here. The patient is also going to be at risk of gastric cancer. So can you see these two? Ulcer, here, gastric cancer. Here is also gastric cancer. Here for the type A, gastric cancer and carcinoid tumor. And never forget increased MCV, how it plays out. Type A, gastritis, is associated with pernicious anemia caused by lack of intrinsic factor necessary for absorption of vitamin B12. Helicobacter pylori antibodies stay positive even when the infection is cleared. So they will test this in the exam. This thing, it's going to be tested, and let me show you how they will test it. So now, you realize that this is caused by Helicobacter pylori. You now bring your dagger. You are shouting, give me those antibiotics we used to kill Helicobacter pylori. Let me flush where son. You're like, oh yeah, that makes sense, doctor. Now bring your antibiotic, you give it to the patient. You're not like, wow, the thing has been cleared off. All right. How will you know the patient has been cured? They will always ask that question in the exam. How will you know the patient has been cured? The only test you will use to know that the patient has been cured, they are these guys. The commoner one is the urea breath test. Another one is just for you to repeat the stool antigen. But this one, they tilt more towards this area. They just say the urea breath test. Which test do you want to do? Anytime you treat a patient for Helicobacter pylori and now want to check whether the patient has been cured, you go for urea breath test. If you check the option, this is not there, you go for repeat stool antigen. If those organisms are there, you will see them. The stool antigen will be there, will be positive. If they are negative, that's fine. But urea breath test will be negative. What about testing for antibody? You don't do that. Because whether the patient is cured or not, the antibody will still remain positive. That's why the others will be wrong. So these are these, what do you call it? The other causes of all these ulcer, stress-related ulcer, calling, head injury, calling and Cushing. Calling for the bones, then the Cushing for the head injury. Peptic ulcer disease and gastritis should be considered in older adult patients who are taking medication for arthritis, and that might just be what we give it out. They are treating the patient, and the patient now develop epigastric pain and the like. Just dyspeptic symptoms, just be like, that's the cause. All right, gastritis now. How do you want to make your diagnosis? Upper GI endoscopy. So this is what they will test, upper GI endoscopy. Now this is for the test for H. pylori. We've already talked about one test. Urea breath test, stool antigen, then endoscopic biopsy. So urea breath test, stool antigen, endoscopic biopsy. So these are the tests that you can make reference to, you can talk about. All right. So for the urea breath test, usually used to confirm eradication after treatment. You can also use the stool antigen. Stool antigen. Stool antigen. Stool antigen. Not the stool culture. Not the stool culture. It's stool antigen. So because you might just go and be cramming stool. You know, say when I get into the exam, once I see stool, I will pick it. You will be wrong. So it's stool antigen. So these are the two. You use them to confirm the eradication after treatment. Urea breath test basically just give the patient a radiolabel urea to drink. If I thought the organism is there, the organism will produce urease that will break the urea down to CO2 and ammonia. So the patient can now exhale that one out. All right. Or batch it out anyhow. So basically that's that. For the stool antigen, you just check that in the patient's stool. It's stool antigen, not the stool culture. So don't go and fall for that trap. This is stool antigen. Oh, we are shouting now. Before you say, I don't know what is happening. No, there is nothing happening. We are saying you just choose to sleep. So that's that. Endoscopic biopsy. This is too invasive. So when you see the others and they mention this in the exam, you need to be very careful before you go for this because this is quite invasive. And that's that. Gastritis. Which test are they going to check? Test in the exam. Endoscopy. How are we going to treat? How are we going to treat? Well, whatsoever that is causing the patient's problem, try to address it. If at all you are considering Helicobacter pylori, which they test in the exam most of the time, please watch out for these guys. Either I used to say metastasized pulmonary TB or CAMP. for those that are used to Nigeria, when you go to camp, like NYSC camp, there are some northerners that will come with metastasized pulmonary TB, just for them to be, sorry, to use the word, they camp. All right. So, but that's just by the way. So, MTB and then camp. So, this may help in a way. So, what is M here is just the metronidazole. So, P is PPI, T is tetracycline, B is bismuth subcitrate. What of camp? Clarithromycin, amoxicillin, metronidazole, then P is PPI. All right. So, these are the 4 drugs you are checking for. You must give the patient now. Relax and get the gist again. You get into the exam. Someone is having dyspepsia. You check for cancer is not there. You check for this is not there. They now say, what do you want to check for? Is this bastard Helicobacter pylori? Because so many people have complained to us before on the road, on phone, and be like, I'm having ulcer. And just go and use PPI. That is wrong. That's wrong. So you don't just say, that's why they always complain about it. They will always be having it. And now say, they even personalize it and say, I have ulcer. I have ulcer. They used to tell me, that's how they will say it. So you need to go and do this test. When they check them and they check for Helicobacter pylori is there, you place them on this antibiotic to eradicate it. And after they are done using the antibiotic for like 14 weeks, 10 days sometimes, so you now go and tell them to go and do another test to be sure that it has been eliminated. So when the test now say, okay, they've done it, it's eliminated, now say, okay, that's fine. You are now free of the culprit. So please never forget this at all in the exam. They will test it. It's one of the things they test, like very, very highly in USMLE step 2 and 3. So if you look at it, it's not really that difficult. So patients, if I thought the patient takes alcohol and the like, tell the patient to stop. If it's antacid or PPI may help. That provided you are not dealing with all those stuff, then you can eradicate this organism. Basically, never forget that. And the likes. So if I thought you are dealing with stress ulcer, like Cushing and calling, Cushing for the brain, calling for the bone injury. So another thing you do is that when those patients are on the ward to prevent them, you place the patient on PPI, prophylactic PPI, when they are in ICU. So, and we are done with that. Let me give us 20 minutes to go for a break for those that are interested to go for. Abi, don't you need break? Do you need break? Dr. Anita, do you need break, Dr. Anita?
Yes, please. We need a break.
Dr. Anita said, before you kill us with PPI and Helicobacter pylori, please let's go on break. So let's go on break for 20 minutes. Just relax your mind and pick the main points. And it's not all of them you will remember. Out of all these jargons we are formatting, it might just be 10 to 12 questions you are going to be giving birth. In real life, during practice, like you will see all of them. So if you don't know, you don't know. You see a patient that you won't be able to think straight, and nurses in US, they will just be making jest of the Africans and be shouting they are not good and the like. So that's why we just need to try to put more strength into this other than just trying to cram some questions and pass. All right, so that's just by the way. Thank you. All right. All right, let's continue our journey. I think it's time already. So, this is all about gastric cancer. The gastric cancer we all know about. So, what are we going to see? You will now see that same dyspepsia that we were talking about, dyspepsia or something related to chronic gastritis. So, but in that question, you are most likely going to see chronic blood loss or weight loss. So, you start suspecting, oh, this is not gastric cancer. So, chronic blood loss or weight loss. So if you talk about chronic blood loss, you can imagine how the patient will present generally. So if you also talk about the weight loss, you can imagine so how the patient is also going to present. All right. So these are the risk factors that we all know. So can you see diet that is high in nitrite, salt, and low in fresh vegetable? H. pylori, chronic gastritis too. So basically, all right. So what do we need to make the diagnosis? Endoscopy is what they will test. Endoscopy. So upper GI endoscopy with biopsy. Then, if I thought they have mentioned that, oh, this patient has this, and this, which are related to dyspepsia, and now say that there is also, you now trace the question, you see weight loss, you're already like, hope I'm not dealing with what do you call it? Hope I'm not dealing with something like gastric ulcer, or hope I'm not dealing with cancer, gastric cancer, because that's why anytime you see a patient with gastric cancer and a patient with gastric ulcer, you need to investigate for gastric cancer because the presentation is basically the same. So how do you mean? This is it. A patient with gastric ulcer. So when you see it, when they eat, they are going to have the pain. We'll get there soon. They will have the pain. The pain will come up. So they stop eating. So they also will lose weight. So when you now see that weight loss, you are not sure. Am I dealing with cancer? Am I dealing with cancer? Is it ulcer? Is it cancer? So if I told you do endoscopy, you now see any ulcer there, you are still not sure whether it's ulcer or or cancer. So you need to do biopsy. So any gastric ulcer you see must be biopsy. All right. So that's just by the way, endoscopy with biopsy. So if the question says that the endoscopy with biopsy has been done, what is the next thing you want to do? Immediately after diagnosis, look for what? Metastasis. So you just check the options and pick the one that's related to metastasis. All right. So that's that. So if the cancer is picked early, the treatment will be surgical resection. So if it has metastasized and is quite incurable, you pick systemic therapy. So maybe chemotherapy and the likes. So that's what you just check it. Has it metastasized? Hasn't it metastasized? Now we have a particular lymphoma. You call it MALT, mucosa associated lymphoid tissue lymphoma. It's quite rare. It's a rare gastric tumor that usually presents in patients with chronic H. pylori infection. So this is a tumor. It's a tumor that is treated with antibiotic. This is the tumor you treat with antibiotic. So if I thought they hacks, if I thought they hacks in the exam, they give a picture, clinical picture of, maybe they even mention it, MALT. This is like tumor that you treat with antibiotic, the same antibiotic you use for H. pylori. You just give it to the patient and the patient will be fine. All right, so that's that. So gastric cancer can present with facial node, which are enlarged left supraclavicular lymph node, or Sister Mary Joseph node, which are palpable lymph node near the umbilicus. So, Sister Mary Joseph, I don't expect you to not to remember that it's going to be around the umbilical, because when they are together, their umbilical will be rubbing themselves. That's just a joke, but don't forget, you can use that one to know that Sister Mary Joseph node is related to the umbilicus. All right, so that's that. In summary, for cancer, don't forget, dyspepsia will be in the question. You now see something like weight loss or chronic blood loss, and anything that you can peg on it. So it will be in the question. So I have quite a number of questions here. So look at this. So I want you to look at this question, though we are not solving it, but just for you to have an idea of how it may be. 68-year-old man comes to the physician because of 4 months history of fatigue. You're like, why are you having fatigue? During this time, he has also had 10 kg weight loss. Now note it down. Okay, there is weight loss, which the patients are due to poor appetite. I don't hate. He has not noticed any change in his bowel movement or urination. He has hypertension well controlled with lisinopril, a colonoscopy 3 years ago, and a CT scan of the chest 6 months ago showed no abnormality. Everything is was fine. He has smoked half a pack of cigarettes daily for 42 years. He is 174 centimeter tall, weighing 75 kg. BMI is 25. Vital signs are within normal limits. Examination shows a pale conjunctiva. Alright, now see there are firm palpable nodule in his left supraclavicular and periumbilical area. Immediately you see this, you are like, oh, hope I'm not dealing with all these Sister Mary Joseph nodule and like. Now say, okay, this is related. Most likely I'm dealing with gastric cancer. Alright, now look here. Chest auscultation discloses no abnormality. Abdomen is soft and not tender. Bowel sound are normal. Which of the following study is most likely to establish a diagnosis? So to establish the diagnosis, what do you need? Upper GI endoscopy with what? Biopsy. So that's what, because you are already thinking towards something. If the question says they've done it, what's the next thing you want to do? So you can be thinking towards CT scan, just to check for metastasis around. The same picture you will see here, the same thing you will see here. So you can look at it. I know some people have been taking the picture like that. Someone like Dr. Ekweme. Alright, so that's fine. So we are done with that. So just rehearse those key points. Those key points. If you look at, they are just like 4 or 5 points. Just rehearse them and leave the rest. You can become a gastric cancer specialist all because you want to write USMLE step 2. It doesn't make sense. They might not even ask a blank question on it. So why do you now want to kill? Just pick 3 or 4 points and leave the rest that are quite meaningful. Peptic ulcer disease. There is no one here that will say I've never heard about peptic ulcer before. That would be a lie. So many people have called us and be like, I have ulcer. So H. pylori, NSAID, alcohol, tobacco, and the like, they can all cause the ulcer. So H. pylori, it causes more than 90% of duodenal and like more than 70% of up to 70% of gastric ulcer. So what is the presentation for the peptic ulcer disease? So you will just say something related to dyspepsia plus whichever cause you see in the question, so that can cause the ulcer. So and that's what you pick. So how the patient will present will be dyspepsia, bony epigastric pain, which can be related to male. It may not be related to male. So most of the time related to male. So if like duodenal ulcer, if the patient has not eaten, it will come up. Like gastric ulcer, if the patient has eaten, once the patient eats, it will come up. So they can also be bleeding, having hematemesis or melena. So when you check you do the physical examination for them, usually it's normal. Now this is it. When you do physical examination for peptic ulcer disease, this is the patient. So this is the patient. So this is the tummy. This is the leg. So when you palpate the upper part here, the epigastric region. Most time you won't feel anything. The patient will not have the pain, because the pain in them is actually due to the ulcer. Alright, the patient will not have the pain. Usually, if you palpate this epigastric region and the patient is having pain, most likely we are dealing with pancreatitis. So that's why they say usually it's normal. So when you check them, you say you are having ulcer now, and some people when they want to press, so that's what even made me to laugh. When they want to press this area, it's more or less like they are exerting their whole weight. See, the patient must have pain by all means. I mean, they must elicit that tenderness by all means. So that's what some people do. So, but never forget that it's not compulsory that there must be tenderness here. In fact, when you read question, the patient is having epigastric, is complaining of epigastric pain, and you palpate, there is no pain there. Most likely you are even dealing with ulcer. So please never forget that, just for you to know. But sometimes they may also have epigastric tenderness. So, but and stool go high. But never forget this point I mentioned here. All right, so that's just that. Then the question on duodenal ulcer is likely going to come in the way I mentioned the other time. This patient usually have the pain coming up at night. I mean midnight when the patient is sleeping. Or the pain wakes the patient up. Most likely you are dealing with duodenal. Go and screen for H. pylori. That's the next thing. Best next step, screen for H. pylori. Can you see? So the pain wakes the patient up. For gastric ulcer, the pain will not wake the patient up. The patient will not even sleep well because their own pain comes with food. Whereas duodenal ulcer, when they do not eat, they have the pain. All right, now look here. Risk factor. What's the risk that the patient is having? Acute perforation. I want you to listen attentively to the gist. It's just gist. There is nothing in ulcer you don't know. But just for you to organize something and be like, okay, this is how I'll be looking at the question. So that's all I'm doing with us. So risk, it can perforate. Now, relax. When they give the question, how will you know that this patient has perforated? You will see the question we talk about. In fact, anytime you are reading that question and something related to dyspepsia, they must put it in the question that abdominal examination is not remarkable or something like that. So, but once you start seeing there is rigid abdomen, there is rebound tenderness, there is guarding, likely the patient has perforated. They will now say, what is the best next step? What is the best next step? If it's all about investigation, your answer will be chest x-ray. If it's about treatment, your answer will be emergency surgery. All by seeing these three words in your question: rigid abdomen, rebound tenderness, guarding. You are like, the patient has perforated. The patient has perforated. So, how are we going to make the diagnosis? So that's why this is very important for you. So I will have said, pick a sheet of paper and write the three of them down. But just be noting those key points. How are we going to make the diagnosis for the ulcer? Upper GI endoscopy with biopsy. That's what they will test. This is just what they will test. So when they do the biopsy, they can also use that biopsy tissue to test for H. pylori infection to see if it's there or not. All right. Then if at all you are also dealing with cancer, they can use so many things, do so many things on the tissue. So don't forget H. pylori testing. If it's there, they need to give the patient antibiotic for it. If at all there is perforation, from the way the patient is presenting, you are suspecting it, you must do chest x-ray, upright chest x-ray. What are you going to see? This is what you will see. You will see air under the diaphragm. So this is the diaphragm and this is the hair under it. So you see air under the diaphragm. That is pneumoperitoneum. Okay, now we'll look at Solinga-Ellison. How you will. So let me bring Solinga-Ellison here for us. So how are we going to treat now? Now, this is the treatment. This is where you are expecting most of the questions. So I just wanted to get the gist here. So we have what we call the acute management. The same ulcer patient that I know is a yes. As this patient perforated cancer, you see, I don't know. The question did not mention it. The question did not mention it. But did you see rigid abdomen? They say yes, it's there. Guarding, yes, it's there. This, yes, is there. Once you see all those stuff, the best next step will be will be this upright x-ray of the abdomen. So you'll be able to see. This is the initial test. So you are going to see here under the diaphragm. You now be like, yes, I was suspecting it. This patient has perforated. If I told you, From the question, you are like, this patient has perforated. The question now say they did the x-ray, but they are not seeing here under the diaphragm. They now say, what is the best next appropriate test to do? The answer will be the CT. Can you see how you go from x-ray to CT? So this is what you rehearse. When you are reading the question, that's what you are looking for. You'll be like, go for CT. So that's CT for you. So they've seen. So if I thought the patient, what the patient is having is just, the patient is just bleeding. So the patient is just bleeding. So you know the vessel that can be involved in ulcer bleeding. If you are dealing with gastric ulcer, which vessel will be causing the bleeding in them? Do we remember? Left what? Gastric.
Left gastric.
Artery. So if you are dealing with duodenal ulcer, will be which artery?
Gastrointestinal.
Gastroduodenal. Exactly. So if the question says the patient is vomiting blood, or we are seeing melena and normal, so you're already suspecting bleeding. And now say, what do you want to do? Serial hemoglobin. Serial, because you expect it to actually resolve by itself. So I want to see the way the thing is falling. So if I thought it's falling rapidly and the patient is becoming, you are monitoring the vital signs, the patient is becoming unstable, you may actually need to be giving the patient, you give the patient fluid, blood, and the like. This thing still does not stop. You now go for urgent endoscopy. So what do you use it for? To actually control the bleeding. That's all. So can you see serial hemoglobin and hematocrit? That's what you do first before you start, so that you won't see that this patient is vomiting blood and you look at it, it's actually, or he's having melena. You are now like, oh, his patient is bleeding. Well, now say, what do you want to do next? And the next thing that you are saying is endoscopy. That would be wrong. Your answer will be serial hemoglobin, because that's what we do normally. Don't change the way we think. Most of the way what we practice in Africa, they actually see they are quite helpful. Well, that's what we do. Just be like serial hemoglobin. As simple as it is, that's what is correct. So after you now look, and you're also monitoring vital, because that's what they will say, oh, you're going to be monitoring, and please, close monitoring of vital signs. We'll write it in the case file. Close monitoring of vital signs. If I thought the BP drops to this level, please call the doctor on call. That's the same thing. So that's the same thing we are doing here. You just realize that the thing is dropping, and I'll be like urgent endoscopy. That's the last thing. That's all. So now let's look at the long-term management. So maybe we've stabilized, the patient is now better, all those bleeding, perforation, and like we have sorted them out. The long-term management is medical therapy goal, just to protect the mucosa, reduce acid, and eradicate H. pylori if it's there. So my disease, you can see, just PPI antacid will help. If at all, so H. pylori to eradicate it. So what they can use triple therapy, they can use the quadruple therapy, the ones we were showing you, MET, PTB. Who remembers those drugs for quadruple therapy? What are those 4 drugs for quadruple therapy for H. pylori? All right, thank you. Metro, PPI, Tetra, and what? Bismuth. That's good.
Bismuth.
Lovely. So that's fine. So if you check that is not there, you can use this triple therapy, and that's that. So I think they've tested this one. That's why you see arrow on it, so that you note it. Be okay. Okay. So basically that's just what you want to note for the exam here so far. Endoscopy with targeted biopsy is also there, but don't be too bothered about these other ones. So let's look at complications. See the arrow here. Hey, you enter into that exam, you say I forget to take the complication along with me. You must be a joker. You, in fact, like a comedian. You say, oh, you must be a comedian. And I want you to get the complication here. The commonest complication United States Medical Licensing Examination Step 2 and 3 we test is hemorrhage. Hemorrhage. So now, this is it. They portray the ulcer patient. They now say which of the following complication is this patient likely to have? Hemorrhage. Because they will write hemorrhage, they will write perforation, they will write gastric outlet obstruction. You are now looking at three of them are there. Don't forget order. That's why when we were in school, they always ask us during what I'll be like, oh yeah, what are the complications? Now say gastric outlet obstruction. Now say like, okay, so how many patients have you seen that have developed it? They have a way of putting it just for us to have something we talk about first. So please never forget this. Hemorrhage, most likely from posterior ulcer that erode into the gastroduodenal artery. All right, the next one is perforation. The last one is gastric outlet obstruction. So if they list the three of them, you go for hemorrhage. If you check hemorrhage is not there, you go for perforation. If perforation is not there, you go for gastric outlet obstruction, which is quite rare. All right. For the gastric outlet obstruction, what will I see in the question that will tell me that the complication this patient is having, say, is gastric outlet obstruction? The question will mention succussion splash. They will mention it. Succussion splash is positive. Once you see succussion splash is positive, gastric outlet obstruction. Now, what is causing the gastric outlet obstruction in a patient with ulcer? What is causing it? If you are dealing with acute, if you are dealing with acute gastric outlet obstruction, your answer will be edema and inflammation. If you are dealing with chronic gastric outlet obstruction, you will be thinking towards scarring and fibrosis. There are two things they can test here. If it's acute, like maybe someone ingested something that causes ulcer suddenly and the patient is also having succussion splash. Now, so what do you think is causing it? But this patient just ingested this thing 3 days or 4 days ago now. And this patient is already having succussion splash being positive. Then that's what is causing it. The answer is inflammation and edema. Inflammation and edema. But if this is something that the patient has been having for a while, now having gastric outlet obstruction, your answer is going to be fibrosis, scarring and fibrosis. So 2 of them will be amidst the options. It's your duty to now check, is it acute or chronic? If it's acute, inflammation and edema. If it's chronic, it's actually scarring and fibrosis the answer. Very easy and straightforward. What about the perforation? Can someone remind us what we say you are going to see in question that will give out the perforation? Guarding? It seems as if I'm talking to myself.
Rigidity
Rebound tenderness and the like.
and rebound tenderness.
Yes, exactly. So that's what they are going to. Once you see it, be like, this patient has perforated. Exactly. This patient has perforated. All right. So that's just by the way. We leave that one there. So rehearse this area very well. Ask your friend, what is the arrangement? Don't just come and just say hemorrhage. You are now looking up and looking down. You will just be blinking and be blinking your eyes. Just arrange them. Play around them. Hemorrhage, after hemorrhage, perforation after that, gastric outlet obstruction. So when they give me the question, they say the patient has been vomiting this, recently having this, having that. I'll be like, okay, this guy, what's now causing it? If it's acute, I'll be thinking towards edema, inflammation. If it's chronic, I'll be thinking towards scarring and fibrosis. And what will I see in the question that will give out the gastric outlet obstruction? Succussion splash. It will be there. What will I see in question that will tell me is perforation, rigid abdomen, guarding, and the likes? All right. So that's about that area. Dr. Ikweme?
Please, can you this succussion splash? How will they paint it, or they will use the same word?
Let me show you. They sometimes they can use the same word. So sometimes they can actually paint it that the patient, they are hearing one splashing sound and like. Let me show you a question that just for you to have an idea of how it may be. So these are all the questions you will be solving by January for those that will be with us. So you solve all of them. Permit me to just check for the one that related to gastric outlet obstruction. So look at this one here. So 45-year-old man from Guatemala comes to the office due to persistent nausea and vomiting of partially digested food. And now say he has had these symptoms for the past 1 month. And now say he has also lost 2.5 kg during this period. So which you understand, or you are trying to be like, okay, what's likely? This patient is vomiting, so nothing is really going down. And now say his appetite is good, but he mentions early satiety. He has not had any hematemesis, black stool, difficulty swallowing, and chest pain. Other medical problems include type 2 DM for the past 1 year and a suicide attempt 3 months ago in which he ingested acid. So this patient actually ingested acid about 3 months ago. He has a history of peptic ulcer disease and often takes antacid for the heartburn. So now you know what the patient normally have before. So, like, you just note it. This has not told you anything. You don't know the direction the question is going to yet. So, now see, he drinks alcohol and smokes 1 pack of cigarette daily. His temperature is 36.8. Blood pressure is 110/60. Then, pulse is 110 per minute. Respiration is 16. Mucous membrane are dry. Abdominal examination shows succussion splats on the epigastrium. Immediately you see this, you now be like, wait, gastric outlet obstruction. Can you see? You know, you say this is gastric outlet obstruction. You now say which of the following is the most likely diagnosis. All your thinking will be what is in this question or amidst this option that can cause that gastric outlet obstruction. Can you see? That will be. Now check the question. Is this patient having ulcer? They say the patient has been having ulcer. And this is not acute. Acute is something like the patient ingested something 3 days ago. Now the food is no more going down. That is acute. 4 days ago, 5 days ago, something like that. But this patient has been having ulcer for a while. So it shows that this patient must have been having, scarring going on that has now narrowed the pyloric area. That's why the answer is pyloric stricture. Do you see them mentioning succussion splash now?
Yes, sir.
Lovely, sir. So if you go through all the questions, so all of them will make sense to you. Here now, so by the time you look at the x-ray, I don't know what is in the x-ray, you'll be making your interpretation from it. Do you get me? So when the time comes and the likes, so that's that. So, and that's that about this area. So if at all you are dealing with perforation, guarding, and the likes, it's actually emergency, acute abdomen. It's emergency. You need to go and do surgery. Immediately, you'll be shouting, Nurse Lagbaja, where are you? Oh, yeah, call the consultant. Call this, call that. It's actually emergency. So don't let us forget the normal thing you used to put us through. Anyway, I'm talking to our bosses here. All right. So the same thing they test. Now, Solinger-Ellison syndrome. Solinger-Ellison syndrome. So now, there is no one here that will say, I don't know Solinger-Ellison. So relax. Get the gist of what they are most likely going to be testing. All right. So what is Solinger-Ellison syndrome? It's just a gastrin secreting neuroendocrine tumor. So if it's gastrin, then this is related to G cells. So gastrinoma. All right. Is gastrinoma? We say yes. Okay. So if this gastrinoma, how will I even know that this is Solinger-Ellison? So if this tumor is secreting gastrin, when you check the question, the level of gastrin will be very, very high. Like very, very high. Like very, very high. Like it can even be more than 1,000. Then, if the question talks about ulcer, you will see the ulcer in the duodenum, proximal part of the duodenum, distal part of the duodenum, proximal part of the jejunum. Once you see the ulcer extending down to the level of the proximal part of the jejunum, you start thinking Solinger-Ellison syndrome until proven otherwise. Because what we give this patient a lot of ulcer, a lot of gastrin that is now making the acid production to be very, very high. Gastrin will be stimulating the parietal cells. So the acid will be very, very high. The acid will be very high. And how come the ulcer extend to the proximal part of the jejunum? Normally, when the ulcer gets to the what do you call second portion of the duodenum and the like. So you expect, what do you call its name, bicarbonate and the like to come into it and neutralize it. Acid denatures protein. All those proteins, enzymes that are important in digestion, the acid want to denature them. So if the acid is very high, the enzyme will be denatured and those food will not be digested. What God did is that let Brunner gland produce a lot of bicarbonate around the duodenum. That's number one. Pancreatic juice, you also come with a lot of bicarbonate. All of them will now shower bicarbonate into the intestine. That high level of bicarbonate is supposed to neutralize the acid. So you now think about it. If you now have a tumor that is overproducing gastrin, that is now making the acid to be very high, even the bicarbonate cannot suppress it. It cannot. So think about what the patient will have. The patient will have denaturation of enzymes. Denaturations of enzymes. So most of those enzymes will just be denatured. The patient will have all manner of indigestion and the likes. So high level of acid will now be going down. Those mucosal lining that are in the distal part of the duodenum, proximal part, they do not secrete bicarbonate. The next thing you see is that the acid will start damaging them and start giving them ulcer. So when you start seeing ulcer at the distal part of the duodenum, proximal part of the jejunum, likely you are dealing with Zollinger-Ellison syndrome until proven otherwise. Festus, you talk too much. You say, no, it's not talking too much. But it's not that, it doesn't mean that that's what they will ask. So let us think now that you have a background information that, okay, when I see this in the exam, this is Zollinger-Ellison. Let us now look at what United States Medical License Examination Step 2 will ask. You can predict what they are going to ask. All right, look at it. The first thing is about the diagnosis. The first thing is about the diagnosis. All right, so fasting serum gastrin. Best next step. You'll see. Maybe the patient is they give there is a way they are going to we are going to portray very soon. So you add everything together. Just be like in the diagnosis anyway. Just don't forget this fasting serum gastrin greater than 1,000 picogram per ml. Then increase in gastrin level even with the administration of secretin, because secretin should actually reduce it. So even the secretin cannot reduce it. So you say that, okay, maybe I'm dealing with Zollinger-Ellison syndrome. All right. What else? So after you are thinking about tumor, you want to know to what extent it has gone, CT scan. So never forget this. So what about the treatment? Moderate to high dose of PPI. If it has not metastasized, don't forget our logic. You reset it, surgery. If it has metastasized, you don't use surgery again. What do you want to cut away? Nothing. So you can just, either you leave the patient or just give the patient chemotherapy. That's all. So check for, so you must do, after diagnosing that this is gastrinoma, you must stage it. And how you stage it is more or less like, okay, let me do CT scan of the abdomen to now check to what extent it has gone, to stage it. Surgical resection if it has not metastasized. Now, I put something here. Forget this at your own risk. Zollinger-Ellison syndrome. This is where most of the question revolve in. Hypercalcemia. Zollinger-Ellison syndrome gastrinoma is part of MEN 1. When we do endo, for those that will still be with us, we will like everything. They are most likely we will bring everything out. Everything out. We don't need to be accurate. We just need to have a logical way of thinking in the exam and in real life. So hypercalcemia. That hypercalcemia you see in them is actually from hyperparathyroidism. It's actually from hyperparathyroidism. So what do you think is causing the hyperparathyroidism in men 1? A, parathyroid adenoma. B, parathyroid hyperplasia. What is the answer? Hyperparathyroidism in men 1. A is actually from A, parathyroid adenoma. B, parathyroid hyperplasia.
Adenoma.
adenoma. I don't expect you to overthink it. Oh yeah, men 1. What is the first letter of the alphabet? Ah. What is... You people are not
A.
taking us. So
A.
I don't know why you are not talking. At least so A. So
What
this
did
will...
you? Can you repeat what you said?
the first letter of the alphabet is A. Letter
A now.
A. Yeah. So adenoma. So parathyroid adenoma. That's where you have it. So you can use that if you will, so you won't forget next time. All right. So the other stuff that you can see in men 1, they can be there, but these are just the few ones they want you to note, and these are the ones they will be testing in the exam. So I will show you a question now so that you have an idea, rough idea of how the question will come. So you see hypercalcemia from hyperparathyroidism, which is coming from parathyroid adenoma, epigastric pain, so peptic ulcer. Then they can also have diarrhea. Can you see? Diarrhea from all manner of indigestion. Why? So the acid is damaging the mucosa, is also inactivating the what? Pancreatic enzyme. The acid is too much. They love these guys. Key fact. So this is the summary of what they've been testing over the years in your first aid. So let me show you, just for you to have an idea of how it will come, so that you now be like, wow, this makes sense. So we are not solving them, but just for you to see it. 45-year-old man comes to the physician due to epigastric pain and diarrhea. What's happening? Past medical history is significant for peptic ulcer disease. You even have ulcer. He has a 20-pack year smoking history, but does not use alcohol or illicit drugs. Physical examination shows abdominal tenderness without rebound or rigidity. They already rule out what? Perforation. So from the ulcer. Now the endoscopy show a prominent gastric fold, 3 duodenal ulcer, upper jejunal ulceration, just a Solingay-Ellison syndrome. So which of the following is the most appropriate next step in the management? The next thing is to be sure that we're actually dealing with Solingay-Ellison. Go and measure the serum gastrin. And the gastrin there is going to be very high. And when you see it very high, quickly check if it reduces with secretin. So if it doesn't reduce with secretin, Solingay-Ellison. Okay, you see, very easy and straightforward. Look at this one. 45-year-old man comes to the office with a 6-month history of recurrent burning epigastric pain and diarrhea. And you know where the diarrhea is coming from? A lot of indigestion, because the acid has denatured most of those pancreatic enzymes. They now say that his stool are fruity and unusually foul smelling, and they float because it contains a lot of fat. The lipase that should work to help in the digestion of lipid is not working, all because the enzyme are denatured. The patient clothes fit loosely. The patient has lost weight, and he believes that he may have lost some weight. He has tried several over-the-counter medication, including antacid, H blocker, proton pump. They will not really work with moderate success. So vital signs are normal. Examination shows no abnormality except for mid-epigastric tenderness to deep palpation. Can you see? Very, very deep. So test of the stool for occult blood test is positive, and stool fat is also positive. So you have a lot of fat, so blood and the likes. Gastrointestinal endoscopy review 2 duodenal ulcer and a just Solingay-Ellison. Now say, which of the following is the best explanation for this patient with impaired fat absorption? So you'll be thinking more towards what? Pancreatic enzyme inactivation. By what? By dose acid. So you see what they put here, pancreatic enzyme deficiency. If you don't know what is going on, someone will be going for this. So reduced bile acid absorption, autoimmune mucosa, someone can just be picking what is not right. So this is the answer. So every information you need is in your first aid. So that's all. I want to show you one more. So I'm not going to read it, but just for you to see. So look at this. So 31-year-old woman comes to the office after 3 months of continuous burning upper abdominal pain that is only partially relieved by over-the-counter famotidine or antacid. She also has experienced recent onset constipation, excess urination. So constipation, excess urination. I thought you say you have continuous burning upper. You say yes, upper abdominal pain is there. I'm also having constipation. Also excessive urination. What are you having? The patient report no weight loss. Doki, I no lose weight. Our menstrual period are regular. The patient's father has a history of many stomach ulcer and multiple kidney stones. And I say, temperature is fine, blood pressure is fine, pulse is fine, respiration fine. Abdominal examination shows normal bowel sound, tenderness in the epigastric region, no palpable masses. And I say, our stools are positive for occult blood, laboratory results are now given. You are now like, wait, burning upper abdominal pain. They say yes. Check for the sodium, normal, potassium, normal, chloride, normal, bicarbonate, normal. Calcium is very high, 11.4. Hypercalcemia. Oh, no wonder the patient is having constipation and excess urination because calcium is osmotically active. That makes sense. But this patient is also having ulcer now. Ulcer with hypercalcemia. I hope I'm not dealing with Solinger-Ellison syndrome. And now, say additional evaluation is most likely to reveal which of the following. Sorry, I'm very sure which of the following. They now give you all this. You are just looking for something related to Solinger-Ellison. That's all you are looking for. So, and just check the option. Blah 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 blah. So this is primary hyperparathyroidism from what do you call it? Parathyroid adenoma, MEN1. So what is the diagnosis here? Solinger-Ellison syndrome or MEN1. All right, so that's how the question can come. If you look at it, just see ulcer, you now see something related to hypercalcemia. Very easy and straight. So that's how the question, you can even predict it. Like you can predict how the question can come. So don't forget the treatment. It must be moderate to high dose PPI just to control the symptoms of pain and the likes. Then we are done with that. The next thing is gastroparesis. You want to tell me everyone here does not know gastroparesis? That's a lie. Gastroparesis is what we all, if I mention gastroparesis, the next thing everyone will be shouting is diabetic gastroparesis, and that is it. It is the same diabetic gastroparesis you are thinking about. So though we have some other causes and the likes, so but primarily is caused by diabetes. All right, so what's this gastroparesis? Early satiety associated with delayed gastric emptying. All right, so how will the patient present? So the patient must have been a diabetic patient. That's number one. So the patient is a diabetic patient. The patient is now having some neuropathy, basically, which you can see in the question. The patient may be having some neuropathy that can also, they will now see the patient has been vomiting and the like. So you just know that I think I'm most likely dealing with what do you call patients we having nausea, early satiety. I'm most likely dealing with. So what's happening there is that peristalsis is not going. You expect the peristalsis to get to the stomach and move the food forward, but the patient ate 3-4 hours ago. The patient is still full. You now say, Baba, will you eat again? Say, okay, give me food. Now give the patient will only eat 2 or 3 spoons. Be like, I'm full, because the former food is still there. All right. Then after a while, when the food accumulate that more, because it's not going forward, so the patient will vomit. So, all right, because the food is not really going forward, the next thing you see is that the patient will have what do you call it? Postprandial hypoglycemia. Dokita. Where is postprandial hypoglycemia coming from? Relax. Don't forget, when the patient eats, insulin secretion has a way of increasing. Maybe from incretin or something, it's going to increase with eating. So insulin has increased, but the food is not moving forward. Insulin is waiting to help in the absorption, movement of the glucose into the tissue, but we don't have enough glucose. So insulin will just be reabsorbing most of the glucose that are there right from the beginning. And the next thing is the patient will lapse into hypoglycemia. All right, so that's just story for the gods. How are you going to diagnose? You chop ogbono and apu and eba. You now say this is what you don't want to take serious. It's a lie. No one will forgive you, even if you forgive yourself. You'll be like, yeah, I forgive myself. I can't kill myself. Please, you can't joke with this. So, delayed gastric emptying on nuclear scan. That's the answer. This is what they will test. No one tests this. No one tests this. No one tests this. Delayed gastric emptying on nuclear scan. That is all you are looking. Just check. Just flip through all the options and pick it. That's all you are looking for. That's what in the endo is the one they will test. In the GI is the one they will test. This delayed gastric emptying on nuclear scan. So please never, never forget this. What about the treatment? Yep. If I say how do you treat diabetic gastroparesis now, I'm very sure everyone will be shouting, what do we call his name? Metoclopramide, macrolide, metoclopramide, macrolide, metoclopramide. Yeah, it doesn't mean you are wrong. It's true. But if you read the question, and this is all about the, what do you call it? The patient has been, if the question is asking, the question may ask about the non-pharmacologic treatment. So if it's non-pharmacologic treatment, your answer is hydration, because this patient is not likely to have to be well hydrated and the like. So hydration and diet modification. So you want to make most of the diet to be more fluidy. All right. So then, if the question says which of the following is the best next step of pharmacologic treatment, your answer is going to be metoclopramide or macrolide, any of them that is there. So, and that's that. So what do you want to avoid in this patient? I want to avoid this pramlintide, glucagon-like peptide 1 agonist and the like, because they will worsen the gastric emptying the more. And that's just that basically. So if you look at it, very easy approach, very easy concept. So I'm not solving the question, but just for you to have an idea, you can see metoclopramide they are testing here, gastric emptying study. So they are testing here. So if you look at this, Menetrier disease. Menetrier disease. There is no one here that will say I've never heard of Menetrier disease here. It's a lie. Even if you are lying to yourself, you can't lie to us. We know you've heard about it. We know you know it. Okay, now let us show you what they will ask. You can also think beyond that because you can look at it in a broader way. So what you have here basically is something that characterizes it. You have large gastric fold, which is due to hyperplasia of gastric mucosa and reduced gastric acid secretion. That makes sense. Now relax. I know you are overlooking something here, so which you actually need to really pay attention to. There is reduced gastric acid secretion, so definitely you have parietal cells atrophy. However, what is happening to the gastric mucosa? Gastric mucosa, you have hyperplasia of that. So mucosa hyperplasia, parietal cell atrophy, Menetrier disease. Festus, how does this now affect us? The way it affects you is that chronic gastritis can also cause parietal atrophy. But apart from parietal atrophy, they will also have mucosa atrophy. So you call that mucosa gland atrophy. So in chronic gastritis, it is mucosa gland atrophy. In Menetrier disease, it's parietal cell alone that is atrophied. The reason is this. When they give the question, they will only give the histology finding that I put up here if you do not pay attention to them. So you are most likely going to be reading the question over and over and over and be like, what are you asking? What is this? So someone will now come and say they asked me a question on chronic gastritis. That would be a lie. And this person, another person will get into exam and be looking for chronic gastritis. That is another error. Type 5 error. So sorry to say that. All right. So basically, you just need to have an idea of something that will look like it. Chronic gastritis. But in chronic gastritis, mucosa atrophy. in menetrial disease is parietal cell atrophy. You have. All right. Are there other things this patient will present with that will give out this menetrial disease in the exam? Basically, you are there. One thing you have here is that what you have here is this. Sorry. So what you have here is this. The patient is going to, they produce a lot of what do you call it? They produce a lot of mucin, a lot of mucin. Mucin is proteinous. So the mucin that is actually produced, they will be lost, and that will make the patient to lose a lot and become proteinemic rather. So, and that will cause peripheral edema. So when you check the question, you are seeing pedal edema. So then as when they do what do you call it, endoscopy, they are seeing prominent mucosa fold. You now check, they do biopsy, they realize that the parietal cells are atrophied. Now, so what's the diagnosis? The answer is menetrial disease. So pedal edema will help. All right. So if I told you do laboratory, what are you going to see? Hypobilirubinemia. You can also have anemia. So the anemia in them is most likely to be related to chronic disease. So maybe something related to anemia of chronic disease. So how do you want to treat? No treatment. No definitive treatment is available. So manager is typically supportive, and you just modify their diet, give them a lot of proteinous diet. You can also give them PPI if at all they are bleeding. All right, so that's just by the way. So please never forget the pedal edema, mucosa hyperplasia, and parietal atrophy. Gastric bezoar. So what are these bezoars? They are just foreign body made of ingested material, most commonly found in the stomach. So it might be hair, it might be anything. It might even be it may even be clothes. It might be vegetable matter. So it might be anything that that the patient might have ingested. So I want you to think about it, because you just need to think about it and be like, how will this patient present? This patient is eating the hair, he's pulling the hair, he's eating the hair. So the hair will go into the stomach. They will now go towards the pylorus. They can block the pylorus. So if they are blocking the pylorus, they can't really. So the patient is most likely to come with intestinal obstruction. So that's one of the things the patient can present with. So the patient can also have intussusception, perforation, peritonitis, depending. So don't forget this intestinal obstruction or small bowel obstruction or gastric outlet obstruction. So how do we want to make the diagnosis? Endoscopy. It's when we do the endoscopy, you now get there. You are now seeing air. You are seeing this and that, vegetable matter. So they are the one that block it. You will now use the scope to remove some of them, and the patient will be fine. So what is the what is the treatment? You can use chemical dissolution. You can use endoscopic removal, which may be considered in more severe cases. So basically that's that. So the chemical dissolution is for mild one. So please never forget this endoscopic removal. All right. So that's that. Bariatric surgery. Bariatric surgery. Bariatric surgery is what everybody here knows. There's no one here that will say, I don't know bariatric surgery. That would be a lie, because it's what people normally do. So though no one expects you in the exam to go and cram the way the surgery is done, because you may end up not even being a surgeon. It depends on so no one is forcing you to know. So you can easily predict that no one will ask me about the surgery itself. Even if you see a question that is testing the surgery, no one will test it in the real exam. So now, what is it all about? It's just a procedure performed to promote weight loss. Oh, I don't love the way my stomach is. I have a lot of, so you can go and do bariatric surgery. All right. So how does this surgery help? with weight loss, either through limiting calories, because they will just reduce the total volume of the stomach cavity. So when they reduce it, so the patient will not be able to eat much again. So, and that will limit how much food is going to the patient's system. So the patient will now be losing weight. Then this also help by decreasing the ability of the body to absorb nutrient, because they will render a particular segment of the intestine useless. So they will render a particular useless. So they will shorten them. So that will definitely reduce the surface area for absorption. So lot of absorption will not occur again. So that's the story for the gods. Yeah, it's a story for the gods. What will they ask me in the exam? So I want you to focus more on the indication of bariatric surgery and also the complication. Those are just the two they test. Just the indication and the complication. So that when the patient, I think the reason why they love the indication and the complication a lot is because people tend to become overweight. Then some people can even have body dysmorphic disorder, and they will come and be shouting that, doctor, I want to do bariatric. I read it online. So that you'll be able to counsel them better for the indication for it. So then people that want to have it, you will see that, okay, I think you should be able to do it. So I think it's common sense. There can be you will need bariatric surgery. You need it. So something like that. So what are these indications? BMI 40 and above. You just need to pick a list of people and just rehearse it. Ask your friend, make a joke around it. Use it to sing, use it to pray, use it to talk, use it to do comedy. You can even be going on the road and just see someone that is very big, and in your mind you are telling your partner, your friend, or your enemy that this person we need bariatric surgery because the BMI is looking more like 45. You say, what do you mean by that? It's already 40 and above now, so we need this. And if I thought they check it and it's actually between 35 and that 40, so 39.9, there must be maybe one or at least one serious comorbidity that will make us to do it for this patient or for this person that is going before me. So just think so that you don't forget them, because these are numbers. You are most likely going to forget numbers easily. All right, so that's how you rehearse this area. BMI 40 and above, BMI 35 to 39.9, with at least one serious comorbidity like type 2 DM, obstructive sleep apnea, and the likes. Pickwickian syndrome, which is considered of triad of obesity, sleep disorder, breathing, and chronic hypercapnia. So nothing to worry about here. So hypertension, hyperlipidemia, shall see one of them there, or between 30 to 34.9 if the patient has uncontrolled type 2 DM or metabolic syndrome. So what do you mean by uncontrolled type 2 DM? It's definitely uncontrolled because the sugar is going to be uncontrolled. Why in this second one here, this most likely to be controlled. All right, so that's that. So you just need to write down the number so that in the exam when you see it, you just know that bariatric surgery, the patient merits it. Exactly. So what are the types? These are the types. I might not be too correct in my pronunciation, but Roux and Y gastric bypass or something like that. The people in the field will understand it better. Maybe that's how they pronounce it or not. Please don't be annoyed. Sleeve gastrectomy, adjustable gastric band, and the likes. So, but the one you just want to have an idea about is just this Roux and Y gastric bypass. So it's just one of them, but just for you to have an idea. So this is how it looks. So there is a way they describe it that I don't really think you should give yourself unnecessary headache. So can you see? So this is the gastric pouch, and you can see this is the room. So you can see the shape is bringing anyway. So that's Y shape. So you can see the shape, see the stomach. Can you see all these? This distal portion of the stomach here that you are seeing here is actually it doesn't get food again. It's useless. So no, don't let me say useless, because all the secretions that are supposed to come from it are still occurring, so they can still go down. Secretions and the like, they will still come down. Can you see, to help with the digestion? But this is more or less like the small gastric pouch the patient now have. So look at this small one now. Compare it to the big one the patient had before. So the patient will lose weight quickly until proven otherwise. Even if the patient wants to eat, just be eating. So it's a reflex. So anyways, so when the patient eats small, the patient is most likely going to be filled up. Do you get it? So, and that's actually how this is going to be. All right. So, that's just by the way. All right. 1 minute, please. Sorry. So that's that. So now you can think about some complications that they can basically hacks here. So look at this area. Just focus on this. Focus on this. All this anastomotic area. This area. This area. It can break down. It can be leaky. So look at the bowel now. So as the patient is eating, so you can see all this area, stomach, that the food normally enter and stay there for a while, is no more there. The bag is removed. So you just go down. You can be thinking towards dumping. So dumping syndrome, we'll look at it, how it can be. So you can have some stasis. The thing can be stenotic. All this area can be narrowed. This anastomotic area can be narrowed. It can break down. It can be leaky. It can be narrowed, stenotic. It can break down. It can be leaky. You can see. So if it's narrowed, the patient will be vomiting. You can imagine how the patient will present. If it's leaky, you can imagine what will happen. The patient can start having something that looks like acute abdomen. So if it's narrowed, the patient can also be having reflux. So if this area is narrowed, the secretion from here cannot go down. This one cannot go down. You can start talking about stasis. So patient can start developing stones and all manner of stuff. All right. So that's just from this diagram. Just also have an idea. It doesn't mean you should now be cramming what you don't need to cram. So sleeve is another one. Adjustable gastric band is another one. So now let's look at the complications, since that's the place where you are thinking about. Another set of questions. We've already looked at the indication. So look at the complication now. So what are the complications you want to take into the exam? You can even think about it. Acid reflux. So if it's narrowed, if the anastomotic area is narrowed, reflux. So it can be leakage at the surgical site. So if at all there is stasis, there can be bile, stasis and the likes. So cholelithiasis, malnutrition, because the patient cannot eat much again. Dumping syndrome. Now, amidst all these guys, they now bring out the dumping syndrome. That Dokita, you say yes, please. So note this dumping syndrome very well. You'll be like, why? So that the exam will not dump you. Say, I will note it. So what is it? It's something you can even think about. What happens here is that so because don't forget the bag of the stomach is removed, you now get one small portion of the stomach for the patient. So when the patient eats, so majority of the little digestion that should occur in the stomach do not really occur as such again. So you have rapid emptying of the food from the stomach into the small intestine. So when they get into the small intestine, because although little digestion do not occur, there will be that food is hyperosmolar, so it has high osmotic power. It will now pull fluid into the lumen in the small intestine. So when it pulls fluid into the lumen, what do you think will happen to the plasma volume? The plasma volume will now drop. As the plasma volume drop, the patient will now become hypotensive. When the patient now become hypotensive, the sympathetic nervous system, just like the normal thing, will now be activated. The patient will now start having tachycardia. Can you see? You are seeing tachycardia, the colic abdominal pain, diarrhea, nausea, just something you can peg on the sympathetic nervous system. You just see that. The question will now say anytime. We'll look at one here very soon now. So, and now see the diagnosis is made clinically just from the picture. What do you want to do? Avoid simple sugar. So increase dietary fiber, the protein there, because the simple sugar is even going to worsen it. So usually it resolves on its own in 7 to 12 weeks. So the question will now be like, what do you want to do for the patient or advise the patient? The patient is already observing this. Reassure the patient. All right, so that's the prognosis anyways. So let me show you one question. So definitely the patient must have undergone bariatric surgery. So sorry. 59-year-old man comes to the office for post-operative follow-up. And that's he underwent a partial gastrectomy for a perforated peptic ulcer 3 weeks ago. So partial, they cut part of the stomach away, or because of the perforation. Now, say the patient also received an extended course of antibiotic with the last dose taken 2 weeks ago. Now, say for the past 10 days, he has had intermittent abdominal pain, that's comes and go, and diarrhea, just having diarrhea. Symptoms begin 20 to 30 minutes after the patient hit and are associated with nausea, weakness, palpitation, lightheadedness, diaphoresis. Just say dumping syndrome until proven otherwise. All right, he has no symptoms overnight because the patient does not eat overnight. So he has no symptom overnight. It's only during the day when the patient eats, and there is no associated fever or weight loss. Now, say medical history is notable for hypertension. The patient has a 20-pack year smoking history, but quit after the recent hospitalization. Temperature is 36.7, blood pressure is 130/65, pulse is 80, respirations are 18. BMI is 26. On examination, the abdomen is soft and not tender with normal bowel sounds. The surgical wound is healing well and has no erythema or discharge. So basically, like, okay, surgical wound is not breaking down. Everything is okay, at least from outside. Cardiopulmonary examination is normal. Complete blood count is normal. Which of the following is the most appropriate next step in the management of this patient? So all you can see here is that every time the patient hits, the patient will develop nausea, weakness, palpitation, lightheadedness, diaphoresis. Last 20 to 30 minutes after eating, you just start thinking it was dumping syndrome. So what do you want to do? Best next step for this patient is actually, the first thing is modify the diet. Give the patient more of something like avoid the simple sugar in the patient. Give the patient more of what do you call his name? Fibers, protein, at least that are quite heavy in a way, and they will not pull water into the intestine. So the answer will be A. So if you are not very careful, this answer may look too simple to be correct. So you're like, okay, maybe it's this, maybe it's contrast, maybe I just need to go and do reconstructive operation again, or maybe it's endoscopy. So that would be wrong. So diagnosis is made clinical. You just need to know how to identify it. So later when we are meeting next time, you will be reading this one and be making your impression out of it. So, and that's dumping syndrome. All right. Diarrhea. Possibly, as we are going to look at diarrhea, some people amidst us here might even be having diarrhea. So it's an opportunity for us to understand ourselves. That is happening to us, at least a bit. Don't mind me. So this diarrhea, this is just the disorder of small bowel, just for us to have an idea. All you need is just idea, not too much detail. You are not I'm not talking about the gastroenterologist and Miss Horse. Some people are authority here that they even understand it better. Maybe we've even been committing one or two blunder in our explanation. But that does not mean, just for us, as I used to say, our intention just to show you one or two things to take into the exam, not to say that maybe we are better than you in any way. So please don't misinterpret us. So we are a very simple set of people. For those that are close to us, they know that these guys are they just go their own way. So we may joke when we are talking about them. It doesn't mean that we are trying to say that. Even if we say until proven otherwise, maybe you will prove it otherwise for us. So let's just look at them simply. So don't complicate our intention. So this diarrhea, types of the diarrhea, type of stool osmotic gap. There is something called osmotic gap, just for you to have an idea of the osmotic power of the stool. All right. So when the patient shits, you just look at the osmotic power of the shits. Just for us, there is a way they calculate it. Anyway, I will get there. So we have what we call the low osmotic gap. These are just the two they will be giving about the stool osmotic gap. Either low osmotic gap or high osmotic gap. If you check the question and they give you osmotic gap, is it less than 50 or greater than 100? That's just the two assignments you have, not to cram everything here. That's all. So if it's less than 50, it shows that the intestine is the one secreting something. So it's secretory diarrhea. So it shows that the intestine is secreting into the lumen. So there is increased secretion or inhibition of absorption of water. So you now have the intestine will now have a lot of fluid, watery fluid, and like making the patient to have the diarrhea. This is what they will ask: is it secretory or osmotic? If you check the question, they give you the osmotic gap and it's very high, you'll be like, this is osmotic diarrhea. And high in the sense that it's greater than 100. So they will definitely mention the osmotic gap in the question. So when you read the question, you will see they will mention it and be like, the osmotic gap here is this, the osmotic gap here is that, blah blah blah, and the likes. So so they will definitely mention it. I just want to look at a question that may possibly just justify that and the like. So if I can still see, and if I can't see, that's fine. All right. So but they will mention it that this is the osmotic gap. All right, so that's by the way, we are not looking at it patiently. So I know there is one question that you see. Just look at the question in the exam. Is it low, less than 50 or greater? So when you are rehearsing with your friend, just be like, Shegun, when you get into the exam and you see osmotic gap, how will you look at it? And answer, I will quickly check, is it less than 50 or greater than 100? If it's less than 50, what will you think about? You say, I will pick a secretory diarrhea. If it's greater than 100, I will pick osmotic. You see all these jargons they put here, ignore them. You don't need them. So you don't need the sample. These are just examples. So but they won't test any examples here. This is what they test most of the time. Is it secretory or osmotic? So the next thing I want you to note is about the diarrhea from laxative abuse. They ask it a lot in the exam. How will you know that until proven otherwise? So this is diarrhea from laxative abuse. Let me check my people if we are awake. Are we awake?
Yes.
Yes.
Yeah, okay.
Yes.
Just for us to be sure, because it seems as if Dr. Esther is dosing small. So I just need Dr. Esther does not know I'm seeing her, but I can see.
I know those, you know.
So Dr. Esther is like, Festus, you are seeing double. I'm not dosing. All right, so don't let us dose. So now look at this diarrhea from laxative now. How will they ask this in the exam, basically? So the way the question will come is the way it has been coming. Is still the same way it will come. It does not change. So it doesn't change. It's either what you will see that will quickly draw you closer and be shouting, laxative, laxative, laxative. They are like, Dr. Lax, hey, relax now. Dr. Lax, relax. You are just shouting laxative. He say, where did you come from? Be like, I came from Africa. The way you are shouting, later they now come and be like, okay, the doctor was correct too. This is how it will come. Either the patient is a pharmacist. The patient is a pharmacist. the patient has what do you call it? Access to laxative easily, or you just check the question, you see the watery diarrhea, that is the patient is moving the bowel 10 to 20 times in a day. This alone in the question, just in this USMLU, just flip to the option straight and be like laxative abuse. You've not read it. Doesn't mean compulsory you must get it right, but you have one thing. The advantage of that is that there are some questions that you see in the exam and you have 10 seconds left. You just be like, I think this is most likely to be laxative abuse. Just look at it, pick it. So this is watery, frequent, 10 to 20 bowel. So you may get into it, the patient has moved the bowel 12 times. This one, that's what laxative abuse, laxative abuse, laxative abuse, laxative abuse. So, nocturnal bowel movement and abdominal cramp are common accompanying symptoms. They can have it more also at night. Laxative is laxative. So, when they are passing they can actually easily be dehydrated. When they are dehydrated, RAS system will be activated. When the RAS is activated, what do you think is going to happen? That's when we throw out the hydrogen ion, throw out the potassium. So you start seeing hypokalemia. You can also start seeing metabolic alkalosis, all from RAS. So someone that is passing close to 12 times in a day, you can imagine. So then if at all you check these two, you are most likely to see the laxative in it. So positive stool screening for this diphenolic or polyethylene containing laxative. So there is one characteristic finding they test in the exam, like they test it in the exam, that you will see when they do colonoscopy, because they are like, Mr. Shitter, now you have been shitting for a while now. You'll be like, I don't know. So when they check, you are going to see what we call melanosis coli. So let us check the melanosis coli. It's just the dark brown discoloration of the colon with pale patches of lymph follicle that can give the appearance of alligator skin. So let us see melanosis, because that might just be the picture they will see and say, what do you think the patient might have ingested as laxative? So melanosis coli, let's see. So this melanosis coli. So you can see the picture. So I don't know the one we even want to. I think it's better we even use this. So you see this and you are shouting. The child gave me a picture that looked like a snake or something, or that looked like a tunnel. I don't know what they are trying to show me. It's melanosis, like melanosis coli, because you are dealing with the colon. So melanosis coli, can you see? Laxative abuse, laxative abuse, laxative abuse. This is what they will give. Something like this. You can check for more picture and see which one you feel makes sense. All right, so that's just by the way. We are done with that. We don't have much to cram. Just pick 1 or 2 points and be like, okay, I'm reading a question. I see 50 episode of diarrhea. Just go to the option and pick. I think I'm dealing with laxative abuse, medication abuse, this one abuse, that one, and the likes. All right. So, what of Campylobacter jejuni? So this is all about infectious agents. Now we want to start looking at them. Campylobacter jejuni. All right. So for the Campylobacter jejuni, even though they used to say that they are not usually linking Campylobacter jejuni to the cause of Guillain-Barré, but it is implicated in it. I have a way of putting their grammar. So Campylobacter jejuni, you'll be thinking towards it when you see a patient having bloody diarrhea and you are now seeing something that looks like Guillain-Barré in the question. So maybe something like you remember Guillain-Barré, areflexia, ascending paralysis, and symmetrical involvement. So when you see that, you're like Guillain-Barré for those that are used to us in step 1, when we have a way of, if I thought we have the opportunity of looking at neuro, we also show us the neuro, like everything, just simple concept. What we look out for, what we pick, just pick them. I used to sing a song for the Yoruba and Miss House. Bẹ̀rẹ̀ mi, àṣà fò gẹ̀rẹ̀gẹ̀. Ó torí àdìrẹ rẹ̀ lé téńté. Ojú tó lé, ojú tó kò. Some people have heard that song before, the Yoruba and Miss House. So don't think we are speaking in tongues. It's just the Yoruba. Bẹ̀rẹ̀ is gulembare. Asha is ASA, A reflexia, symmetrical involvement, ascending, something like that. So when you see this, just the three of them, just see it in the option. In the question, say this is Guillain-Barré until proven otherwise. So they can also have autonomic involvement that's there with ASA. Asha. All right. So that's just by the way. These are the things they may link to the diarrhea. You see, bloody diarrhea. You now see this, something that look like, you just say Campylobacter jejuni. So what is the treatment? So the treatment is actually supportive. So see the way they put it here, supportive treatment first, then fluoroquinolone or azithromycin. Now relax. So if you don't rehearse this, you may get into exam, they now say option A, fluid, option B, fluoroquinolone, option C, azithromycin, option D, ceftriaxone, option E, just start listing all manner of jargons. If you are not very careful, you may be going for antibiotic first. So unless the question says that supportive treatment has been ensured, what do you want to add to it? You now be like, okay, fluoroquinolone or azithromycin. So don't joke with supportive. Campylobacter jejuni. Never forget this. And we are done with that. So let me show you this question. So sorry, it's just because of what we are doing. You'll have seen the way we do our things in the concept. 17-year-old previously healthy boy is brought to the mind department due to 3 days of abdominal pain and diarrhea. And as the patient initially developed watery loose stool with periumbilical pain that has since moved to the right lower quadrant. And as over the past 24 hours, he has 12 mucus containing loose bowel movement as well as nausea and vomiting. You are like, what do you call it? It's laxative. You just quickly run through the options. You can't say anything that, okay, his younger brother has also had diarrhea, which has contained some streak of blood for the past few days, but is now improving. Temperature is 38.8, blood pressure 110/70, pulse 110. Examination shows mild diaphoresis, right lower quadrant, tenderness is present. There is no rebound. Laboratory analysis show a white blood cell count that's very high, and also 80% neutrophy. Now say, what is the most likely diagnosis? Now you see, this is a very wonderful question. Is what you will use here is actually what we call the elimination method. There is a way each of these guys actually present, which we are going to see. So there is a way they present. Diverticulitis, it has its own. We are going to get there. I'll show you everything. Appendicitis, E. coli, we will soon get there. So norovirus is just the viral infection, then the Campylobacter infection. So this is just a very rare way of setting it. But basically, when you check the question, you are going to see something. They can link it to something related to Guillain-Barré or reactive arthritis. What about the Clostridium difficile or Clostridioides difficile infection being the cause of the diarrhea? It has its own peculiar way of presenting. So don't bother yourself here. We'll soon get there. We'll look at it. I'll show you how you will be identifying it and what we give it out. It's just a summary of whatsoever they might have put here. It's just a story. You will get it. It's very easy. Like very, very easy. So this is Echinococcus granulosus. What we give this out is just, this is gotten from close contact with dog. Definitive host for tapeworm. It's going to cause simple liver cyst. So it has something to do with the liver cyst. And if I thought they describe it on CT, so what you will see then describe is eggshell calcification echinococcus. So egg cell, egg xenococcus, egg chinococcus, eggshell calcification. All right. So that's just by the way. I usually found incidentally. So what do you want to do? Sorry. You want to just go straight to surgical recession. So please never forget this. You don't want to aspirate because they mention is they are seeing a cyst. You know, be like and go and aspirate it or drain it or something. That would be wrong because if at all you spill out, it can give the patient anaphylactic shock. So echinococcus. All right. So that's just by the way. We'll look at closely down this DVC very soon. Just relax. So now this area. Enter Moeba histolytica and E. coli. Enter Moeba histolytica and E. coli. So I don't have story to tell you. That's me. I don't have story. So but the fact you are going to use to dissect these guys is travel history. We call it travel history. So when you check the question, you just hear recently travel. Recently travel. When you read that question, no matter how lengthy it may be, you now see the word recently travel in the question. You will just be like, either I'm dealing with enter amoeba histolytica or E. coli. Enter amoeba or E. coli. Enter amoeba or E. coli. Enter amoeba or E. coli. They say Mr. Enter, and Mr. He cool. Is he like, are you sure of what you are saying? I say, yeah. At least for now, I don't know much about it. With this travel history in this question, it's either I'm dealing with enter amoeba histolytica, the man just enter into another country, so or E. coli. These are the two differential. So how will you now know the one you go for? Check what kind of diarrhea is the patient having. If it's bloody, enter amoeba histolytica, breakdown of tissue. So E. coli usually non-bloody. Can you see how simple your thinking is? The question will be very lengthy. You just see the patient is having diarrhea. Recently traveled. You just open your eyes wide. I heard something. Did you say the patient recently traveled? Yes. It's either I'm dealing with enter amoeba histolytica or E. coli. What kind of diarrhea is this patient having? Bloody or non-bloody? They say it's bloody. Enter amoeba histolytica. Until proven otherwise. Travel history. So maybe we should call travel history diarrhea question. Maybe that will help. It doesn't mean they can't, but this travel history, very peculiar, very wonderful. At least it will help you. If you look at it, nothing much to look for. So enter amoeba histolytica now, you have an idea. Travel history, bloody diarrhea. So all this other stuff here, they are just story. So if you do endoscopy, they will say flag-shaped ulcer. That's why it's histolytica. All right. What is the treatment you want to give to this patient? Metronidazole. Enter amoeba histolytica. So metronidazole. Never forget metronidazole. E. coli. Travel history 2. They will mention all these things. Travel history, they're not bloody diarrhea. Sometimes it is initially non-bloody, can now become bloody later. So, but usually non-bloody. So, but this is how you look at it. This one will not have this non-bloody then becoming bloody. Enter amoeba histolytica does not have that. So this E. coli may initially be non-bloody and now eventually become bloody. Shall never forget travel history. That's the main cocoa. So the rest is their story. So how will the patient present? So you don't need to bother yourself. Their own duty is to put the presentation. Your own is to see travel history and think around these two guys. There is a concept, we call it hemolytic uremic syndrome. By God's grace, on Saturday, I will be taking you on a journey into the hematology world. So don't mind the way we talk. We are just catching cruise, but just hematology word for us to have an idea of how to think about blood and realize that this thing is not difficult actually. All right, nothing to cram in them. We are not cramming anything. We are not cramming anything at all. So this is HUS, hemolytic uremic syndrome. So Hemolytic uremic syndrome can be caused by this E. coli. So E. coli, it can cause it most especially if you are dealing with children. So never forget this. This might just be what they will put in question, something related to hemolytic uremic syndrome, and that child is having diarrhea. You just say, oh, until proven otherwise, so E. coli new. You just say it's E. coli, E. coli, E. coli, E. coli with this serotype 0157H7. They used to ask this in step 1 a lot, 0157H7. All right. Do you want to give these patients antibiotics? No. You need to be very careful. Antibiotic, anti-diarrhea to be avoided. So you now see you're just shouting antibiotic, 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 antibiotic. No, fluid. Give the patient fluid. So don't forget fluid at all. So that's for this. When we are looking at H2S, we'll be looking at that later. So what about salmonella? Salmonella. You'll be thinking towards salmonella as the cause. If the question says the patient recently ingested maybe raw egg, poultry product, or milk, or the patient is exposed to reptile, maybe a turtle or snake, and the patient now developed diarrhea, you'll be thinking towards salmonella species. So that's just by that. So if I thought they say, what do you want to give to the patient? Fluid. Who are those that are more at risk of this salmonella species being the cause? Sickle cell patients. So the question might revolve around someone that is a sickle cell. So please never forget this, because this can also cause osteomyelitis in them. So food, egg, poultry, milk, reptile. As I'm saying reptile, some people are looking around them. So wait. Reptile, so either turtle, pet turtle, or snake. All right, so that's just by the way. Shigella, you see, initially watery, now eventually become bloody. You are like, E. coli, E. coli, E. coli, E. coli, E. coli. They say, Mr. Eco, no now, this patient does not have travel history. We say, really? Then Shigella. So you have changed your you say yes. So at least you have something you are thinking about. You don't need to be accurate, but just have something, have an idea. Be like, okay, initially watery, then later become bloody, diarrhea, with no travel history. Likely you are dealing with Shigella. All right, with this one, what is the treatment? Fluoroquinolone with azithromycin with third generation cephalosporin. You can also use this trimethamine sulfamethoxazole with ampicillin to prevent person-to-person spread. Tenia solium, pork. From pork, definitely the question we mentioned pork. At least you remember Tenia solium, tapeworm. Then Trichinella spiralis. This is acquired by injection of undercooked meat, pork. So Trichinella spiralis. So they can have this triad of myositis, periorbital edema, eosinophilia, and the like. So what is the treatment here? Albendazole. For the Tenia solium to albendazole with symptomatic management of CNS, because Tenia solium can actually cause neurocysticercosis. However, Tenia saginatum does not cause that. All right, so this is a fact I think all of us still remember. Do you get the gist around diarrhea? Or some people are even already using toilets. So just look at it simply. If I ask all of us now that, okay, pick a sheet of paper and now write the organism, just at the front, just put, if I would just be like, okay, you see travel history, what are the two organisms that will be coming to your mind? So you just quickly put this and this. So how will you separate them? Say, I will check for this and this. Very easy, this thing. Don't give yourself too much headache, because the stuff plenty. You don't want to be overthinking on them. So these are the two electrolytes. So primarily sodium and potassium. So this is stool osmotic gap. This is how you calculate it. I remember when I was doing my housemanship, so I had one SR that was a very wonderful man. Very, very wonderful man. So Dr. Shitu, he should be in Bowen University Teaching Hospital. All right, so I remember then that he was the one doing most of this calculation then. So you just pick and just be like, yeah, calculate this stool osmotic gap. So those times will be just be like, you like calculation a lot, but at least we had an idea of what medicine was all about, even though we didn't understand what he was doing, but he was always ready to teach because he understood the nitty-gritty of all those stuffs. So he was ready to really teach a lot. So he was the one who always calculating this thing then. So stool osmotic gap is 290 minus 2 multiplied by 2 sodium, 2 potassium. So if the question gives you 2 sodium, 2 potassium, so you just look at it. If it's less than 50, what will you be thinking about? Osmotic or secretory?
Secretary.
So if it's more than exactly, so if it's more than 100, you'll be thinking towards osmotic. So we are okay. Exactly, we are okay. All right, so look at this key fact. Cryptosporidium isospora species are associated with chronic diarrhea in patients with HIV. So it shows that in immunocompromised patients with HIV, like HIV, if at all they have diarrhea, this is also one of the these are the one of the organisms you can be thinking about. If you are dealing with transplant patients, you'll be thinking about something like CMV colitis. So now relax. We've looked at all manner of infectious causes of this. So now let's look at the way they classify. They have one broad way of looking at diarrhea that is very awesome, very good, very, very okay. One of them, but for the exam, you just want to look at them simply. So don't over classify. So in your head, you are just like acute diarrhea, chronic diarrhea. So what is the acute one? Less than 2 weeks. What is the chronic one? Greater than 4 weeks. Relax. So relax. Now, if you are dealing with acute diarrhea, less than 2 weeks, so look at what you take into the exam. Usually infectious and self-limited. For all you care, the patient may not need anything from you. Just say, for how long have you been having this? Just for like 5 days. If it's not bloody, then you don't need to. And it's not persistent. Persistence is between 2 to 4 weeks. Chronic is more than 4 weeks. So look at it like this. You look at it like this. I want you to get the gist. So when you are looking at those questions, it will now make sense. It doesn't mean that if you give me 15 questions on diarrhea now, I will get the whole 15. That's a lie. But just for you to have 1 or 2 points. Some questions you don't need to even get them right. But just for you to have an idea. Because those questions are set by like specialists, the what do you call them? Authority in the field. So you don't need to get all of them, but for you to have an idea, so you learn from them. So don't be too hard on yourself. That compulsion, when I see, I must just get it. If you don't now get it, you now be looking down on yourself and think that the exam is not meant for you. It's a lie. Who told you those that passed, they were getting everything right? Some people were even going into the examination all by faith, and you ask them, are you sure you've passed? And they say, I just know. How do you know? You just say by faith. By faith. So just relax. What they will set it. So that's why you just need to think simply, because it doesn't mean that when you now start thinking a complex way, your probability of passing is very high. It's a lie. It reduces, because what you are supposed to think simply about, you now be overthinking about them. So just put your mind at rest. You see? So less than 2 weeks. So 2 to 4 weeks, then greater than 4 weeks. So this is persistent, this is acute, this is chronic. All right, you are like, Festus, why are you writing this? Okay, let me show you. You read a question and it's falling under less than 2 weeks. This is acute diarrhea, usually infectious and self-limited. The next one here. So common causes of pediatric diarrhea: rotavirus, Norwalk, enterovirus infection. So these guys. For chronic now, you now read the question. They say this patient has been having diarrhea for maybe 4 weeks, 4-5 weeks. You now say this is chronic. So if this is chronic, let us give it a name. Don't mind me. So there is a singer. We call her name Simi. I think there is a singer called Simi now, or Simi. I think it's Simi. I think it's Simi now. Simi. Yeah. So that may help. Just have these 4 categories of this thing to actually be thinking about basically. Am I dealing with secretory? Am I dealing with inflammatory? Am I dealing with malabsorption? Am I dealing with increased motility? If that helps. Once you see greater than 4 weeks in the exam, just think towards these 4 guys. Is it secretory? So you will now go back to that question and I'll be checking for what gives it out. That, okay, for carcinoid, am I seeing something that has to do with maybe flushing, blah, 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 this one, that one? Whether is there carcinoid? Are they saying that it's T-colored diarrhea of VIP? OMA. So, secretory. Inflammatory bowel disease, or irritable bowel disease, rather, giardiasis, the stool will be floating on their then amoebic dysentery. So, for the malabsorption, you check the question, you see something related to malabsorption there. So it will give it out. Then for the increased motility, irritable bowel syndrome. So inflammatory bowel disease, irritable bowel syndrome. Sorry, I always mix them up. So please don't be annoyed with me. All right. So that's just by the way anyway. So Simi, maybe that will help. If at all we are giving something like, just from the duration. That's why I underline this, because it just brings you closer to these guys. So I'm not solving this question, but just for you to have an idea of the way it comes. So look at this now. You just come here, you're like, 24-year-old woman comes to the office due to 6 weeks history of abdominal cramp, loose stool, and bloating. Abdominal cramp, loose stool. This woman has been shitting for 6 weeks. It be like, this chronic diarrhea. So am I dealing with secretory, inflammatory, malabsorption, or increased motility? Just be thinking towards those 4 categories. So you now be checking the question. Foul, smelling stool each day, night. He has lost 2.5 kg. The patient has had no fever, vomiting, blood in the stool. She has no prior medical deeds. The patient works in a daycare center and has not traveled recently. So what do you think they are trying to rule out here? Has not traveled recently.
Entamoeba histolytica or E. coli.
Okay. All right. So that makes sense. Okay. So you actually wanted to just say that, what do you call his name? E. coli, because the question has already said there is no blood in this too. So temperature is 37.1, blah blah. Abdomen is soft with active bowel sound and mild distension. There is no tenderness. Remainder of the examination shows no abnormality. So which of the following is the most appropriate next step? The most appropriate next step is just for you to be like, what is really causing this, which we are going to go through now. All right. So, but these are what you are thinking. Am I dealing with secretory? If it's secretory, you will have seen something related to secretory in the question. If it's inflammatory, you may see something related to inflammatory in the question. If it's malabsorption, you will see something related to it. If it's increased motility, you will see something. There is a way the increased motility, like that irritable bowel syndrome, the way it comes, I will show you. So that's just how the question here will come. So you already have an idea, differentials. You call them different. You can just be writing and be listing. So let me say it's during word round. I just say that, okay, this patient has been having diarrhea for 5 weeks now. Dr. Ajanle Koko is there, yeah, pursue this question for us. Now I'll be like, what are your differentials? Maybe we are dealing with this. This could also be this. It could also be this. Is this patient having this? Is this patient having this? This may even be during morbidity and mortality. And now be like, oh yeah, talk about what is going on here. Or what do you think? So you rehearse, and it's when you rehearse them, they actually become parts of someone. So if someone does not rehearse, someone will just forget them. All right, so that's just by the way. So now we have an idea of how question on chronic diarrhea will come. So let's look at the diagnosis. Now, this is the diagnosis now. For the acute diarrhea, if it's less than, they don't say what's the best next step. So you don't do anything unless the patient has high fever, is bloody, or the diarrhea is what do you call it, lasting for more than 4 to 5 days. So that's when you be like, let's check. So because usually they resolve within few days. So some people just, once they are becoming persistent, you just start checking what is going on. So you don't do anything for acute. So if you check the question and the question is saying the patient has been having it for like 10 days, what do you want to do? Don't do anything unless the patient is having fever, is bloody, and the likes. What about the chronic diarrhea? So if for the chronic diarrhea, you need to do something because you have simi to think about, which you don't know which one is which. So secretory. So what is that thing we even mentioned so far about the secretory that can give us this is secretory, who remembers? What is the name of that thing?
The
Osmotic gap. You want
yes,
to
less
see,
than 50.
you're already mutating the name small. So it's fine. So that's fine. So secretory. Just see that just check for these two osmotic gap. So that makes sense. So that's very fine. So for you to now go for carcinoid, IPoma, I think I mentioned one or two things about them. So what can give them out? So you can see them in the question and the like. So you'll be thinking towards bile acid diarrhea if you are seeing something because bile acid is supposed to be reabsorbed at the terminal ileum. If they've done recession of the terminal ileum, so bile acid will not be reabsorbed. The patient will not have bile acid diarrhea and a number of stuff. All right, so carcinoid tumor, so maybe related to ileum or maybe related to the appendix, related to something. So that's that. FIP Homer 2. So stool analysis is the next thing. So stool analysis. In the stool analysis, you check for this leukocyte. You check for culture. You check for Clostridiodis deficit. Can you see? You check for over parasite. So that's what you are doing under the stool analysis. I don't know how we can put it. Maybe maybe you can call it, maybe I don't know how to put it, but I'm thinking towards something that you can shall remember. Parasite, leukocyte, what do you call it? The parasite, so leukocyte, culture, Clostridiodis deficit, toxin. So so these are the parasite, culture, leukocyte, and the like. So these are all you check for. That's the reason why if you check this question, I was trying to use to demonstrate something for you there. So immediately you check this and you are like, this is actually chronic. They now ask you here and be like, which of the following is the most appropriate next step in the management of this patient? I actually feel that this should be more of what do you call it, stool culture, for you to have an idea of whatsoever that is actually wrong with the patient. Do you get me? The infectious. But antigen is also one of the things they test for anyways. All right, the same thing for another question here. So this is just this is another one. So if you check it, this patient has been having it for like 5 weeks, and as the patient condition is most likely to say with which of the following. So you just check, your duty is just to check the question and now check around that simi and be like, what am I? Is it secretory? Is it inflammatory? Is it malabsorption? Is it increased motility? All right, so you check the question, whichever one that is where the question is tilting to, you'll be able to have an idea, be like, okay, this is tilting more towards this, and that's what you check and makes the option to pick. All right, so that's just by the way anyways. So when we meet next time, we'll be solving those questions by yourself. So you now put everything into practice. All right, so what about the treatment? So acute, you don't investigate unless the patient is having fever, his blood is becoming persistent. So even the treatment, just give the patient oral rehydration. That's what they will test. Antibiotic is not indicated except you are dealing with Clostridium difficile infection. All right, what about the chronic diarrhea? Whatsoever that is causing it is what you address. So diarrhea after injection of egg, raw egg or dairy, or is related to reptile, salmonella, and that's all. Let me give us 20 minutes break. Happy? We need the break. All right, so go and rest for 20 minutes. So we meet just 20 minutes after this time. According to my screen, 6:15 we meet again. So this is the malabsorption, celiac disease. So celiac disease is the first one we'll be looking at here. So what do you want to take into the exam for the celiac disease? Sorry. So basically, you have this background knowledge of the celiac disease. You know, it's definitely due to gluten hypersensitivity. All right. So I want you to pay attention to it. I know you know celiac disease, so I'm not actually going to be parabolating around the way the celiac disease presents, but what they are most likely going to be testing. All right. So, you know, you will see the mucosal inflammation, villus atrophy, crypt hyperplasia. For those that are used to us, I have explained it several times. Why do you have the crypt hyperplasia? In the crypt of Libacon, that is where God actually hide those more or less like the stem cells. So anytime there is a lesion that is affecting the mucosa, whatsoever that is in the crypt of Libacon will come out to replace them. So you will have crypt of Libacon hyperplasia, so that they will be able to replace those damaged mucosa endothelial cells. Mucosa cells rather. So that's epithelial cells. So that's what you have them. So that's that. Villus atrophy, crypt hyperplasia, then mucosal inflammation. We also have some extra intestinal manifestation that they can have. One of them is dermatitis herpetiformis. Basically, then the others, autoimmune disease of the thyroid gland, liver, type 1DM, just something related to autoimmune disease again. So that's what you have. So how am I going to know that this question is all about celiac disease in the exam? So you are most likely going to see something related to mucosa in the question, that the mucosa is actually having injury, so the patient cannot really absorb food very well. So you will see something later. So you can see the patient having diarrhea and the likes. So the next thing you are most likely going to see in question that will give it out are these two guys. Dermatitis herpetiformis, you will see them say that the patient is now having one skin lesion around the elbow around the buttocks, around this, around that. So once you see this dermatitis herpetiformis, you'll be like, this diarrhea that this patient is having is most likely related to celiac disease. Or you see microcytic anemia, because iron is supposed to be absorbed by the duodenum. So if at all anything affects the duodenum, iron absorption is going to be impaired. So the patient can have microcytic anemia. Can you see diarrhea with microcytic anemia? Likely you are dealing with celiac disease. Very easy and straightforward. So there is now a test they are going to be giving in the exam that will help out. Because when I'm seeing diarrhea and I'm seeing maybe malabsorption and the likes, so in your mind you'll be like, maybe I'm even dealing with pancreatic insufficiency, so the pancreatic juice cannot be produced, or because the pancreas is having issue, so that's why the patient is having the diarrhea. So for all you care, you may even be dealing with SIBO, small intestinal bacterial overgrowth. What is the small intestinal bacterial overgrowth? This is the small intestine. The bacteria will now coat it. Normally, we are supposed to have bacteria in our small intestine, but God is so wonderful. What God did is to regulate it so that they do not overgrow. The way God regulates it is through the acid that is produced and the likes, then through the peristalsis that occurs. So they move those bacteria down. So with the food. So if at all anything affects the movement of the peristalsis, those bacteria will be stasis and there can be overgrowth. So or if at all anything influence or changes the acid produced, so if the acid is not produced, maybe you place the patient on PPI for a very long time, the patient can develop SIBO. So because nothing to regulate, acid should kill. So nothing to regulate to really limit their multiplication. All right. So if those bacteria coat the small intestine like this, think about it. Absorption also will not really occur. So the patient may still even present like the celiac disease, though all these dermatitis herpetiformis will not be there. So in the question. So when you see diarrhea, you are not sure which one is which. There's now a test, the question we mentioned. You call it D-Silos test. So D-Silos test actually gives you an impression about the integrity of the mucosa. So what is D-Silos? D-Silos is just a very simple sugar that when you give it to the patient swallow it, it's going to be absorbed passively. So it doesn't need one channel for it to be absorbed. So it's just going to be absorbed. It's going to be absorbed passively, basically. So its absorption is only dependent on the integrity of the mucosa. So if the mucosa is good, it will be absorbed. If the mucosa is bad, it won't be absorbed. So if the mucosa is good and is absorbed, you will see it in the urine. So you will see it there. So when you give this patient, I think they normally give them 25 grams of the D-Silos to drink. When they drink it, so if the next thing we realize is that it's not absorbed. So when you check the urine, it's either you find a very low level of D-Silos in the urine or you don't even see anything there. So you say D-Silos test is positive. Now, immediately we see that diarrhea positive D-Silos test, we are shouting mucosa injury, mucosa injury, mucosa injury. So what are our differentials? Maybe we are dealing with celiac disease. Maybe we are dealing with Whipple's disease. Maybe we are dealing with small intestinal bacterial overgrowth. So what we do next is now to give the patient antibiotic. So if you give the patient antibiotic and after a while you now repeat the test and the test is now negative, so most likely you are now seeing the D-Silos in the urine. So you are most likely dealing with SIBO because you show that antibiotic has killed the excessive bacteria and has made the intestinal integrity to be very good. So your diagnosis is going to be SIBO. So SIBO D-Silos test is going to improve with antibiotic like rifaximin. However, if the question says they give the patient antibiotic and still they do not really see improvement, then you are not dealing with SIBO. So you are not dealing with intestinal mucosal pathology like Whipple. You are most likely dealing with celiac disease. Very easy and straightforward. So if right from the beginning without antibiotic or anything, they do it, and you realize that the D-xylose is actually absorbed the way it should. So the test is negative. Then whatsoever you are thinking about has nothing to do with mucosa. So you give the patient D-xylose to drink and it's absorbed. Then there is nothing wrong with the mucosa. You'll be thinking towards pancreatic insufficiency. Patient having diarrhea, they do the D-xylose test and it's just normal. Then do not think about anything mucosa. Mucosa is good. For it to be absorbed, it's good. So that's about the D-xylose test, palaver in the exam. So how do we diagnose celiac disease? So now in the exam now, it'll be like, what will be the most tested concept under the diagnosis is serologic testing. What are you testing here? You are testing for this anti-tissue transglutaminase IgA. Anti-tissue transglutaminase IgA. This is the answer. Or endomysia IgA antibodies. Most of those antibodies are actually, all those antibodies are actually IgA. Unless the question says the patient is IgA deficient, that is when you go for IgG. So if the patient is not IgA deficient and the question does not specifically mention the fact that the patient is IgA deficient, so you are going for IgA. But if the patient is IgA deficient, so the question mentioned that the patient is IgA deficient, you go for IgG. Version of these guys. Anti-tissue transglutaminase IgG will be your answer. All right. So what is the gold standard to confirm the diagnosis? You've seen the antibody and the likes. Biopsy, duodenal biopsy. What will you now see on the biopsy? Phyllos, atrophy. Can you see crypt hyperplasia and mucosa inflammation? That's what you will see. Okay. So what about the management? The management they are going to test in the exam is this one. This is the one they will test. This is the main management. That's why they put it as cornerstone of treatment and result in symptom resolution and mucosa healing. What is that? Lifelong adherence to gluten-free diet. This is the answer. Just say avoid gluten in the diet. Avoid it. Say, doctor, is there no any other thing I can take? Mama, avoid gluten in your diet. You will be fine. Just stay out of it. You will be fine. It will improve by itself. So this is what they will test. So rehearse it. These words they will test. This one, this statement. That's the answer. So when they give the question, like you know. Like you just think, just avoid the gluten. Just check through the options. You will see big grammar and the likes. No, it's not that one. Just avoid gluten in the diet. And I love something about abroad. The thing is that sometimes you take your child to the hospital. You are like, give this. They should give this. It doesn't meet any criteria. They will just tell you that go and be breastfeeding your child. You now look like, I think you should admit and give oxygen, give antibiotic, give this. That's not it. So this patient will be sent home now. The patient will now be shouting and though if the patient has been having diarrhea, is now becoming dehydrated and all manner of stuff, they actually need to do something. But this is the main thing they will test in the exam. So what is the next thing they are most likely going to test here? Because the patient is having issue with respect to the duodenum. So the patient is going to have iron deficiency, folic acid deficiency, vitamin D, and 12. So the absorption is not really going to, is going to be impaired. All right. So that's just by the way. But never forget this iron. That's the main thing here. Please never forget the iron. So please let's watch out. All right. Why vitamin B12? Why the vitamin B12 and light? Because most especially by vitamin B12, because the patient can also have some other autoimmune condition, so which can even revolve around the stomach. So that's just by the way. So and that's that. Other etiologies of malabsorption. So we are done with the celiac disease. All right. So please never forget, I've mentioned it. Lifelong adherence to gluten-free diet. Check all the questions. That's what they are testing for the management. Serology testing. Can you see for this antibody? The main one It's anti-tissue transglutaminase IgA antibody until proven otherwise. Then dermatitis epitiformis in the question. Then they will also make reference to these silos. What about, I know Dr. Babali, oh, sorry, this is not. So the treatment for the dermatitis epitiformis, Dapsone. If the patient has it. So you can see all these questions. Your duty is to come and solve all of them. You see, the one for, can you see? Can you see? You solve all of them. You read them, you solve them. So this is the D-silos test they are putting here. So your duty is just to analyze the question and be like, okay, what's happening to the D-silos here? The answer should be this or that. So you just be like, okay, this makes sense. If you look here, the test is repeated after a 2-week course of rifaximin, but the urinary concentration of these silos remain the same. So you show that you are not dealing with SIBO. You are not dealing with SIBO or WIPO. So you are most likely dealing with something like celiac disease. So what about the WIPO? WIPO disease. With respect to WIPO, basically something we give it out. One of them is this periodic acid scale test. So this is someone that is having chronic diarrhea, nutritional malabsorption, arthritis, lymphadenopathy, cardiac issue, and the likes. And now see, they just trace the question. Now see this periodic acid scale test, and they say it's positive. Your answer is WIPO until proven otherwise. Short bowel syndrome. At least you already have an idea of how this look when we were looking at the bariatric surgery. So this is small intestinal bacteria overgrowth. You also have an idea. So you're just anything that can make those bacteria to grow a lot. So that will cause it. A very good example is abnormal motility. Motility moves those bacteria down. So if I thought there is stasis and the like, they overgrow. Abnormal anatomy after abdominal surgery. So it's also going to reduce the motility. The same thing for GI cancer. All right. Systemic disease like diabetes can also cause it. So please never forget this at all, and some other causes that I've mentioned before. Omeprazole. The patient is on prolonged use of omeprazole and the likes can also cause it, because acid will not be produced to even reduce the proliferation of those bacteria. So they overproliferate. All right. The initial test specific for celiac disease in the exam, United States Medical Licensing Examination Step 2, is what? IgA anti-glutaminase antibody or anti-endomysia antibodies. This is what they will test. What is the gold standard test you want to do? Intestinal biopsy. What are you even biopsying? Duodenum. So what will you see? Crypthyperplasia, Philos atrophy. You can also intraepithelial lymphocyte. All right. So that's just by the way. For the SIBO, when you do the biopsy, it's actually definitive. What is the treatment? I just hope they are still. So what is the treatment for the SIBO? It's actually antibiotic, but I'm just saying that because I don't think they are still talking about the SIBO here anyways. All right, so that's just by the way. If you see dermatitis epitiformis under the celiac disease, you use Dapsone. So that's that. I will just talk about the carbohydrate mal, and I think I will allow us to go and rest. So this carbohydrate maldigestion, you have the lactase deficiency. Lactase deficiency. Where do you even see lactase? At the tip of the villi. Can you see at the tip of the villi? They should be there. That's where the lactase should be. All right. So that's lactase. Lactase. So it should be at the tip of the villi. So it may not be there. It may not be there. Usually with aging, so the quantity that is there actually reduces. So the patient can be lactase deficient. A patient that is elderly or older can naturally become lactase deficiency. It doesn't mean that the patient does not have lactase ab initio. It's just that the quantity has reduced significantly because of aging. Secondary, something must have affected the villi, maybe diarrhea that has chopped off the villi, clear off the villi, celiac disease, clearing of the villi. The patient can become lactase deficient. All right, so that's just by the way. So the story should actually give it out. So there is something that will help to know that this question is lactase deficiency until proven otherwise, and that thing is them talk about the fact that the patient becomes symptomatic anytime the patient takes dairy products. So anytime the patient takes dairy product, maybe milk and the likes, so the patient is not digesting dairy products. That's what it means. So those dairy products will now be converted to short chain fatty acid. So fatty acid is acid, so they generate a lot of hydrogen ion. All right, so when you check them for hydrogen breath test, the hydrogen in their breath will now be very, very high. Very, very high. So that's for lactase deficiency. So the question we always talk about this hydrogen breath test. So you just give the patient what do you call it? So you just give the patient this maybe lactose to drink, and you check that, you realize that the hydrogen in their breath is quite high. So how do you want to treat them? Just avoid dairy product. That's the basic thing. And you can give them oral lactase enzyme to drink. All right. Sucrase, maltase, fructose intolerant. I won't bother us on this. So let's look at carcinoid briefly. This might even be my last stuff. So carcinoid syndrome. So with respect to carcinoid, something we give it out for you to know, this is carcinoid, carcinoid. You just see diarrhea. This patient is having diarrhea, and the question we talk about something related to the serotonin in the patient. So like flushing of their face and wheezing. So once you see that, be like, this is carcinoid until proven otherwise. Now, this is how you look at carcinoid in the exam. You look at it a non-metastatic carcinoid, also a metastatic carcinoid. Where does carcinoid even arise from? The ileum, the appendix. What do they produce? They produce serotonin. That's what the those carcinoid tumors will actually produce. So there is what we call first pass metabolism. So when this serotonin passes through the liver, majority of them will be cleared. They will be cleared. So if at all the little one that shall find their way out of the liver, so they can also be cleared by what do we call it? This monoamine oxidase. So they can actually break them down. So that's for this serotonin. So in the exam, immediately you check the question and you start seeing manifestation of excessive production of serotonin affecting the heart. It shows that the liver cannot clear them. So what can make the liver not to be able to clear serotonin? Likely the tumor has metastasized to the liver. When they metastasize to the liver will be fighting but cannot destroy itself. As a result, the level of serotonin is going to be very high, that will be going to the heart. So when it gets to the heart, what is it going to do? So we'll be looking at that. So it's going to cause some valvular lesion. So it's going to cause some valvular lesion that you just want to put at the back of your mind. So something related to tricuspid, a very good example, tricuspid regurg, then pulmonic valvular stenosis. So if you look at it, like once you start seeing something related to the heart in a patient that is having diarrhea flushing, so it shows that that tumor has metastasized to the liver. So in the exam, you want to differentiate: am I dealing with a metastatic carcinoid tumor or non-metastatic carcinoid tumor? It is the metastatic carcinoid tumor that will produce what we call carcinoid syndrome. So non-metastatic carcinoid tumor will not produce carcinoid syndrome. So carcinoid syndrome will involve what do you call it? A lot of serotonin push coming out, affecting the systemic, the heart, and the likes. So if you check the question and you are seeing the heart is affected, you are the most likely dealing with carcinoid syndrome. So if you check the question, you realize that the heart is not affected, you are most likely just dealing with carcinoid tumor. So in syndrome, the heart is affected. So the tumor has has metastasized to the liver from the appendix or the terminal ileum. So however, from the liver, so it can actually and from the liver it can go to the serotonin that is produced can easily go to the heart and other part of the body, and that's that. So you don't have right heart manifestation because the monoaminosidase in the lung will break down those serotonin. So please watch out for that. So now, how are you going to diagnose? So you just see something related to serotonin. So high urine level of serotonin metabolite like 5-HIAA, hydroxyindole acetic acid. So that's the best. Just the HIAA, 5-HIAA will be very high. So you can immediately diagnose. The next thing is just go and check what's the level of metastasis, the degree of it. So you can go and do the CT scan. So how do you want to treat? If the patient is symptomatic or trotyde, so if the tumor is resectable, you do surgery. If it's not resectable, you don't need to take the patient through the stress of surgery. All right. So serotonin is produced from where? Who remembers the amino acid that forms serotonin? Tryptophan, right?
Yeah.
Exactly. So tryptophan. All right. So if this tryptophan is also important in producing a particular vitamin. What's the name?
Niacin.
Niacin. So apart from niacin, which other vitamin do you need? Do you need in production of niacin? Which other vitamins do you need in the production of niacin?
B1 and B6.
Yeah.
B2.
B2 and B times 3 is 6. So
B2 and B6.
3,
Two,
6,
6.
20.
For those that are all right,
Two and
so
six.
2 times 3 is equal to 6. So you need a 6. You need 2 to produce the niacin. So together with the tryptophan. So in this patient now, most of the tryptophan are converted to serotonin. So what do you think what do you think will happen to the level of niacin that will be in the system?
Will be reduced.
It will reduce. It's going to reduce. Seriously. So it's going to reduce. So it has reduced. So the patient will become niacin deficient. So how will the patient now present? The patient can present with what we call pellagra. So pellagra. So in pellagra now, you can talk about 4 Ds: diarrhea, dementia, dermatitis, and death. All right. For all you care, you are just in the system, just see this patient that is having dementia. Just see the patient is just having dementia. You are just like, it's old age. It's old age. It's old age. So when they take the history further, they now see diarrhea. Immediately, you check the patient's skin. You are seeing dermatitis. The next thing, you say, until proven otherwise, most likely, I'm dealing with something related to carcinoid or vitamin B3. So something like that. So you just look at it and don't forget this dementia. So dermatitis. If I thought they asked that which of the following can the patient develop or something, the answer will be dementia. Dermatitis, the patient may even die. So that's how you look at this area very, very well. So you see that it's quite easier than you think or than you could ever imagine. So what is the treatment if the patient is symptomatic? So octreotide, if this tumor is resectable, you do surgery. So basically, so let me just show you how the thing may come so that you see that you have a lot of questions to solve on it. 1, 2, 3, 4, 5, 6, 7. You solve 7 questions on this. You now say that they give a question on carcinoid, you don't know. That would be a lie. And the question is the same. The way all of them will come. 52-year-old woman comes to the physician with symptoms of bounding sensation in her neck and lower extremity edema. Now say she has lost weight recently. Other medical problems include migraine disorder, chronic diarrhea, and severe post-menopausal flush. You're having flushing. The patient has a 30-year smoking history. Physical examination shows poor oral hygiene. And a 2/6 murmur is hard at the lower sternal border that increases with inspiration. So can you see? So 2/6 murmur hard at the lower sternal border that increases with inspiration. So which murmur do you think? You are seeing diarrhea, you are seeing flushing, you are now seeing murmur. So what kind of murmur do you think this is most likely going to be? Anyone? You start with letter H.
Holosystolic.
Holosystolic murmur. So that's holosystolic murmur. Now say echo shows retracted and immobile tricuspid valve leaflet with poor cohabitation and severe tricuspid regurgitation. Insufficiency. Which of the following is the most likely diagnosis? So you can see something related to tricuspid valve here. So you'll be thinking it was carcinoid syndrome. So carcinoid syndrome incorporates cardiac manifestation and the like. So why the carcinoid tumor does not? So you talk about syndrome when the tumor has metastasized to the liver. So the liver that should be breaking it down is not the one producing the serotonin. And all of them will look alike. You just see them talk about flushing, wheezing, diarrhea, flushing, wheezing. Maybe you can call it diarrhea, flushing, wheezing question. Carcinoid until proven otherwise. All right. So that's going to be where I'm going to stop for now. So thank you so much, everyone.